I'm glad we didn't tire you out too much, and welcome to all of the people who are joining us virtually, but we'll have a good group here. Just wanted to highlight the fact, if you have a chance to go, Leonard Wabasha mentioned this Hokokata Tea, the lodge at the camp center gives a view of the history of the Mdewakanton, Shakopee, Mdewakanton, and Sioux community, which is, you know, it's about a mile from here. You know, and it'll be hard during the maybe Thursday before we leave. You might be able to get over there. It gives a little different picture than what you get of this tribe from inside the casino. It's a little bit more sacred space, and so I encourage you to stop over there. But let's first get to the important things, the meeting business that we have to do. I asked for a moval to approve the minutes of our last meeting. Magda, motions at a second. Belinda, any comments on the minutes? All right, hearing none. All in favor of approving the minutes, say aye.
Aye.
All opposed, same sign. Minutes are approved. All right, yesterday was quite an eventful day and lots of important information and pertinent stories. So I'm just curious, just in the time we have here, you know, the next 15 minutes or so, I'd like to just hear from you about, from all of what we heard yesterday, what touched your heart? What piqued your interest? What stoked your passion? What stimulated your imagination? What energized your potential for action? And what questions still need to be asked? Joy.
Why are we separating moms and babies just because a mom is incarcerated? And how do we stop doing this? Because we know how wrong that is for that baby and for that mom. So can we make this a priority from this committee?
Belinda.
Good morning, Belinda Pettiford. I think several things touched my heart, but I especially the two young ladies that participated, I think it was Autumn and Lanice, and sharing their story and being willing to be so vulnerable in front of us. It made me want to see, are we doing enough with our recommendations? Are we going deep enough with them? And I know you gave us that as a charge last night, not to go mild, but to spice it up some and definitely move forward. But I also was struck by the different levels of trust of the Indian Health Service. And depending on who you ask and their relationship with them, and wonder, are we, I do think we've done everything we can in many respects to try to get them at the table, but are we being strong enough on our recommendations? Should we just be asking for more resources, or should we really be looking at that system with our recommendations? Because the system obviously is flawed. When you hear someone that has the opportunity to utilize the Indian Health Service and they say they wouldn't even send their four-legged pet there, there's something wrong with that system that is deeply ingrained. And I don't know if our recommendations have gotten to that yet. So I think we need to spend some more time and go deeper with those.
Sharonda.
Sharonda Thompson here. For me, it was the disrespect of their beliefs and traditions in many facets, the hospital, the prison, the lack of respect for their beliefs and their traditions is the words, I'm at a loss of words for it, because it's horrible. It's horrific that we're not taking that into consideration. This is a part of them, and we're stripping that away from them in any opportunity that we can. And I think that really needs to be rectified.
Thank you. Kate, looks like you want to say something. Yeah, it's pop up, but whenever you would like.
There's so many things that I was struck by and touched by. One thing I know that, last meeting we had this virtual, and I've been thinking a lot about how different it felt and how much more I could absorb and appreciate, when we were in person. And then it's a little bit about apples to oranges because it's different content, but I think there's really tremendous, I took pages and pages of notes, which I never did on the video, but so I'm kind of relatively new to the development of the recommendations and that sort of thing. So there's just a bunch of things that jumped out, but at me, but I think systems is something that Linda brought up, and we've got systems in place that aren't working. And I just keep going back to that, that there's been efforts to change the people to fit the system instead of changing the system to fit the people. So I hope our recommendations can really highlight that the systems need to change to fit the people. The issue of respect of traditions is exceedingly important. And I will add that perhaps some of that comes from a lack of understanding, lack of knowledge. I put myself 2 feet in that, of not kind of really having depth of knowledge of what what those traditions are and how important they are. So I think we need to get more knowledge out there among the not only the clinical care providers, but the broader public health nationally. I think we've got Minnesota public health providers who are deep into this, but in North Carolina they're not. I'm telling you. Sorry, Belinda, but yeah, and we have for the East Coast we have a population is probably the highest. I understand it's the highest population of Indigenous and Native people on the East Coast, and we're not. I'm not, and many of my colleagues aren't. So I'll stop there, but lots more ideas.
Thank you. Other thoughts that touched your heart, piqued your interest, stoked your passion, stimulated your imagination? Phyllis.
I think for me, I'm sorry, I'm Phyllis Sharps, a nurse, a perinatal nurse. Who spent my career caring for underserved African-American women in urban settings. And as I listened to the stories here, the pain and the hurt was very real. And it's not unlike what I hear from the women I care for, and the level of distrust of systems that are supposed to help women that further victimize women and stereotype, and I don't think always give the care that they're entitled to, the best care, the best practices. And as I think about the recommendations, I think we need to be bold, but the other thing that kept running to my mind is how do we make sure, or how do we build in accountability? Because we don't want another set, I'm sure, I'm new to the committee, so it's my first meeting, but I'm sure you don't want a set of recommendations that people read and nod heads, and then they get put away on a shelf. And 4 or 5 years from now, we'll be back considering some of these same things. So I think we need to also think about a mechanism and who else outside of federal agencies and folks that are represented here needs to hear. Are there other audiences? Are there other mechanisms and ways to get recommendations out? Because if we certainly have it going to communities that are most infected, that's another level of accountability that might be that we might be able to build into the system.
Thank you. Sherry.
Sherry Alderman from Oregon. I'm a developmental behavioral pediatrician with infant mental health interests and expertise. Again, I agree with what everyone has said, and a tremendous number of spotlighted issues and questions came up for me as well throughout the whole day. I'm very grateful for. what I hear is that it's important that the dominant culture hand over the power for Indigenous peoples to create their own system and provide supports that would enable them to actualize that system that they choose. The question that I have is to refer to this group of people that we're talking about as Indigenous people is a dominant culture bundling of a very diverse group of people. And I wonder, and that diversity also includes very significant disparities across that group of people. And so what I wonder is how can our recommendations not only hand over the power for Indigenous peoples to create a system that works for them, but also cultivates an atmosphere that they create that brings all of the voices, the diverse voices that they have within the Indigenous people to be able to address the disparities and bring all of the people that we're talking about to a level of empowerment that is best for their families, the communities, and the babies.
Thank you. Great.
Marie Ramos, family medicine physician. Many things struck me. I think two additional thoughts in addition to my colleagues that I'm considering for today and into tomorrow is what are current systems in place that are working to advance and promote health equity that we already have modeled for us, maybe in other areas, whether that be in commercial payer systems or in certain Medicaid spaces that we can help to translate into this space in particular. The second area is the concept of workforce and thinking of creative ways to co-create solutions with our priority communities, and particularly with our Indigenous brothers and sisters. So how can we elevate those recommendations to encourage and instigate alternative ways of promoting workforce? And I think we have several examples from yesterday that can help us with that.
Great, thank you. Magda.
Good morning, Magda Peck, MP3 Health, University of Nebraska Medical Center, City Match, and MCH Champion. Glad to be here. First, I want to acknowledge the power of story. Story comes before data. Stories are data. But we've separated the heart from the numbers. And when we do so, we become numb. And so the storification that happened in yesterday's design, the invitation for story, people are eager to tell their stories if they trust that they will be heard. Second, of interest to unlearn and learn anew that Indigenous health is predominantly, in many ways, or equally an urban issue. And that the percentage of folks of Indigenous descent who do not live on reservation, who are living invisibly in America's cities is just, it's an invisible fact. And I think that we need to recognize the urban Indian health issues uniquely and truly open our hearts and listen to what has been inaudible. Third, what can I say about passion? I think that anger is really useful. This is not a time for politeness. And for anyone to have been with us yesterday at a minimum, to not walk out and feel outraged, even if it's new for those of us who are white and privileged. The outrage is something we have to continue to stoke that fire and honor the anger and act. Anything short would be another insult. So it's not so much the passion, it's the absolute appropriate and essential anger to keep fires lit. And last, this is a moment of political will. This is a moment where we have this tiny sliver of attention of Secretary Becerra and HRSA Administrator Carol Johnson. We already have the remarkable ears and hearts and will of our MCHB colleagues. Thank you. And our CDC colleagues. Thank you. But if we're going to change systems and change policy, it has to happen both in communities, but where power resides. And so I just want to acknowledge that we have some things we can do while we have this open window, and to be bold about it. As a start and a final note, there were some remarkable humans who addressed us and welcomed us into their story, who would be fabulous ACIMM members. And I hope that the place to recruit starts here, so that when we meet next again, there is no excuse for not having greater voice and visibility beyond the extraordinary leadership of Dr. Palacios. If we don't change us, how dare we ask for anything else to change? It starts with that little step right here, right now.
Thank you. Janelle?
Thank you, everyone, for everything that has been shared, because it's exactly what I was hoping to hear reflected back today, and that all the stories and comments from yesterday were able to help show the committee just how intense the situation is and how dire the needs are. In a conversation afterwards I had with two wonderful colleagues, Dr. Ramos and Latasha from NICHQ, I would say that my world was turned upside down when they introduced an idea that was right in front of me and that I've lived, but I forget because I live in two worlds. And that is a reframing of these recommendations. If we're to be bold and not be mild, like Secretary Becerra has asked us to be, then I would rename these, instead of recommendations, these are amends. These are restitutions. This is what is owed to us. We're not asking for these things. This is what is ours. We've already prepaid.
Thank you, Janelle. From our ex officios, also, any thoughts, not just the appointed members, anybody else, any other thoughts that you might have?
Good morning. This is Charlene Krollinger, CDC. I just wanted to say we are here, we are present, and we are listening. And we appreciate being invited to the table and given the opportunity to hear Native voices. Those lived experiences yesterday were very impactful for us, and we hope to contribute significantly in the discussions for the amends.
Thank you.
Good morning, and I'm Amanda Cohn, also with CDC. Just ditto to what was just said, but I think the other thing that struck me and we think about is that this is the tip of the iceberg in some ways, right? And I think that this is these stories reflected these lived experiences, but there are so many more. You know, not, I'm hopeful. I think somebody said yesterday that that changes that can be made to amend this population will have benefits for the whole population. And I do see that. And so I'm looking forward to hearing the recommendations and the amendments from the committee. Thank you.
Dr. Warren and Lee.
Thank you. Michael Warren, HRSA Maternal and Child Health Bureau. First of all, thank you all for an incredible day yesterday and for the work that went into organizing this and creating such a powerful agenda, and look forward to today and tomorrow as well. As I was reflecting last night, I always try to think, where have I been implicit or complicit in the system that we have and in the outcomes that we have? And I was thinking about, in particular, the implicit part of that. And during my time in state public health work, I was in a state where there were not large federally recognized tribal communities. And I did not know, it was my own ignorance about urban Indians. And so when I would hear national statistics about disparities, it didn't cross my mind that there was work to do. And so I think about that opportunity lost. And that is frustrating on the one hand, but I think about there is a time to learn and relearn, and this is it. So I appreciate that learning and teaching that we got yesterday. I also want to comment on the power of the story. And I think it's one of the things, one of the many things we've been robbed of during COVID. We figured out a way to meet virtually. We have made do, but the lack of in-person connection, I think, has taken away some of those opportunities to not only hear, because we can hear that virtually, but to see and to feel in the room the palpable pain and sorrow and anger that I think for all of us are so important to feel. So I want to thank you all for bringing us together in this way.
Lee, do you have any thoughts?
Yeah, I have two observations from yesterday that were comments made. One early in the day about when data come out that reveals a problem, many look at the results and say, what's wrong with these people? And I think it is incumbent upon all of us to remember that when we see and hear data, that we have a filter and a lens that we use for addressing those data and how we choose to interpret our reactions to it. And there is an easy leap that we can make to what could they do better for themselves. And I'm not saying that that isn't a question that needs to be addressed, but that needs to be addressed by the individuals who are affected by it and not necessarily by us. And therefore to try to focus on what is the responsibility of whatever chair we're sitting in to address the needs and not filter it through a lens of judgment, a judgment on those individuals. The other, and this is just sort of my take on and my general approach to life, is I tend to look at inconsistencies and say, you know, we're doing it this way, but it doesn't make sense for us to do something different in another place. And one of the points that was raised yesterday afternoon was the fact that we go to these heroic efforts to save these mothers and these babies through the clinical systems that we have in place. And then we release them afterwards into an environment that may be just as destructive as what they were facing before they had their condition. And so when we're making our recommendations, that we're making fulsome recommendations about the life of the individual and not just an individual intervention, because our concern is with the whole person and not just with that particular experience that they're having. So that's my observation. Thank you.
Thank you all for those comments. Just to acknowledge that we do have some people on Zoom that are joining us, NCHS, CMS, the Office of Minority Health. So they are looking at us on the screen as we speak. And I wanted to reflect on or reiterate what Dr. Warren said. I think just having this meeting in this facility, in this place at this time, bringing the stories together from the people, from where they live and where they work is really important. And then just having all of us, as Kate said, around the table, it just changes the character of our interaction. So I really appreciate that. So we're going to move forward into our meeting today. It's also going to be packed, but I want to highlight just two things. You know, I always kind of reflect on the history of things. There's two birthdays today, one among many, but I want to highlight Ivan Pavlov, you know, the Nobel Prize winner for as physiology. He said, while you are experimenting, do not remain content with the surface of things. Don't become a mere recorder of facts, but try to penetrate the mystery of their origins. So I think that's relevant to what we've got. A lot of facts, a lot of data. So let's just not look at it and admire, as was said yesterday, admire those data, but let's look at and penetrate the mystery of those things. And that's what I heard people talking about here. They were getting at the mystery or the pain or the substance of that. The other birthday is Sidney Harris, a journalist. He said, an idealist believes the short run doesn't count. A cynic believes the long run doesn't matter. A realist believes that what is done or left undone in the short run determines the long run. That is our charge today. We are here in this time. I don't care. We have to be a realist and say, all right, how can we make this better in the long run? Which is not going to end with our work tomorrow. It's going to continue. And we need the partnerships. We need the data. We need the passion. We need the support. We need the partnerships. So let us think about that as we move forward. So now I'm going to turn it over to Joanna Bryan, who you heard yesterday, who did the tribal welcome. She's going to update us on what's going on with the Shakopee, Bidwakit, and Sioux community. I realize that if we're here, we should learn a little bit about what they want. And I particularly really wanted to have this meeting at the Shakopee, Bidwakit, and Sioux community because oftentimes when you look at Indigenous folks and American Indians, Alaska Natives, we always look at deficits. And certainly Shakopee, Bidwakit, and Sioux has lots of resilience and lots of positive things going on. And so I wanted to highlight some of those. And we've heard from some of the other presenters, but this would be a good time to do that. So Jan, I turn it over to you.
Thank you. Good morning, everyone. I'll admit, you know, hearing your guys' reflections is super powerful and very encouraging for me, right? I was not able to be here yesterday due to we have our general council component. It's our required meeting for tribal members, and that's where I needed to be yesterday. And again, at some point this afternoon. And I will say, you know, in my spare time last night, I dug up, you know, your charter and I looked at your last set of recommendations, trying to find something that I could make relatable to the SMSC. I think when Ed first asked me to kind of do this review of SMSC, I'm like, wow, like, how am I going to make that relate to the rest of the world outside my little bubble here in Prior Lake, Minnesota, right? So I'm going to share a few things, but the things that I heard this morning were the things that I woke up saying, I hope they're looking at this, right? So I'm going to try and break it up into getting the overview done and then talking about why I think SMSC and what's led to our ability to make those changes and implement some of the programming that obviously lived in your previous recommendations. So for those of you that don't know, obviously SMSC, we have our own healthcare system that we operate. And I think the foundation of recognizing how we're able to do that is our self-governance ability as a sovereign nation and our ability to self-govern our federal funding that comes through us and then is just passed to us through the IHS system. Now, not every community or tribe is able to do that. I know they're trending towards the ability to do that. And I think that that's really crucial in the empowerment of the tribe, the community to improve and govern their own health, right? So we are able to, in the last, I've been working in my role within the health department for the last 18 years. We have very stable leadership within our community. And so the mission of healthcare kind of stays focused. It stays right up there in the front of what our community is trying to do. So we've been able to incorporate a healthcare system that includes all of the good stuff, right? Your primary care, your urgent care, your vision care, your behavioral health services, We do, chiropractic and physical therapy, we kind of put it all in there in that whole person care model. And then we ensure within that system that we have collaboration amongst departments by one unified medical record, right? So information is there and available. Our dental team, when they're treating a diabetic patient, can clearly see what's going on with the diabetes care. Our diabetes educator can look and see, hey, I see you haven't been and gotten your cleaning. Let me help you set that appointment. They can go in and set the appointment, right? And make those connections in care that need to happen. So I think that addresses that whole issue of fragmented healthcare and how that really can impact any individual's health when the system is fragmented. I'm sure you all have had experiences in a healthcare system where you're showing up and you've been referred, and the very first thing is they don't know who you are. Sometimes they don't know why you're there. You're filling out the same paperwork you filled out at the previous place, and you would have thought that, the records were going to be sent over, and you're starting over at ground zero every single time you engage with a new person in your healthcare journey. And I think that can be super disruptive. And again, so I feel like you guys have talked about, right, what really impacts or what can impact an individual's ability to receive medical care. The opportunity, is the care available? Can they get there? Can they get to where they need to get the care from in a reasonable method and in a reasonable amount of time? The environment, where is the care being provided? And then I think barriers, everyone has a unique set of barriers, and you really don't know what those are until you ask. And I think we've learned in even serving our clinics, our services are available for our tribal members, and we also serve what we call our area natives. So natives who are not members of our tribe but live within Scott County have eligibility to get direct care services from our community. And even within those populations, our providers, when they first come on board, we have to explain to them, you may have a well child check on your schedule. Our minimum appointment length is 30 minutes. We want our providers to spend time, but don't be surprised when mom shows up. She's going to have the child on the schedule, and she may have 2 or 3 in tow. So it's not just about treating the one child that's on the schedule, right? It's about having the ability and the flexibility within the healthcare system to treat the family when they're there, when they are in front of you, and making that connection. And that's not really realistic in the way in which our healthcare system runs today, right? Super quick, fast paced. In my opinion, healthcare has become a business, and it's not about the business of taking care of people's health. It's a money revenue generating system. Now, if you guys can fix that, I'd be astounding, right? Like it's a big picture problem. And so again, like I said, I think that there's two pieces that I'd like to share today of why I think that we as a community, using our self-governance capabilities and what that leads us to be able to do with partnerships, and then how important I think that is. I heard some reflections here about empowerment. How do we empower the individuals who need the care? And this will be a contrary statement to, I think, anything I've even ever heard myself. So I'm really surprised that it's rolling around in my head. If as a committee in this particular instance, if you are truly looking for the ability to impact Indigenous women and children, that population is probably your lowest hanging fruit if you really want to make an impact. And there's ways in which to do that. Where are your policies or recommendations guiding for funding to go to? I think that federally recognized tribes have the ability to take and receive that money and implement their own programs to ensure that their communities are healthy, right? Check one off your box. Give them the opportunity to rise to what they need to do and take care of their own people and determine their own policy. I did read several of your recommendations. I think the last 167 pages. I didn't get to page 167, kind of rested in the first 10, 15 pages with the recap. And what struck me, and I've seen it everywhere I've looked before, but I think I was looking at it through a different lens last night. Recommendations, you guys have recommended everything, right? We're recommending doula care, we're recommending alternative options, we're trying to get people there, we're doing all these things. And then somewhere in the paragraph to providing evidence-based care. So you're creating an amazing recommendation, but we're also putting a barrier right into the language of the recommendation. I fully understand the need for evidence-based care and the research, and everyone's favorite word is data. Unless you have personally been in a situation where your healthcare potentially is being impacted because someone doesn't have enough numbers on a piece of paper or something, a checkbox isn't done, it's a very, I would say humbling, but I'm going to change that to devastating place to be. I'd ask you to look through the same lens of any other individual who may not be part of a class who is suffering or having a health disparity. I don't know that they need to prove the need or the outcome for them to get the care that we're talking about here today. I don't know that the same factors apply. You can if they have that ability to go out and get their private insurance, they can go to the doctor, they can do all these things. There doesn't have to be data coming back saying that that's an appropriate use of the money. And I think that's the lens that we're kind of missing here today as well. And here's an example of kind of something we were able to do with those things, right? I mean, under our ability to manage and create our own components, not to say that, you know, we go from where the funding goes to IHS and, you know, IHS kind of, you know, sometimes they put little, and we need to do this, and you need to give us names, and, you know, there's challenges there, but we pretty much are able to create these culturally based programs that we know work within our community. We have a program that we call, it's a care coordination program. We call it Wataya Care. And the navigation concept in and of itself is really showing to help us connect, right? We have services, but we don't have all the services, right? There's always going to be a need for our members to go outside the boundaries of our reservation and plug into a system that can be very challenging. And so what our care provider does, we have a nurse who then ensures that the appointments made, the records are sent over, all of the information, that it's in the hands of the other place that we're referring to. We not only do that, but we also send another copy with the patient. So when they get there and the facility says, oh, we don't have your records, we must have never gotten them. Well, here's another copy. Here's my last lab test. This is why I'm being referred. In certain situations, when we're talking about large issues or very challenging health conditions, we will either send our nurse or our provider. We use PAs and nurse practitioners within our clinic settings. They'll go with them and be that medical person there to help them navigate that care. When you think of a concept of someone getting a challenging diagnosis, we've seen it happen before. You go in and someone's told they have cancer, right? Once you hear the word cancer, I think everything else intuitively shuts off in your mindset. And then they want to rattle off 14 pages of options and treatments and considerations and all these things you need to do. And I don't know that people are hearing that. I assume that would be the same thing, very similar to a mother going in and hearing that there's something wrong, right? There's a challenge with her pregnancy. Natural body response is you first need to, you're going to shut down. You need to process. And so by having that other individual there that not only knows their past history, can understand the diagnosis, take notes, be able to relay that back, help coordinate future care appointments. And I think most importantly, ensure that we're not getting a duplication of services. Like I said, right? When you go from referral to referral. Everybody wants their own lab work and they think they need to use their x-ray machine to get an x-ray of the same thing you just had x-rayed. And I don't know if that always necessarily makes sense. In some cases, maybe so, but I think that duplication of care and that care navigation has been super important within our community. And so that's a good example, right? Now, could I provide statistics and data on that? Yeah, I could go dig and we could make it, we could get it all out and pull it over our system because we have the benefit of having a resource to put those statistics in. But it's not the primary driver. We look at the outcome. If at the end of the year, we can say that we reached a success where we had no incidences or we didn't have any mothers or children passing away from complications, then I would deem that a success for that year. And we would move forward trying to improve and move on other topics that could be impacting that from other ways, right? Because it's not a singular. You guys have demonstrated that already with what I heard you say this morning and kind of everything that I read that I could get my hands on, last night, catching up on everything that you guys have been doing. Another example I think of is what I call kind of the blending of services, right? So when we look at our community, we have a childcare facility that does a lot of the primary childcare from, infants all the way up through school age, and it even goes a little bit past that. But when we went to address, for say, the social and emotional development of our youth, we go to where the children are, right? We go to where the potential to make impact is there. We don't necessarily make them come to us. So by infusing a childcare or a model that called conscious discipline, by training our staff and infusing that staff into the childcare environment, we are able to identify challenges in very, very young children with emotional needs or coping skills or whatever it is, and impact them on a daily basis with consistency, more so than not 5 days a week. That's primarily where they are. And then extending that education into the home, to the parents. And when we say we bring a concept like that on, it's not just the staff at the Playworks facility that we engage in that training. These children are also going to cross over into our education department. So we train the staff in the education department on the same model. They're going to end up in our health clinics. And so we ensure that our providers are also aware of this very unique method and the benefits of doing that. And so it's again, integration campus-wide throughout our health system to ensure that everyone who has the ability to impact these individuals is doing so in a consistent manner. So that's another one of my favorite programs. So it's relatively young in its development. I think we've been working conceptually for about 3 years. And this last year in 2022, we were able to get a designated classroom off and complete lots of training. And in October coming up, we have a whole week that we're actually closing the facility, bringing all of our staff together and doing a training across the board. So that create challenges, it does, but we'll figure out our way through it to get that training done. And again, like I said, I think some of the other things and that philosophy, I think, carries over to things even outside the health and wellness department, although they're closely related. If you've done any research or know anything about the community, if you talk about any particular issue, nutrition, we have an organic farm. Our farm then provides produce to our store that's across the street, over in the whether it's convenience stores behind that. Mesophia, right? It's an avenue for us to have our produce and fresh stuff out there and available to our membership, right? So I think that conceptually, the way in which we address issues is that full scale approach in all the little pieces that we touch. And I think the most important thing that I would say that I heard this morning in the reflections and that I saw in some of the recommendations is I would really encourage you guys to look at the systems, right, that you're relying on to deliver your recommendations. I saw the word Medicaid a lot of times in the recommendation as what appeared to me to be the arm that was gonna deliver these recommendations and care or carry out your vision. I think if as a group, if you've never tried to fill out a Medicaid application, it's, you know, it's a good time. Um, Collaborating between in Indian country, the policy that they have, the insurance that they have, and first and secondary and who paid benefits. I can't have an elder tribal member waiting 17 days to get a wheelchair because they're worried about who's paying first and who's paying second, and Medicaid can't do this because this hasn't done this. I mean, it's that internal flow that's broken. Had they been on a private paying policy, they'd flop their card down and a wheelchair would automatically be delivered like same day. I mean, sometimes people they can't go home until they have these things, the home outfitted, the home healthcare stuff. So I think you guys are right on cue with saying all the recommendations have been amazing. I mean, can they be improved? Sure. But where's the roadblock? Where's the barrier in what you're trying to do? Just like you look at with healthcare, I think that your systems is going to be the place where I would think you could make the most impact. And conceptually, that's really all I had to share this morning with you guys. Ed wanted me to be sure to leave time for questions in case there was any questions in regards to something that SMSD is doing that I could potentially answer.
Joanna, thank you very much. Questions? Yeah, Sharonda.
Sharonda Thompson. Thank you, Joanna. I appreciate what you were saying. I just want to kind of clarify some of the thoughts that I had in my head based on what you said. So the way that you all are set up, you're a federally recognized tribe, so you get the funds directly and have the ability to govern your funds and your healthcare. So what I was thinking you were saying, correct me if I'm wrong, is that if we can increase the funds to the federally recognized tribes, they would be able to incorporate the other tribes that do not have that ability to govern themselves and their healthcare, that are near them, like you do with the other natives that are near you but not part of your tribe.
Yeah, you know, again, I can't speak for all communities. I mean, again, in my experience we talk about, so Minnesota, right? I'm obviously very familiar with Minnesota because this is where I live. I mean, the 11 tribes that are here in Minnesota, they do work together and collaborate, you know, in regards to how those things are going to be done. But the first part of your question, yes, I think that if you want to impact the indigenous population, you need to recognize that they have the ability, will, and drive. And I think the knowledge that you're searching for to improve the health of their own people. And so instead of running that funding through any other gatekeeper, you need to allow the tribes that funding and give them their money to improve their health, right? Because they're the only ones who can really truly do it. And yes, I mean, I do think that having the ability, again, that on site, when we add or create a service within our direct care clinic, it obviously immediately benefits our population that may not be enrolled in our tribe that have access to the clinic. Your urban question on the urban population is where you might need to consider how would you fund or give the tribe the opportunity themselves to support their urban population, right? There's a lot of dynamics that go into play about individual who may be enrolled in a federally recognized tribe that's living in an urban setting. But you also have to, there's probably urbans that are not enrolled in a federally recognized tribe that also live within that city population. But again, that barrier to when the funding is provided, it's for services that they normally provide within the reservation bounds. So if that individual is displaced to have to go work and provide a living for their family, their ability to go back and forth to get that care is challenging, but maybe some type of direct allotment that allows them to care for their urban population could potentially improve the outcome.
Joanna, I'm curious, you know, the Shakopee Waakato Sioux is a major player in Minnesota. I mean, you have an influence throughout the state, you know, particularly in the Twin Cities with the university, with, you know, some hotels in St. Paul and lots of not-for-profit organizations. How do you embed sort of your culture and your learnings into your more community outreach activities? How do you try to influence the broader population that you are influencing because of who you are? And what is your strategy and how do you make that happen?
That's a great question. I mean, I think that ultimately, yes, we have that ability to engage in conversation. But again, it comes down to, I think it comes down to a lot of hard work by a lot of the people who are part of our team, our employees, the people who we bring on as we'll say experts, that are providing our healthcare. So for example, when we talked about that care navigation program, right? And I heard you guys talk about, how to ensure that it's to address the lack of respect it's really education, right? You really have to get out there and you have to educate the people surrounding us that are providing care to my members when it's not within my own clinics, right? So we partnered with, for instance, St. Francis. They're probably the closest hospital to us, a couple miles down the road. So we went in and the tribe, we used our staff to do like cultural training. And the year that we did that, they ran everyone through the program, and we engaged with over 500 medical care providers within their system and talked about all of these great things, understanding things. We helped, we have a smudging policy in play at St. Francis. It's also at another facility. It's with one of our youth behavioral health care partners, which is Prairie Care. They've taken on and made that part of their policy. And again, I think most times it's like, well, how do you do that? Like, what do we have to do? And what does it have to look like? And I think, allowing the individuals to bring in their what they deem is culturally appropriate in any situation. I mean, they'll direct you, I think the policy really even wasn't that complicated. And that's like, number one, get a cover for your smoke detector. That's it. Like, it's that simple. You either, cover it so the smoke doesn't set it off, and then the individuals can go ahead and do whatever traditional component of their that they want. So I think it's a lot of education. It's a lot of reaching out, making yourself available, showing up to the table for the conversations, and just trying to infuse. And I think we try to do it by example as well, right? Like some of our missions and what we put out there, when we were focusing on nutrition, the seeds of native health, right? And we helped develop that campaign and partner with the U of M. So there is a lot of partnership that needs to go on. And that's not always the easiest thing when you're talking about Indian country, because not relationships with outside cities and government structures that surround a tribe or reservation land, those are not always, the healthiest and or most positive relationships. And so, but I do think that that's where the hard work has to come in on both parts. They have to come to the table realizing that if we're going to actually make an improvement, we have to find a way to interface with and exist within that system that lives outside of our walls and make it work to our benefit. Yes.
Okay.
Couple questions. We're trying to think big. We're trying to think bold. We're going to try to put recommendations out that'll incite change. When we think big and think bold, then we kind of have to think practical too in terms of recommendations. So this is the kind of background for my question. I need to learn a little more about the pass-through situation, that you have. Is that something that you negotiate with Indian Health Service? How does it happen that tribes get that pass through? And is it practical for most tribes to be able to do that, or are small tribes going to not be able to manage that? And would it be constructed then at a state level? I mean, how can you make that concept really practical? Because it sounds really good.
Yeah. Again, I don't know the statistics in regards to how many tribes within Minnesota or within the region are at. Where are we? 60% of the tribes are already utilizing a self-governance contract. So where they're not, again, that would be a good question. Why are they not able or choosing not to use that self-governance contract? It's a choice. I mean, you have a choice. Again, there's a process. I mean, that you have to contract. Basically, you have to have an agreement. And there's some, obviously, I'm trying to think off the top of my head, it's been a long time since I looked at ours because it's been in place for so long. The ability, you have to show the ability to maintain the financial component. So there has to be some proof of some stability and whatnot. And there's some audits required, of course, there's always red tape, right? There's always pieces that they have to do. So, and I think that number continues to grow. At least I know that the tribes that we come in contact with or that we're talking with, that's something that we're always sharing. I mean, we're always going out, and when we're asked, and we get a lot of tribes that come and visit us, and we're like, hey, look at your option for self-governance, right? So that those funds can be directed directly to you. And I think just a follow up on your component. Yes, I love the dream big, the going bold type thing. I don't really have a practical, no, it's those hard to blend those two together. It's very, very hard. Yeah, I mean, yeah, there's always a way. I'm a firm believer that there's always a way to get to the end of the road, but at the same time, how do you, again, it's all going to allow the individuals who are capable and can do that to start doing that themselves.
We have time for one more question, and Dr. Warren has one.
Good morning. Thank you
Good
so much
morning.
for being here. I was struck by your comments a few moments ago about the relationship with other city or state governments and some of the challenges there. And at HRSA, we've been trying to work to look where we've got the opportunity to expand our eligibility for grant programs directly to tribal communities. To do that, some of them, the way the laws are written, the grants go to states. And so are there ways that we can think about those programs and support those interactions with tribal communities within states, or experiences that you've had that make that work better, that we could take back to that grant funding?
That's a good question. Well, I mean, my first thing, we'll change the language. Don't limit it to just states, but that could be, sound simple, but extremely problematic, right? I think that, again, I think it would be in how you're going to allow them to deliver that, right? So again, it's all about these systems that you want to use. We're saying there's funding available, but we want to run it through a system that has inherent barriers in the system. And so I don't know how to solve that problem unless really, and I think maybe jokingly, I was serious. You have to change the language. You have to change it at the beginning in order to make that impact, right? If you're gonna give funding to a state, why would you not give it directly to a federally recognized tribe? I don't know. But so that would be my question, is why is the policy what it is? I mean, again, when you look at a state system, any public health system with any state, I mean, they have a huge job on their hands. And I'm saying, again, if there's a community that happens to reside in there that has a sovereign status and has the ability to facilitate their own, why would you not want to direct that care, let them improve it, and reduce the amount of scope that the state has to have?
Joanna, thank you very, very much for hosting us here and
Yeah,
for your
absolutely.
presentation. I hope you can hang around for a little bit during the course of the day. I know you've got other things going on, but I'm
Yeah.
sure that people may have some questions. that
Absolutely. I have
probably-
to step out for a little bit, but
Yeah.
I'll be back this afternoon.
Wonderful. Thank you
Okay,
very much,
good. Well,
Joanna.
good luck and have a great day.
All right, let's now move on to our next panel. So if we have Meredith Raimondi and Patrice Kunish, come on up and sit at the table up here. And I know we have Stacy Bolin we don't have this quite yet. That's going to be the next presentation, is the swearing in of this. But there's another big thing that happened today. Your money is now going to have a signature of an American Indian woman, Chief Lynn Malerba. And I say that because one of our panel members, Patrice Kunish, was interviewed by NPR's Marketplace report, I believe. And so as I'm driving in today, Patrice, I heard her voice on the radio. And all right, so we're going to be talking about policy and program considerations to improve Indigenous health. And we've got Meredith Raimondi, Vice President of Public Policy, National Council of Urban Indian Health.
Good morning. Thank you. I think we have a slideshow as well. so
Oh, okay, okay.
I'll
good.
let them get that.
'Cause,
sorted.
yes, yeah, no, this is fine. Mary Owen had talked about this, this historic day. So
Yeah.
we've got it, it's going to be marked a couple of times.
All good to go, Emma? All right, thank you. We are. Apologies. All right, thank you. Well, good morning. My name is Meredith Raimondi, and I am the Vice President of Public Policy at the National Council of Urban Indian Health. I'd like to thank the Advisory Committee for the invitation and the opportunity to present today and talk about recommendations regarding the health of American Indian and Alaska Native infants, children, and mothers living in urban areas. Thank you to the Shakopee, Mindawakaton Sioux community for hosting us for this very important meeting. NACUI also thanks this committee for its commitment to improving the health of Indigenous mothers and babies. I'd also like to thank Joni Buffalo Head and the Indian Health Board of Minneapolis, which has been providing healthcare to Native people in Minnesota and urban communities since 1971. Native communities throughout the country experience maternal and infant health disparities compared to the general population, something you have heard over and over the past few days. While there is not a one-size-fits-all solution to address these alarming disparities, we have prepared some recommendations for the committee today. Next slide. Like many of you, we have been working in this space for far too long without seeing results that have improved health outcomes for mothers and babies. As we begin, I'd like to highlight some recent work on this topic. In March of this year, we submitted comments to this committee, and last month we submitted comments to HRSA's Maternal and Child Health Bureau regarding the Pediatric Healthcare Access Program. In our comments, we have continued to stress the critical importance of including urban Native populations in HRSA's overall efforts of improving health outcomes for all Native people. I will cover some of our policy recommendations in the following slides. Next slide. I just wanted to share a little bit about NACUI, the National Council of Urban Indian Health. We are a national nonprofit organization devoted to the support and development of quality, accessible, culturally competent health and public services for American Indians and Alaska Natives in urban areas. We advocate for the health of urban Native communities, and we provide critically needed technical assistance, training, policy support, and other services to urban Native communities located throughout the United States. Next slide, please. So you've heard a lot about urban Indian organizations and urban Indian health over the past few days, and I just wanted to break that down a little bit further. One thing that we heard about is, federally recognized tribes and federally recognized tribal members. In addition, urban Indians are defined in statute to also include descendants and state recognized tribal members. So these individuals may also receive services through the Urban Indian Health Program. And then Urban Indian Organization is a technical term used in the Indian Healthcare Improvement Act to convey the health clinics that are run by urban Indians to provide healthcare to urban Indians. I'd like to recognize that Minnesota is a historic site for the hosting the first meeting on tribal land because the Twin Cities and Seattle, as you heard from Socia yesterday, were among the first official urban Indian organizations in the country.
These programs were first established as pilot projects created by the communities, beginning with the Indian Health Board right here in our backyard of Minneapolis. 51 years ago, in 1971, Representative Julia Butler Hanson of Washington, who ran the Appropriations Committee serving Indian health, said the problem arises when Indians leave a reservation on their own and are clustered in cities such as Minneapolis, St. Paul. She also stated that improving the health of mothers and children has always had the highest priority in the Indian Health Service. This was 51 years ago. And here we are today, and we are hearing the exact same issues over and over and over again. And I would just like to point out that this, even the language of the colonizer is apparent here when it says that Indians left the reservation on their own. We heard again over and over how people were relocated, displaced, and terminated. This is by the country, and these are the systems that we are talking about. But I would also like to highlight that urban Indian organizations are a shining light and a place within the system that is working when it isn't able to do so. Congress first established urban Indian health clinics in 1976 officially, when only 40% of Native people were residing in cities. Again, 50 years later, the budget for Indian Health Service for urban Indian programs is 1% of all Indian healthcare. There are 41 urban Indian health clinics with 77 facilities, and they are growing at a rapid pace. Yet they cannot keep up with the growth that they're experiencing due to lack of investment and funding. Next slide, please. So this just explains the Indian health system. Like we said, a lot of systems are being discussed today. There is the Indian Health Service, which runs federally run facilities. Then there are tribal, contract, or compact facilities. And then there are urban Indian organizations. Next slide, please. You heard a lot about the services provided by these clinics. And I would like to also note that the Oklahoma City Indian Clinic is opening a first ever urban Indian maternal health clinic in the coming year. As providers of culturally focused healthcare, we have heard that term over and over again, and you have seen from the discrimination that people have experienced why it is so important to be able to go to a provider they can trust. At least 23 of the clinics provide maternal infant health and prenatal and/or family planning. Again, as Socia mentioned yesterday, because there's no dedicated funding for urban Indian health in the maternal area, they have to do with what they can with the funding they have. They also provide pediatric services and participate in the maternal child programs such as WIC and HRSA's maternal infant and early childhood home visiting program. Next slide, please. We'll make sure these slides are available. These show where the different clinics are located throughout the country. Next slide, please. And this is where all of the different types of IHS facilities are located throughout the country. Now, as you know, there are Native people everywhere and there are not dots everywhere. So that is something we can change. Next slide, please. Okay. So significant disparities persist, and there are many statistics on the coming slides. And again, we will make these available. Next slide, please. So we have a handout that we have shared with you, and we hope that this will be helpful as you make your recommendations going forward. Next slide, please. Again, we went through some of the factors that you heard about. Cost being a major component and a barrier. Again, filling out Medicaid applications and the discrimination and lack of cultural competency. Next slide, please. We also wanted to highlight that Native infants and mothers living on tribal land and reservations, along with urban Native infants and mothers, experience significant disparities. This chart here is from 1989 to 1991. The location we're in is number 1 for inadequate prenatal care for American Indians and Alaska Natives. Thankfully, the areas of Minneapolis, St. Paul, New York City, Bakersfield, California, Baltimore, Maryland, Billings, Great Falls, Montana have all done incredible work to improve urban Native populations and access to resources. However, significant disparities continue to remain. Next slide, please. Another thing we've heard about a lot over the past few days is the federal government's trust responsibility. And so I wanted to outline what that is and why it's important. This is a sacred promise that the United States made to American Indians and Alaska Natives to provide health care. So when we talk about a return on investment, there is no return on investment. This is a prepaid healthcare plan, and it is the United States government's responsibility to provide the highest health status, highest possible health status, and to provide all the resources. How is the system going to be successful if you do not set it up for success by providing the resources that this law says that you are supposed to do? Well, our UIOs do carry out the trust responsibility to provide healthcare for Natives in urban areas. In fact, recently through the COVID-19 pandemic, when you heard that there was an influx of resources to the system, the highest percentage of population receiving COVID-19 vaccines is the Native community. And that's what happens when resources are provided and made available. The healthcare is accessed and it is received. Next slide, please. Unfortunately, despite the critical importance of the Indian health system, the United States has not met its promise. This underfunding is particularly troubling to urban Indians. According to the U.S. Commission on Civil Rights, the low funding federally appropriated for urban Indian healthcare is concerning and likely fails to meet the obligations of the federal government under the trust responsibility. Over half of the UIOs provide maternal health care, but due to chronic underfunding, many health centers only have the capacity to carry out these services for the early stages of pregnancy. Despite the desire to do so and the community-based need, many urban Indian health clinics cannot expand their services due to underfunding. Often expecting mothers who wish to visit urban Indian health clinics have to be referred to hospitals and non-UIO clinics for continued care. And in yesterday's example, you saw how the transfer of care resulted in the death of a mother and her children. Next slide, please. We support the committee's recommendation to reauthorize the maternal infant maternal infant and early childhood home visiting program, MCV as it's called. Earlier this year, we signed on to a letter to support doubling the tribal set aside. Again, when you're talking about the set aside, that's an additional amount of funding allocated in different bills by Congress for tribal and Native communities. So if any bill touches any part of the HHS, it is the goal of tribes and urban Indian organizations that it have a set aside. And that is how it can get infused into the system. That is how you can have funding that isn't grant based, but it actually goes directly to the people who need it. Next slide, please. Another thing we've talked about is the lack of data. One of our UIO leaders has said, data is dollars. So the stories are incredibly important and moving and critically important to understanding the issues. But we also need to invest in the ability to provide data. Without data, there is gaps in care that are inevitable, and unwanted health outcomes will continue. Data concerning native and maternal and infant health and mortality is not collected or extremely limited. A report by the South Dakota Advisory Committee on Civil Rights said there is a lack of consistent, comprehensive data available regarding maternal health of American Indian populations. And this lack of data makes it difficult to develop explanations for the present maternal health disparities. Now, there have been many reports and there have been countless studies done, but we can continue to provide and investigate and work with tribes and tribal organizations to collect and apply their own data in the way that they would like to see it done. Our next recommendation, sorry, next slide, please. Our next recommendation is also the establishment of a confer policy with the Health and Human Services. Native American representation is extremely important, and we would like to see all of the Health and Human Services truly understand and appreciate that their responsibility extends to Native people. I've heard a lot about how IHS is not able to succeed, but without being a stakeholder at HHS, they will not be able to have success. We support elevating the position of the IHS director to the assistant secretary role so that they may better work with HHS as a collaborator at the table instead of an agency that doesn't have the resources it needs to be successful. We also support encouraging HHS to work with all Native people and urban Indians through a confer process so that they are hearing from Native people about the healthcare needs they have. Finally, next slide, please. We'd like to reiterate the importance of Native American representation at the table on committees. We appreciate that there is an ex officio member from IHS, and we also recommend that there be appointed an urban Indian provider and tribal provider added to this committee. Again, we've heard over and over about how important it is to have representation, and that's why you need to hear directly from the people whose services and healthcare you're going to be affecting. Finally, before I conclude, I would like to say that equity is a buzzword that we're hearing every day, especially in the space of healthcare delivery. But if there is not Native representation at the table making decisions about their healthcare and the policies that affect them, then you are not doing justice to the conversation of equity. Over and over again in Washington, I find that I attend meetings or coalitions where there is not one Native voice or Native organization represented. So I would like to encourage you to contact many of the people here today or myself if you are establishing or working on any equity project that doesn't include a Native voice. If you are, thank you. Please continue to do so and know that that is meaningful. This is an urgent need, and we have outlined many recommendations today. I would also like to truly thank all of the people who spoke. The stories will resonate with me for a long time to come, and I know they will resonate with the people here today. I hope that the administration will hear the stories, lift you up, and begin to create lasting policy considerations. Thank you.
Mr. Ramondi, thank you very, very much. Very helpful information. And I'm sure there'll be lots of questions when we're done with the three presentations.
Okay,
So
great.
thank you.
Thank you.
Let us now turn to Stacy Bolin from the Sault Ste. Marie Tribe of Chippewa. She's Chief Executive Officer of the National Indian Health Board. And she's going to be joining us virtually. And Alicia Sneddy, the NIHB Maternal and Child Health Project Coordinator, is here in person. So we can follow up with her. But Ms. Bolin, I turn it over to you.
Miigwech, ani, Gijnakas Mikinikwe. Good morning. My Indigenous native name is Turtle Woman. And with that name comes a responsibility to speak the truth for all the people. I am a citizen of the Sault Ste. Marie Tribe of Chippewa Indians in the Upper Peninsula of Michigan. And I'm the Chief Executive Officer for the National Indian Health Board. It is a pleasure to be with you today. I've been listening to the deliberations and the discussions and the presentations by folks from our community who have had notable experiences, let's put it that way, that really need the attention of policymakers. So thank you all for your service. And I'm delighted, as I said, to be here. Next slide, please. The National Indian Health Board represents and serves all 574 federally recognized American Indian and Alaska Native tribal governments. We are the consolidated, unified voice for Indian country in the United States from the federally recognized tribal perspective. We were created in 1972. This is our 50th anniversary this year, for the express purpose of advancing the voice of federally recognized American Indian and Alaska Native tribes to ensure that tribal sovereignty is reinforced, strengthening tribal health systems, securing resources, and building capacity to achieve the highest level of health and well-being for our people. That's the work that we do, and it can often be summed up in the word advocacy. Next slide, please. I wanted to share with you some terminology concerns that we have and perhaps offer some helpful input from the tribal perspective. I've heard a lot of talk from this committee about Indigenous populations and serving Indigenous populations, but there is a correction that the tribes would like to see, and that is the American Indian and Alaska Native term. Those are legal terms, and they portend a legal status of our people in the United States of America. These are the correct terms to use when discussing federal policy as it pertains to the sovereign nations and their citizens. This is found in the United States Constitution, and the US federal government, because of treaties and our special relationship, again, codified in law, Supreme Court cases, and the Constitution, the United States government has a special trust and treaty obligation to the tribes. It attaches to the 574 federally recognized tribal nations. And we know that the word Indigenous, yes, we are Indigenous to these lands, but when working on policy and discussing American Indian, Alaska Native, and any kind of a policymaking environment, those are the correct terms to use because they are the legal terms of art and expressions of our people, and they respect our political status that our people have in this country. Next slide, please. Each of the issues that we'll bring before you today are examples of structural policy, practice, and funding priorities contributing to the ongoing harm to American Indian and Alaska Native health and public health. Many of the policies that we're going to discuss today, or that we're going to point out, or the statistics that we will use, are a result of paternalistic policymaking, cultural barriers, or the great hand of colonization that began 600 years ago and seems to continue to operate invisibly in the policymaking arena. The good news is that the requested suggestions advanced here will if put into practice, would set the path for long-term improvement in American Indian and Alaska Native health. I also just want to quickly give a shout out to my Native Hawaiian brothers and sisters. What I've described here in terms of nomenclature does not imply in any way a lack of respect or recognition of the colonization, the suffering, and the histories and the current status of our Native Hawaiian brothers and sisters. I'm simply pointing out the legal status that is very, very different for American Indians and Alaska Natives. Next slide, please. So I want to frame this discussion today in the context of the August 31st issued CDC life expectancy report. Life expectancy in the United States has dropped for the second year in a row in 2021. That's the largest two-year drop since 1922-23. While there's been a 0.9-year drop for all Americans in the aggregate, American Indian and Alaska Native life expectancy dropped 6.6 years in 2021. That puts our people down to 1944 levels for all Americans. This is unacceptable. And if these facts do not portend an emergency, they are not the canary in the mine shaft that is laying on the bottom of the cage. I don't know what will get the attention of policymakers and how change will be made, because we're tired of winning the race to the bottom. And we're so glad that you are here and listening and committed to making change that is better for all of us. And of course, our American Indian, Alaska Native women, our mothers and children, child and maternal health is captured in this number. Next slide, please. The report is, as I said, a bellwether for years of structural racism that has saturated American policymaking and appropriations practices and left our people with the worst health status, systems, and outcomes in the nation. Next slide. So these statistics have been discussed numerous times during this reporting, during your meeting. I'm not going to go into it more. My slides are available to all of you for anything you'll find helpful. You're welcome to them. Next slide, please. Historical trauma, of course, plays a massive, as it says here from Maria Yellowhorse, Braveheart, a massive cultural trauma across generations rather than the most limited diagnosis of PTSD, which is inadequate in capturing the influence and attributes of Native trauma. And I want to contextualize, again, what we're talking about in this way, because when we talk about social determinants of health, we really need to develop, and the National Indian Health Board is developing with tribes, a tribal determinants of health wheel that respects the medicine wheel and respects the fact that when the social determinants of health were developed, they were never intended for our people. Our people were not involved in creating them. Our voices are nowhere. There are several portions of the social determinants of health that attach to us. But when you're American Indian, Alaska Native, health is defined by the full health of your mind, body, and your spirit. That lends itself to the cultural integrity of traditional values, traditional healing, and ways of knowing that are necessary for our people to achieve full health. And the social determinants of health simply do not address or capture that. Next slide, please. So again, you can look at historical and ongoing oppression and marginalization. We've talked about a lot of this over the last couple of days. I want to call your attention to genocide and the cultural erasure that came through war, boarding school policy, et cetera. Because we believe that if you really want to make a difference in child and maternal health in Indian country, you have to address the underlying causes and not simply the symptoms. Next slide, please. So we've done a lot of work in the child and maternal health arena at NIHB. We initiated an annual National American Indian Alaska Native Maternal Mortality Prevention Institute. We partnered with CDC on a number of initiatives, and we have led a child maternity. We are leading the creation of a maternal mortality review committee. We're involved in the Hear Her campaign and the American Indian Alaska Native portions of that campaign. Please, next slide. So I want to go into some recommendations for the committee. And I offer these again from the tribal perspective. I mean them and we mean them in the best way possible. First of all, President Biden reignited and reaffirmed Executive Order 13175 that requires consultation and coordination with American Indian, Alaska Native tribal governments. He charged all executive departments and agencies with engaging in regular, meaningful, and robust consultation with tribes in the development of federal policy that have tribal implications. So we encourage your committee to work through HHS and engage with tribes on any public recommendations you are seeking to advance. Tribal consultation is a very specific thing that occurs, and it is between the federal government in respect to its trust obligations and its legal relationship with tribal nations, with sovereign tribal nations. So we encourage, and really cannot say it affirmatively enough, that your recommendations are developed with tribal consultation and input. Next slide, please. We recommend, as a practical matter, Medicaid expansion. We recommend that the committee support legislation to eliminate the coverage gap for American Indians and Alaska Native women who reside in states that have refused to expand Medicaid or to extend postpartum coverage. These are absolutely critical life and death opportunities through 1115 waivers, through a number of ways that Medicaid expansion can help and treat our people, even though the tribes have a relationship with the federal government. States do not. So an American Indian person who is entitled to healthcare, because we do have the world's first prepaid healthcare system, which we paid for with our land, the gold, the iron ore, the oil, the trees, the water, everything that the land has provided, and the robust riches of the United States, which are land-based. Those were all our lands. We forfeited those. And I know that some folks think, well, you were a defeated people. No, we negotiated because we were a terrifying people, and we fought as hard as we could with our resources that were not on par with those of the invaders who came here. And what we have is a result of negotiations that were entered into. And the Supreme Court of the United States has repeatedly said that the treaties are the supreme law of the land. So even though our people have the right to that health care through Medicaid, if you're in Arizona, because states control Medicaid and they have a Medicaid expansion, you have access to all that means. But if you're in South Dakota, where there are huge tribal nations, huge populations of American Indian people, and they did not do Medicaid expansion, our mothers, our expectant mothers, and their children do not have access in the way that they need to. So supporting this is extremely important. We have done a great deal of work in this arena. We have a committee called the Medicare, Medicaid, Healthcare Reform Advisory Committee that is run from the National Indian Health Board. It is a standing committee that advises and provides technical support to the Tribal Technical Advisory Group, to CMS. And I encourage you to use our resources. Please contact me as a resource. Our webpage is www.nihb.org. We have a vast body of work in policy that we have been fighting for and developing over decades. And during our 50th anniversary celebration at the end of this month, which I shamelessly invite all of you to attend to learn more about tribal health in person, we will be launching a web-based library that will contain the compendium of work that we have done since our founding. Next slide, please. So recommendation on doulas and midwives. I want to share something with you that might surprise you. Let me pull this up really quickly so I have my document to read from. This is about the president's budget request. I don't know if you're aware of this, but in the HRSA budget request put forth by the president, there were a very limited number of, there were 48 students included in the budget who would receive loans to become certified nurse midwives. 48 was what the president's budget had in the 2023 budget request. Now, this is an area where this committee could really have some muscle. The National Indian Health Board has noted in official testimony to the agency on behalf of the tribes that this is not even one person per state, not one certified midwife per state, let alone a number sufficient to address the urgent needs of American Indian and Alaska Native mothers. The tribe's request, the president's 2024 budget includes $15 million for scholarships to train 200 nurse midwives to practice specifically in Indian country. And we further request $30 million for a culturally competent nurse midwife training program to be established at one or more tribal colleges or universities. If you really want to solve these problems, you go to the heart of the problem and invest where the investment will best provide the return that we all need. I'm getting back to my slides now. Just give me 1 second, please. So next slide, please. So another recommendation, we support data sovereignty and research capacity. In the Indian Healthcare Improvement Act reauthorization of 2010, tribal epidemiological centers, tribal epicenters, were put in the law as required to be treated as public health authorities for purposes of the Health Insurance Portability and Accountability Act. We have for years and decades not had access to our own data about our tribal citizens, data that is held by CDC, NIH, and others throughout HHS. Tribal nations and epicenters experience uneven data access throughout the federal government. The Government Accountability Office issued a report earlier this year that affirmed these access issues that the tribes and tribal epicenters have been bringing to the government's attention for years. They put out 5 recommendations for how this can be addressed. We agree with all of the recommendations, but I also want to point out that we have 2 pieces of legislation that NIHB has been collaborating and working with Congress to advance. One is HR 3841 and one is S 1397. Those are tribal data sovereignty acts, and they would ensure that tribes have access to the data that was promised to them in the law in 2010 that has yet to come to fruition. If you can, we would love for you to support the passage of those 2 bills or ask that the secretary does so. We have also made that request. We were in Albuquerque last week with the Secretary's Tribal Advisory Committee. The National Indian Health Board is the technical support for that committee. Tribal leaders uniformly requested support from the agency for these 2 pieces of legislation. Next slide, please. Oh, there you go. This is the foundational issue I was discussing earlier about culture being necessary to our health. Some of you may be familiar with the work of Dr. Michael Chandler. He is a clinical research psychologist in Canada, and he did a seminal work on First Nations in Canada and suicide rates. And he had a hypothesis that if you have strong cultural presence in community, then suicide rates will be lower. And when I heard him speak on this, he said the first things that you throw out when discussing suicide rates among First Nations people is depression and poverty, because they are, quote, as common as the sand. That makes me very sad as a Native person and as an American, because we have normalized suffering for American Indian Alaska Native people, and that cannot continue. But my point is that he did, in fact, prove his hypothesis that where culture, community, traditional values, traditional healing were present in community, suicide rates declined in direct relation to the strength of cultural presence increasing. Now, bring us to this, the boarding school issue. Now, the United States of America had a 100-year policy. And actually, if you look in the law, the policy was longer than that, because boarding schools officially became a funded entity of the federal government around 1866. But in the 1820s, there was already federal investment being made directly to churches and religious institutions to transform my people from Indians to just scrubbing us of our identity, which, by the way, in the Geneva Convention is a crime against humanity. So when we talk about culture being part of health, we talk about culture being part of Native women's health and cultural grounding in prenatal care and perinatal care, postnatal care. We have to heal from what has occurred. We have to have truth and reconciliation on what happened with the 100-year boarding school policy. So we hope that as a looking at the disease and not its symptoms, the symptoms are these horrible rates that we have in maternal deaths and so forth, our health disparities. But the disease itself is something far more insidious. And legislation like S-2907 and HR 5444, which would establish a Truth and Healing Commission on U.S. boarding schools, will be part of healing that underlying cause. So we encourage you to support this as well. Next slide, please. And I'm almost done. I'm a little talky today. So we, of course, recommend increased funding for the Indian Health Service. Building housing for doctors and healthcare providers on Indian lands is an absolute necessity. We found that this is a block to our people being able to have continuity of care with physicians, with doulas, nurse midwives, whatever the case may be. I remember being on a conference call and someone from one of the federal agencies said, well, if Native women don't like the way they're getting their healthcare, they should go seek another place. Well, if you're living on Pine Ridge, you don't have a car, you're poor, you have Indian Health Service there, which has limited capacity. Where are you supposed to go to get your other healthcare? I mean, it's just not rational. It's not rational from our world perspective. So if we had housing, we could have physicians who would have a place to live, doulas, midwives, our healthcare providers would not have to commute 4 hours each way, which, as you can imagine, isn't going to happen. It's not happening. So that's a place that is a block to our success in our health systems. Prenatal care capacity investments, traditional, culturally linguistic, appropriate care, tribal, maternal, infant, and early childhood home visiting program, and food and nutrition investment, both pre and postnatal. Next slide, please. We are working on a tribally led maternal mortality review committee creation. One does not yet exist in Indian country. There is one American Indian OBGYN in the United States who has served on one of these committees and is serving on one now. And NHB is contracting with him to help develop this policy presence, this opportunity in Indian country. And we're working directly with tribes as well. Next slide, please. Support educational awareness campaigns. That's self-explanatory, I think. Next slide, please. That is the end of my presentation. In closing, I want to say that the National Indian Health Board is very engaged in the health equity discussions, policy recommendations, and development. We have an American Indian Alaska Native Committee at the Centers for Medicare and Medicaid Services. We have had 2 national summits on health equity in Indian country, and we will continue to work this out. In fact, I'm meeting with the Centers for Disease Control and Prevention head of health equity in about 11 minutes to talk about how we can help form those policies that are tribally informed. We do have issues with the lack of investment directly to the National Indian Health Board and tribal entities to be able to develop health equity policy, to be able to do the kind of community-based key informant interviews and outreach that really needs to be done to get to the heart of this matter and ensure that the tribal voice is accurately reflected and included. We find that a lot of private foundations will fund non-Native entities to do Native work. That's not appropriate. And I know that's a little outside your realm, but I felt compelled to mention that. So we have developed excellent resources in this area. And if you would like to engage with the National Indian Health Board on the tribal side of health equity work, please don't hesitate to contact me. My email is there along with Alicia's. And I say, Chimagwich, thank you for this time.
Thank you very much, Ms. Boland. This was just like the previous presentation, really helpful to the committee. Did I hear that you will be leaving us in about 10 minutes?
Yes, sir. I have to be on the call with the
All
Centers
right,
for
Will,
Disease
will,
Control.
will Alicia be able to answer some of the questions that I'm sure that the committee will have related to your presentation?
I think that she is very, very capable. Yeah, I think she
All
can
right.
answer the questions.
All
And
right.
if you have more, I'll rejoin or I'll do the best that I can to be available as a resource. And also we can follow up in writing to the committee as well, if that would be helpful.
Yes, thank you very much. All
Thank
right,
you so
thank
much
you.
for the time.
All right. Now let's transition to Patrice Kunish from the Standing Rock, Lakota, founder and director of Penny Haha Consulting and major gift officer of the Native American Rights Fund and NPR commentator as of this morning. Welcome.
I'm Patrice Kunish, and I was on the radio today. Chief Liz Malerba of the Mohegan tribe in Connecticut has been confirmed as the U.S. Treasurer. So we shall see her name on U.S. currency. And it is a wonderful reminder to all of us of the wonderful things that can happen through steadfast dedication and commitment to the people and to the work that we need to do in all of our communities. And when I say Mpetuashte, I want to say it's a good day. And I mean that in both ways. It's good to be here. It's good to be on this topic. And I hope that with this conversation, we're going to do good work. And Mitukuape is a Lakota word for all our relatives. And I do believe we are all related together on these issues, on these concerns, and in our commitment to improving outcomes for Native people. I'm really impressed with what I've heard today, and I truly do not know what I can add to this. But I heard you say, let's be realistic and let's look for better services and programs for outcomes in the future. I also want to say that improving Indigenous birth outcomes is not my area of specialty, my area of subject matter knowledge, as we've heard from the previous presenters. But what I do have is a personal knowledge and a personal experience in this area. And maybe I can start out sharing with you how that vulnerability from a logic model, personally, contextually, can help illustrate or illuminate some of these recommendations that we've heard. I was a very young mother, 20 years old, away from my family. I was receiving a number of social services, public health, public housing, food stamps, WIC, and I was very vulnerable myself, but not knowing that I was vulnerable. I received absolutely wonderful prenatal care on public health, but my birth and after birth experiences were very unusual and very scary. One of the cultural things that we pride ourselves in our family as women, as mothers, and by the way, I'm one of 13 children. And at one point my mother had 9 children. 9 children under 8 years of age. So I thought I knew how to be a caregiver. I thought I knew how to take care of babies and little ones. One of the most important elements of being a mother in our family was breastfeeding, that we would nurse our children. And here I was, a young mother at 20 years old, trying to work, trying to go to school, trying to feed my family, and just not realizing the accumulative stress of trying to do all of that at the same time and navigate these social services. I was very diligent and committed to nursing my daughter. And one day when my daughter was about 4 months old and she weighed about 9 pounds, 5 ounces, a visiting nurse came to see me. This is a visiting nurse from the public health service. And she stepped into my apartment and she took one look at my little girl and she said, failure to thrive. I had no idea what that meant. I never heard that term before. For all I knew, I was doing the absolute most important thing, and that was nursing my baby. I did not know the consequences of that. And she said in the next breath, if you don't feed that baby, we're going to take her away from you. And that was harsh, that it was hurtful, that was judgmental, and there was no questions about what is your life circumstances and how is this going for you, and did you know, thus and such. And right then and there, she fixed a bottle of formula, and certainly my baby was hungry and she needed that nutrition. That daughter is now a mother herself and had complications with her birth. But Lucy Wintermoon is thriving for all intents and purposes. She's beloved and she's thriving. But I share this because we know that poor outcomes in American Indian infants are also related to poor outcomes and poor health care for American Indian women. And if it's hypertension and preeclampsia to anemia to diabetes to poor nutrition, all of this goes together. So while I don't know much about Indigenous birth outcomes as an expert, I do know something about inclusive prosperity and building communities. And that's what I really would like to address today. Another question that I'd want to ask, and I'm really not going to use my slides today because I think so much of what we've heard and the discussion from the other presenters really has provided the full, rich context of the issues. But I like to ask the question, why? Why are we concerned about this? And American Indians, Alaskan Natives are the fastest growing population. We've heard about life expectancy, and that is truly frightening. And I think that's a reflection of the devastation of COVID. But American Indians and Alaskan Natives are the fastest growing population in the United States. And through the US Census 2020, we know that it's a very young population. So just in the past decade, American Indians population have gone from 5.2 million to over 7 million, 7.2, 7.3. This is a vastly diverse population. It's a it's a very young population. The median age is 26 years old. And of course, this is the childbearing years, right? We absolutely need to look at this population in terms of its youth, its vulnerability, and make sure that we are providing the essential care to continue to support this community. We heard a lot about the urban Indians, and depending on how you look at Indian country, about 60%, I would say, live on or near Indian reservations. And those tend to be rural. And so the problems associated with rural healthcare are very much coterminous with the problems in Indian country. And believe me, it is a beautiful place to grow up in Indian country. And something I wanted to introduce today when I said about community well-being and inclusive prosperity, oftentimes we hear, well, why don't you leave the reservation? We heard about displacement and termination and relocation, and my family's much a part of that history as well, of boarding schools and such. But I would like to see policies that allow us and allow our families collectively to remain in place. So that means no displacement and invest in those communities. And we can do this in a number of different ways. We've seen a lot of healthcare policies Maybe what we haven't talked about is how do we address poverty? And you may have heard the supplemental poverty rate measures just came out. And along with these, life expectancies, which seem very, very, very dire, I want to take a minute and just look at the supplemental poverty measures. And it shows significant decrease in US poverty rates, despite the chaos and the hardships and the deaths that we've experienced through COVID-19. So in 2020, we saw a dramatic drop from 12.5% to 9.7%. That was huge. That was truly remarkable. And then COVID hit. In 2021, we saw these rates falling further to 5.2%. So that means an additional 3.4 million kids have been pulled out of poverty. And the reason why these children collectively and their families, collectively, I should say, have been pulled out of poverty is because of these social safety nets. Those that I experienced. Was I proud of having to be on food stamps and public housing and public health? No, but they saved me and they saved my children, and I was able to get through school and earn a degree that led me into the capacity of providing both an income for my family and giving back. And the most remarkable thing is that we did this in just 2 years. And we were able to do that through a supplemental income distribution. And that was through the earned income tax credit and the child tax credit. Now, the child tax credit, I think, has expired. I think it's a policy we should consider on the table, make it permanent. Earned income tax credit is absolutely essential. I received it as a young employee. But to see this decline so remarkable, so substantial in such a short period of time, I think we can do it and maintain that low level of poverty rates. The other thing I wanted to mention are some things that are incredibly practical, going back to that realistic perspective and the question of why. Why do we want to take care of Native mothers, and why do we want to take care of Native children? I do some work with the Minnesota Indian Child Welfare Law Center here in Minneapolis. And one of the biggest concerns they have is taking care of pregnant women who might become the subject of child protection service. And the biggest fear they have is that when they go into the hospital and they give birth, the first thing they experience is a urinalysis, a UA. And if there's any trace of drugs in that UA, the baby is removed from the mother. There's no chance of bonding. That CPS system cycle starts, and we have a huge disruption, emotional, familial, physical disruption. So we need to go backwards and find an opportunity, that opportune time to engage with that mother. And we find something very, very simple and very inexpensive has worked tremendous good. And that is a parent mentor. A woman herself who has been through the system, matched with a mother, so that she can care for and guide that mother through the birthing process, so that at the hospital that UA comes to the Native mother and the child is able to remain intact with the mother, and then work on parenting post-birth. That's a very, very practical, simple policy recommendation. And it's about family, it's about kinship, and it's about care. Another response to the question why, we've heard, I'm sure, a lot about the COVID-19 and the impacts of COVID-19 in our Native families. What we might not have heard about are the impacts of COVID on caregivers, because Native women are head of household, primary income earners. They often are much more vulnerable to, they have been much more vulnerable to COVID-19. And in the past 2 years, we saw not only a tremendous rate of mortality in Native Americans, but it's hit Native women particularly. And this has left a number of Native children orphans, COVID orphans, as we call them. And sadly, Native kids have the highest rate of caregiver loss amongst all COVID families, 4.5% the rate of white women. So one Native child in 168 children will become a COVID orphan. Compare that to 1 in 753 white children will become a COVID orphan. So we need to protect our women. We need to provide them health care. We need to provide them care and nutrition. The other thought that I had, and that comes from the other task force going on at this time, and that's the White House Task Force on Hunger, Nutrition, and Health. We know that Indian country has food deserts. The food insecurity is afflicting our Native families. And when you're a pregnant mother, you need that good nutrition. You need to provide as much as possible for yourself and for your child. So when we take care of hunger and provide nutritional food, and we demonstrate the importance and the correlation between health and health of the mother and health of the baby, we are going to reduce the number of complications and mortality. So going back to my theme about community well-being, and I loved what Stacy said about the whole human being, the whole person. That's mental health and physical health, but I also want to include community health. And we know that when we remain in place and invest in community, we not only have positive economic outcomes, which translates to reduction of poverty and support of the family, we have lower crime rates, we have higher rates of home ownership, we have higher rates of self-employment. We really support the community in a big way, and those are called social networks. And another big study that we should introduce into this discussion is the Raj Chetty, the social network, the social mobility network. And this is why I think focusing in Indian country is so important. A few years ago, when I was at the Federal Reserve Bank overseeing the Center for Indian Country Development, we took a look at Raj Chetty's opportunity map, and we wanted to overlay that with Indian country and kind of see, what does it look like? Well, as you can imagine, the upward mobility income-wise for Indian country wasn't very good. There was, if you're in the the lower levels, you're not climbing the ladder. And if you're along the ladder, you're probably going down. And there were two remarkable findings or revelations for us, although the data, I want to say is a little messy and doesn't match, specifically or really tightly. But we did see two things that are pretty remarkable. Native women had the largest disparities for intergenerational mobility. That means Native women are pretty much stuck. But the other thing that we found rather remarkable is that kids, Native kids who grew up on or near the reservation, these census tracts that overlapped reservations, actually had a much better, more positive upward mobility possibility. So that's why I say invest in community, invest in the well-being, housing and education and family. And there are very simple things that we can do for guidance, for support. The data is certainly important. The healthcare is absolutely essential. Basic supports like broad care for telemedicine are going to be incredibly important. But when you're lifting up the community, you're really embracing and putting your arms around every single one in the community. And in that way, we prosper together. I'm just going to close because there's so many, much food for thought here. But I think oftentimes about the great Lakota chief and spiritual leader, Sitting Bull, who said, let's put our heads together and see what future we can make for our children. And I think that's the work we're doing today. So thank you very much.
Priest, thank you very much. Again, great presentation. And even though you may not claim you don't know anything about Indigenous birth outcomes, the reason I asked you is because of your community focus and your work with the Federal Reserve Bank and the fact that you are nominated to be a commissioner for the Administration for American Indians, which is a huge policymaking endeavor. So could the other presenters and Stacy, or excuse me, Meredith and Elisha come up and we'll take some time. I built in the agenda some time at the end of the day. So we're going to, give everybody some chance to speak. So we're going to take about 10 minutes here for some conversation. Then we'll take a short break and we'll come back and we'll give Mary Owen her full 45 minutes, but we'll get everything in on the agenda unless we really get off track somewhere along the line. But let's raise some questions for these three individuals and the incredible presentations that we just heard over the last 45 minutes. Any questions, comments? Janelle?
Thank you for the presentations today. It was all presented eloquently, and there is so much that was covered today that still the committee would probably have more questions about, the history behind why states have sometimes really difficult relationships with tribal communities. That goes back in our history, and it's exactly what was said, that states do not have a special relationship as sovereign nations do. So that sets up for sometimes jealousy that abides, and that still plays out today, in addition to the fact that many state people are not aware of general US American Indian history. And so there is a lack of understanding on those parts. I just want to clarify when one of the other issues that I have been meaning to bring up is this Indian of urban Indians, and then the size, the 76% American Indians identified are located in urban areas. And I want to be clear, these are not, when we look at that data, that includes populations of towns that are 2,500 and over. So you can still have very rural communities like in Montana, where I'm from, that have over 2,500 people, but still very, very rural. And they're considered urban. So, and they're adjacent to reservations or on reservations. So we use the statistics, 76% of Native Americans, they're not all in Minneapolis, they're not all in Seattle or Chicago or LA. They're around, just as Patricia was saying, that they're all around, most of the people are around reservation borders in and within. So the other part of that issue is that Native people tend to be a mobile population. We move back and forth. Most of my family members, depending on what day you find them on, are either on the big city, Missoula, Montana, or they're back home on the reservation. So it's a very mobile population. And that is just for context. Still, all of us are underfunded. All Native communities are underfunded. So we're not trying to quibble about trying to make sure that resources are pulled away from one group and given to another. We're saying we've already prepaid, give us what we need.
Any comments from the panel on that? I think great points to be made, how define things. Lee.
Good morning, and thank you for your presentations. Very insightful, and we very much respect the input from the organizations that represent tribal entities because they stand in the gap between the dominant culture and the systems that are in place and trying to address the needs of the individual living on the tribe and living in urban areas. I'm going to ask a question, throw it out there, and it's a bit of I don't want it to be a bombshell. I'd like for it to be something that we consider or talk a little bit about. I'm noticing a certain gap, and I raised this out of total humility, having worked with tribes since the early 90s. We have spent many hours here talking about the needs of maternal and infant health in tribal communities and for individuals. And I know that our focus here is on that particular issue, but as we talk about community and we talk about social determinants of health or factors that contribute to well-being of the society that we're trying to work with, I've noticed a tremendous lack of any reference to men. And with other than reference to men, not necessarily Native men, but in a situation of danger. And the recommendations that I see that we're making are recommendations targeted at systems and approaches. And I'm wondering whether there are recommendations and advice from you in how this committee can address the whole system as it relates to the whole family, as it relates to the community and the people. And if any of those recommendations should be directed at addressing the needs of men.
Thank you, Dee. That has come up in side conversations, so I'm glad you brought it up. So I really look to the panel of your thoughts on how we include men in the conversation and in our recommendations and in our data collection and all sorts of things. Patrice, do you have any thoughts?
I always have to offer. We have found that Native men are absolutely integral to this equation of supporting maternal health and well-being and infant well-being. They're part of the overall family. Some of the things that I have seen in my personal experience and in working with tribal communities is the some of the different roles that Native men and Native women have in society. I mentioned earlier that statistically, women are the head of household. They are the main income providers. And that tells me that men are absent or the other partner in the family are absent. So whatever we're doing to support community in terms of job training, employment, housing stability, income supports, what have you, it has to apply across the board that can hopefully support and enrich the entire family unit. I'm wondering, Meredith, do you have something in your data?
Yeah, I think this is where one thing that Patrice mentioned also was the age, where the caregiving age of where the community is expanding at the highest rates. And one thing to note is that young Native American men ages 18 to 34 have the highest rates of suicide of any population. And this is why, the work that our youth council and the youth councils we're developing for future generations are so critical. Every year, we host 5 individuals. It was the first urban Indian youth council in the country. And there are higher rates of intergenerational trauma experienced from being distant from the land and the community. And so each year they create a mental health awareness campaign. And this year they did the Rivers of Rejuvenation. You can find their stories on our YouTube page for NACUI, but what we're seeing is that the young men in this program are extremely dedicated and committed and willing to make change for future generations, and they're willing to step up. But we need to, again, really reinvest. That's funded through the SAMHSA. So, programs like that, Native Connections is what it's called. It's expiring September 30th. Another program that, without the investment to continue, we're not going to see those rates change. And we really need to be investing, from day one. So, it's infants, but it's up to youth, and it's through young adulthood in those critical times, so that we continue to, we need to keep people alive, and so that they can be part of these conversations and play a role here.
Alicia, any thoughts?
Yeah, just real quick, introduce myself again. So my name's Alicia Sneddy. I'm Navajo from New Mexico. I'm very new to the National Indian Health Board, so I'm very honored to for Stacy to bring me along and support and represent our organization. I'm a recent graduate and PhD graduate from the Bloomberg School of Public Health, and just being raised on a reservation as well for part of my life, and growing up mostly in Albuquerque, New Mexico. So relate to the conversations as being an urban Native American woman, being an older sister too, and having younger brothers and siblings. So, and I'm still learning a lot in this work. So I really appreciate everyone's insight stories, learning a lot. And I apologize if I can't answer any of your specific questions today, but definitely taking notes here, and we'll relay that back to Stacy and the rest of our team at the National Indian Health Board. I'm just relating to these incredible women here that I'm sitting with today about how to address and including men into the conversation, and more Native youth into this work. Just seeing it myself and growing up on the reservation, and relating to that, and we can't ignore, historical and intergenerational trauma in our families and communities, and that stigma of caring about certain issues and being involved, and really that lack of investment in youth programs and resources in our communities. We have lots of great stuff I've been seeing on the national level in DC, but when I think back on the Navajo reservations, and specifically like Crown Point, New Mexico area, Gallup, New Mexico, and many other Native communities around the country that don't have those funding mechanisms to create, these youth councils or resources. And I know someone mentioned yesterday about just needing more supportive figures in the community, and relating to like big brother, big sister type of programs. Yeah, so that's all I have to say. Thanks.
Really glad you're here. Time for one more question. Well, I see two hands, so we'll two more questions. So let's start with Colleen and then Magda. Press the one that has the ear. Just touch the one that says there you go.
Hello, I'm Colleen Malloy. I'm a neonatologist and pediatrician from Chicago. I've been on this committee for 4-ish years, so this has been an exciting meeting to be a part of. So Mr. Wilson, Lee's question kind of dovetails with something I've been thinking about, because working in an urban setting, I feel like there's always kind of the question of data, because looking at the three of you, like people would make a judgment, what ethnicity, what box do you belong in? So when mothers come in to deliver at our hospital and the nurses are checking off different categories that people belong in, I think there's a lot of judgment there, because I don't know, like there's a blonde lady here, and and even yesterday, Dr. Ellinger said that Janelle is the only person who has American Indian blood in their family, and that's actually not true. My husband's family is American Indian. And so I think that even looking at the definitions of how we describe people in different boxes, when I just did a little search, I was interested to see that the IHS defines someone who's eligible for services as even someone who in the household of American Indians is part of that living situation, even if they're not of American Indian blood. So I just think there's, when we need better data, and if so many Indians are living in urban settings, I'm positive that there's mothers who have delivered at our hospital that were not coded as American Indians, even though they definitely were. And so I don't know the best way to do that. Self-reporting probably, but sorry. So I guess my question for you is how to improve how we are designating people in certain boxes, because I think just looking at people is so judgmental and it doesn't accurately reflect the true history of that person. So is there a better way that we can kind of get that data?
Thank you for the question. This is something that I really noticed, especially during the COVID-19 vaccination process. I don't know, I'm sure if you were getting a vaccine, you had to fill out a lot of questionnaires. And time and again, I saw that it was a select one box for race. And at Native American populations are most often in combination with other populations. And so if you force people to select one box, then you are not counting the data properly. And we do need better data systems, because time and again, I have heard from my colleagues and coworkers, they have gone in for multiple appointments to the same clinic only to be reclassified as white over and over again. So we are not counting people, and the census count again is an undercount because things are not being collected properly. And this is why, as Stacy mentioned, but this is why tribal consultation and urban confer is so important, because you need to hear how the data should be collected in a way that's going to be informative. So I believe, yes, self-attestation is important, but people get sick of going to the doctor and having to check if their race is correct on every single appointment for just a regular medical appointment. So we need to do better at that, and it needs to be in a non-discriminatory way.
Magda?
Thank you. One quick thing. That was a question about the fathers of the babies are never really involved. So if I'm looking at a mother, I don't know if the father is American Indian or African American or white or black. And so I think that that's always, if IHS is classifying a mother who's carrying a baby of American Indian descent as someone who is in the column of IHS, like, I don't feel like that's widely known or documented appropriately. So thank you for your answer.
All right, well, thank you. Magda said she would step back for a little bit and have some consultation on the side. So thank you. Let's give this panel a round of applause. This is just fantastic information. And we're going to take a 5-minute break, really 5 minutes, and we'll come back here at 11:35. I'm losing control of the crowd, or I've never had control of the crowd. We'll just take it out of your lunch. You'll only have 10 minutes for lunch. And our presenter's taking control. I love it. I love it. We will be getting started here in just a minute or two, or no. All right. I'm really pleased that we have Dr. Mary Owen to come and talk about some of the issues that have been brought up. Mary is the Associate Dean of Native Health at the University of Minnesota Medical School up in Duluth. And previous to this meeting, I sent around a link to the Metro Doctors journal. It's the Journal of the Twin Cities Medical Society, and there's an interview in there with Dr. Owen that where she answered a lot of the questions that we have raised over the last couple of months. So I encourage you to look at that Metro Doctors article, that interview. It really contains much of the information, a lot of the information that is of import to this committee. With that, I will turn it over to Dr. Owen. Welcome.
Ashish. This is a slide that you already have seen. I want to point it out today, though. I think this actually happened yesterday. Dr. Joy Neihart and I worked together in Alaska, and we are connected in lots of different ways, including this woman. So it's been a pleasure to see another Native woman in Congress, particularly in this case, an Alaska Native woman. And we happen to know that she's an excellent choice for the job. I also will say, as an Alaska Native woman, it's refreshing to have someone in office who doesn't claim to be married to an Alaska Native woman. So, which if you know anything about Alaska politics, you know that that seems to be a trend. So maybe marry a Native woman, I don't know, but in any case, it's a nice change. Next slide, please. And goodness Chief for your work with these slides, by the way. So growing our own Indigenous health workforce. I am, as was stated, the Associate Dean of Native American Health at the University of Minnesota Medical School. As Dr. Dawn Warren has pointed out many times, we have a dearth of health professionals who are Native American, and particularly those working in academia. I am one of now two, since he left his post at the University of North Dakota, he'll speak to you tomorrow, Associate Deans in the entire country, Associate Deans of Native American Health. That's how short, or that's how grand our problem is. I want to thank you for inviting me to speak, Dr. Erlanger. I don't know if everybody is aware of this. You might be or you might not, but when I came back to, let me back up a second. I came to Minnesota from Alaska to go to medical school here. And I came here because this program is noted at Duluth, specifically at the University of Minnesota Medical School, for its work in creating a workforce of Native American physicians. I then went back, which is what I always wanted to do, to work for my tribe for 11 years. And I did full scope family medicine at that time, delivering babies and working in the ICU, working throughout the hospital, and also working in clinic. And that's where Dr. Neihart and I came in contact with one another, probably more than she wishes, but it was great to work together. In any case, then I came back to the University of Minnesota to teach medicine because I was burnt out of every sixth night of call, and also because we were not addressing those social determinants of health. Even in my own tribal clinic, and we're going to talk about what that looks like for tribally run clinics, we had a corporate model, and the leaders there insisted that I just get back on that rat wheel and keep running, despite the fact that I kept seeing my patients every couple of weeks and knowing that I'd never address the problems. And we were not investing in community, as our previous speaker mentioned was so critical, and which I'll emphasize as well. So I came back here to work at the University of Minnesota, and one of the first things I did in trying to find research on the social determinants was look around the web, and I found quickly Dr. Erlanger's, I'm probably killing your name, Dr. Ed's treatise almost on social determinants of health, an impact they had on communities, not just Native communities, but all communities. And I couldn't believe it. Here was a State Department that had as its leading document, or one of its leading document, all the things that we knew as people of color, as impoverished people, the things that really impact our patients, the 80%. In 2014, he probably wrote it earlier. So thank you for that work. Thank you for everything that you do. Next slide, please. Put this slide in there to emphasize why it's so important that we be represented in these decisions on these committees everywhere that you're talking about our populations, because we're different. People talk about inclusion, and that's great. But what's really important to us is that we get recognized, that people recognize, as I heard this morning, you did, that we have our own ways of doing things. Not all of us, these are generalizations, but lots of us do, lots of our communities do. And this is a picture of my community members dancing over our regalia that's just been returned from the Peabody Museum. And it was returned because of NAGPRA, the Native American Graves and Repatriation Act. Our At'u is our regalia, and it's part of us, it's our ancestors, we're bringing it back to life. They're with us again. And this, it's called animism. We have a belief that all things are related and all things are alive around us. And it's pretty cool, because if you're related to the animals, the trees, everything else, you're less likely to do them harm, for one thing. The other concept is related to one another. So everybody in this room is related. So we're less likely to do harm to one another if we're related. So it's important that we be represented so that we can convey that. The other factor I want to point out in the importance of our being here is that people still, as I heard this morning, people in this country don't even know that we exist, despite the fact that we are on our lands. And I forgot to say thank you to the Shakopee Mdewakanton Sioux community for allowing us to sit here today and do this work on your land. Miigwech, Gunischish. I work in clinic still 1 day a week, and I had a complicated OB patient. So I called up the OB-GYNs in our town that we work with in Duluth, Minnesota, and said, hey, can you help me out with this? I'm so-and-so, I work at this care clinic that you consult with. And I could hear her processing in her mind who I was, who the patient was, but she looked up the patient and then she said, and it was not maleficent or in any way badly intended, but she said, oh, that's from that native clinic over there. And again, nothing bad about what she said, just that it made me realize how we are those guys. We are not connected to the rest of this country. Our country, we're those guys. That's why we have to be here. That's why this is so important. Next slide, please. And I'll just point this out from my favorite author, white author, Sir Michael Marmot. He's an epidemiologist who has worked a lot on social determinants of health and did the seminal Whitehall studies in England that showed the connection between socioeconomic status and also just status in general and health outcomes. And he points out that, we've talked about this in this meeting, if you don't have autonomy, you don't have control of your life, you don't have good health outcomes. And that's what it is. That's what's going on in Native communities. It's poverty, it's education, it's all these things tied together that create a system where we do not have autonomy. We don't have control, and this impacts us generation after generation after generation. Next slide, please. Thank you. Other reason that it's important that we be there, besides having control over our lives, besides letting people know that we exist, is to address the bias and stereotypes. This is by Pumala et al. She's a South Dakota researcher, and this is a 2016 study where she tested for bias among emergency room physicians in the upper Northwest. And you can see here that when she tested for bias, there was a strong preference for whites among those emergency room providers. Now, we all know this, but what really struck me is that this carried through for our babes. They even had a strong preference for white babes over our babes. If that doesn't hurt, if you're in this community and people are telling you that they would rather take care of those babes than your babes, as was stated this morning, you get angry. It is hard not to be angry. Next slide, please. Thank you. So representation matters, right? In this instance, in many instances. And you can see here, we're that 0.3%, that thin black line among physicians. Next slide, please. Thank you. If you look at the top on the men and the top on the women, American Indian, Alaska Native, there's 13 up there for women, and this is 2022, and 13 down there for men. So 26 total out of 20,000 physician graduates every year. 26 out of 20,000 physician graduates every year. How can that ever be acceptable? We're not going to change things until we are part of the system that impacts us, and yet we can't be there. Next slide, please. And I put this slide on there to show you it's not changing, it's getting worse. These are our applicants to medical school, 1980, 0.4%, 2016, 0.2%. Next slide, please. Matriculants, 0.4% to 0.3%. This has not changed. It's something that we talk about amongst the Association of American Indian Physician colleagues. It's not changing. Next slide, please. This slide, is an article that shows you that our dentist colleagues share the same. They primarily take American Indian, Alaska Native providers we know tend to go back and serve our communities, but yet we're underrepresented. For the dentists, it's by 0.7 or 7.4 fold to meet the need in our communities. Next slide, please. And this slide shows you that we are underrepresented in all health professions. Next slide, please. What I want to have you take home with is that everybody are oftentimes I hear, well, if we just help them in medical school, it's not the problem of being in medical school. Once we get there, well, once we get to the door, we know our acceptance rates are pretty close to those of all other populations. I have one slide that I didn't include here that shows we're actually better at getting into medical school once we get to the door. The problem is that we're not getting to the door. And this slide helps show why. And this is a pretty, when you look at that 74%, these are high school graduation rates. I want you to realize that we've talked a lot about the differences in communities. In Duluth, Minnesota, where I live, the high school graduation rate was 50% pre-COVID. Now it's down to 41%. 41%. 25, someone was doing math yesterday, 25 in each class, there's about 25 Native American high school students. So that's 12 of those, less than 12 of those that graduate. Of those, we know about 40%. So now we're down to 12, and that's generous, go on to college, right? So now we're down to less than 6 go on to college. How many of those are going to go on to a health professions program? You can see where the problems start. And the 50% in Duluth is not unique. Someone pointed out yesterday that this state prides itself on its health outcomes. It also prides itself on its education outcomes. It ain't so great. Next slide, please. So you've heard about this many times by now, doctrine of trust responsibility. It doesn't just apply to medicine, it also applies to education. We were promised education and we ain't getting it. You can tell because I'm saying ain't. Next slide, please. Thank you. Anybody heard of the Human Development Index? Yeah. So there is a brilliant economist who worked for the World Health Organization named Abu Ahak. I'm sure I killed his name, but he is a hero to me. And he at one point said, I think it was over probably 20 years now, said that asked the question, why are we only measuring the status of the country by its gross domestic product? Why don't we look at the health of its people? So he made a formulation that was made up of access to knowledge or education, standard of living, poverty, and lifespan. And you can see on here how we fare in this country. This is from 2010 statistics, Native Americans at the bottom on the Human Development Index at 3.25, I think. Sorry, that's hard to read. You'll get all these slides later. What's also important to remember is that that is a slide, a composite of Native Americans across the country. So in some areas, like where I live, where Dr. Warren lives, it's much lower. It's down to 2.5, I believe. Okay. And we're going to go through these and talk a little bit about those social determinants of health, but we're going to try to run through them because I know we're short for time. Next slide, please. And you've heard some of them. Thank you. Educational systems. Next slide, please. So this is how Native Americans fared in the educational system, those graduation rates, how well we're doing from 2005 to 2016. It has not improved, as I just mentioned to you. Next slide, please. So why is that? And here's that Minnesota slide. Next slide, please. I was once told by a dean when I came to this work at the University of Minnesota that Native Americans, she actually said to me as we were sitting there, Native Americans don't value education. Well, we do value education, but we have a little bit of a different view of it for obvious reasons. What's important here is that to think about is there are lots of important things to think about, but one of the things I want you to think about is that 1920, 80%, up to 80% of our kids were in boarding schools. Imagine what that might have felt like for those kids once they got done with boarding schools to go back to a community, oftentimes not their traditional community where their parents knew how to harvest and work off the land, but a newer community where their parents were struggling to figure that out, as well as struggling how to make do with all these other ways that have been imposed upon them, right? Not their traditional ways, which they're now told are substandard. So the kids go back to that. They don't speak the language. They've been forced to learn English, so they can't communicate well with their families. They didn't learn how to raise children, right? They didn't learn the basics of of maintaining a household, and they do like young people do. They get together with other young people and they have families. So there's a family now that probably is going to be dysfunctional. They don't have the skills. They haven't been taught them. And they go on to raise another family. And it goes on for generation after generation. 80%. What does that do for our community? Next slide, please. One of the things I was hoping that Shakopee told about today was what they have been doing. But I'll get to that in a second. First of all, you should know that our history is not taught Most of you don't know. I heard it this morning. You don't know anything about us, right? You're not alone. I teach at medical schools and none of the students know anything about us beyond Wounded Knee. Most of in 1890, Dr. Warner corrected me one time on that one. Most of them don't even know that, but they certainly don't know that we are here as representatives in this room in professional roles. Very much part of our culture still. Nobody knows about us. Shakopee is trying to change this. And they have started an effort to create textbooks to spread around the state of Minnesota and hopefully other areas to tell the real history of who we are. So there are good things happening, and that's a definite area that could be supported. Next slide, please. Economy, next slide, please. Talked a little bit about, our previous speaker talked a little bit about this. Look at our income levels, how they've actually dropped from 2005 to 2016. Next slide, please. Why would that be? Why would we have such problems in our communities and in urban areas? Well, for one thing, we got the worst land. Anytime we had good land, it was taken back, like the Black Hills. And then some of us were relocated into urban areas where we were promised, I didn't hear this said today, but we were promised education and those jobs and housing that never was delivered. So go figure, we have our feet, we're on our knees again. Next slide, please. Then good old termination for some of those reservations that we did have, where people were pushed off of that land. All those trust responsibilities were taken away. Next slide, please. Thank you. Here's just the impact on the Menominee, what happened. So dropout rate increased to 75%. They had no way to support themselves. Their land no longer belonged to them. They couldn't do the community ways that help keep them alive. Next slide, please. And then finally, we all know that right now in this country, for anyone, our wages are not keeping up with inflation, right? We have some areas on reservation lands and in urban areas where it's so much worse than that. Half of our country, the previous speaker talked about, I don't think I agree with her on the poverty rates or what was being implied, but our poverty rates are at least 50%. If you look at what is called poverty in this country, the poverty lines do not support anybody in this country. So actually, I think half of our, and I've heard other people say this as well, half of our community is on their knees. And I feel that when I'm in clinic. Half of the people I see cannot survive, are not surviving. So the fact that they made it in to see me is quite miraculous, oftentimes. Next slide, please. Healthcare systems, next slide, please. So there's our health. We all know the latest statistics showed our men at 62. Thank you for asking the question about men. Definitely should be part of the conversation. 62 years of age for our men, lifespan. All of us in here know how many men are aware of the impact that this factor has had on our men. Our men die young. Our elder men die young. Next slide, please. For a lot of our communities, by the way, our men are the uncles and they raise the men after them. So they play such a critical role in supporting our communities. I think most of you are probably aware of this, but COVID impacted us. It's nothing new. H1N1, same thing. We died at 4 times the rate of other populations. Next slide, please. Thank you. And this is more about the mortality. This one just came out, or this one came out in 2019. Next slide, please. And again, you can have these slides after. I want to, you guys you have heard this said already today. You recognize the underfunding of the Indian Health Service. There's a lot of bashing of the Indian Health Service going on here. And I have frustrations with the Indian Health Service, but that's what we got. We got the Indian Health Service. If we don't have that, we don't have the Indian Health Services, how likely is the government going to continue to recognize the trust responsibility? That is a real fear. So should it be better? Yes. But you know what should also be better? HHS. Who does our IHS respond to? They respond to HHS. So when we beat up on our IHS folks, some of whom are my friends, I get it. I'm frustrated, particularly with PIMC as the recent president of, I'm the immediate past president of the Association of American Indian Physicians, and we were mad about PIMC. And we asked the same questions you did. What is going on? And what is this ACOG business? So I'm so glad that you're asking that question. What is this ACOG business? Where is that report and why is that not transparent? Why are we not seeing it? So yes, absolutely. We need to see those things, but who do they reply to? So I love that idea that to elevate the head of IHS right next to the head of HHS. It has to be done. Next slide, please. The impacts of underfunding, you can see the vacancy rates. This is a slightly older slide. It's from 2018 GAO report, Government Accountability Office report. And in the IHS facilities in our Bemidji area, the physician vacancy rates were up to 46%, almost 50%. So IHS reports these a little bit lower. I don't know. I'm a little skeptical. When you have these kind of numbers, how did they go down that fast? We know the vacancies are probably still there. Next slide, please. Thank you. One other component of that system of healthcare that impacts us is persistent racism. I don't know a single Native American who doesn't get anxious about going to an emergency department. I've talked about this with my colleagues thinking, am I just off base here? I once had to get up in the middle of the night while I was living in Duluth to go to the emergency room because I have typical dental care and I was having pain. And I was in the back room getting ready and I heard my husband yell out to me at the same time I was thinking about it, get dressed up nice, babe. Because he and I both knew if I didn't, what that would look like. We do not like emergency rooms in general because of the racism that I talked to you about earlier. Next slide, please. So all these social determinants and all of this history, it is a cause for our health disparities, but it's also a part of our recovery and a part of who we are now. And I want to talk a little bit about what it looks like in our communities. Next slide, please. But first we have to make sure that we clarify so that there's understanding. I heard somebody wisely say this morning, we can't just look at and ask ourselves, why are they like that? We have to look and say, why, what happened? Trauma-informed care, what is in the past that contributed to the presentation we're seeing today? And Roxanne Dunbar Ortiz, my favorite Native American author on our history, points out you can't view poverty and social dysfunction without examining what led to these conditions, particularly the impacts of colonization. You have to look at our history to find out what's going on. Next slide, please. And historical oppression, you are all aware of this. Your document is brilliant. Next slide, please. Here's the piece that I think you will relate to. This is American Journal of Public Health 2014, so now about 6 years old at the very least. Or I mean, sorry, 8 years old at the very least. But look at those numbers. Our American Indian to Alaska Native ratio to whites of our 1 to 4 year olds, unintentional injuries, 2.88, three times that of white kids. Homicide, 3.5 times. So one, the trauma that happens immediately to our babes, and two, the trauma that happens to our communities when this happens. We have small communities and we are interconnected. So the repercussions of that are tremendous. Next slide, please. Suicide rates we've talked about. Next slide, please. Missing and murdered women. I have just thought about this not too long ago. I have at least 3 cousins who were murdered, homicide victims. This is not an uncommon story amongst us. Next slide, please. But there's good. Thank goodness there's a little uplift at the end of this talk, huh? Healing with culture, Dr. Chandler was already mentioned. The other researcher you should know about is Dr. Walls, Melissa Walls. She does research in Boys for It and connects the healing of culture connected with diabetes. She's also a co-director with Dr. Warren out at the Johns Hopkins Center now of the Center for Indigenous Health. And their research both point to the fact that when you bring in our culture, when we have our culture surrounding us, our health outcomes improve. I have a little debate going with a colleague that I think there's there is also a component of autonomy, the fact that we're running those programs ourselves. But nevertheless, we know how healing our culture is. Next slide, please. This is a slide, an older slide as well, of the impact of what's it called now? I'm forgetting what the program's called, the diabetes, it's our diabetes program that was started probably in the 80s, maybe 90s, but anyway, it was started to address the fact that we had high renal failure because of diabetes. And so in our clinics, we started programming where we would all come together. We already tend to work in teams in our clinics anyway. Remind me, I got to talk about our clinics too. And addressing diabetes altogether. So when patient come in, if we found out they had diabetes, we'd be hitting them with the latest and greatest medications. We'd be addressing their dental care. We'd be addressing their foot care, all of that all together. And as a result of that kind of programming, we were able to significantly decrease end-stage renal disease. Next slide, please. Land back movement. This is a powerful movement. It's not literally us asking for our land back. It's asking for people to recognize the power, and it's for us to regain the power of our culture, our language, all those things that are happening now. It's a very exciting time, actually, this decolonization movement. Thank goodness. Next slide, please. And as we heard already, recognition of the impact of boarding schools on us. If you go to Canada, they have done terrible things to their people as well, but sometimes I think that there's such power in that truth and reconciliation movement that they are going through that you wonder about the impact of it here. How much could we do here with it? Next slide, please. And I don't know if, have you seen this, Ed? Have you seen this one? It's pretty cool. It's from I have to always look, I wrote this up there because I can never remember what ASPE stands for, Assistant Secretary for Planning and Evaluation. This is a document that just came out this year in April. And it really talks about how, when you address those social determinants, how you can improve health. And some of these ideas are kind of radical. That's why I love this when I saw it. For instance, so you don't need to convince HHS. This document already exists within their department. Shows that if you give people housing, people with chronic disease housing, hey, they do better. Go figure, right? If you give them food and nutrition, they do better. If you hit these social determinants, they do better. Next slide. So that's the prelude to recommendations. Next slide, please. Lots of recommendations. I tried not to repeat them, but some great ones were said today. And so there might be some repeat on these. Prioritize health of Indigenous. Within your number 1, prioritize health of Indigenous mothers and infants. Prenatal care supports. I think I did hear that you might have all these. I just didn't see them. Not only transportation, but daycare, providing meals. And here's the crazy one. How about paying people to go to those? Because people often can't take time away from jobs. That's why people don't come see us oftentimes for any clinic appointments. They can't take time away from the job that's keeping a house over their head, right? Improve living conditions, and just near number 2, improve the living conditions of Indigenous mothers and improve access to high quality healthcare. Treatment of, when I was working in my home clinic, oftentimes when I was trying to get a patient into treatment, I can't tell you the number of times I heard this. We don't have an option open right now. We don't have a slot open right now. You're gonna have to wait a month. Well, they're not going to need me in a month. They need me now. And think about those young Native women who could become pregnant and they want to stop using, or their partners. We need those treatment options now, anytime they walk in the door. Baseline. And not only cultural treatment options, I heard that yesterday, of course we have to have that, but how about treating our entire community? Because we know if you treat someone for 6 weeks, that's not enough. If you treat them for 6 months, that's not enough. And if you only treat them and not their family and not the people around them, that's not enough. Mental health services times 100, and I'm not joking about this. Pre-COVID, we did not have enough. And it's not just for people who are using substances. I just told you about the impact that the history has had on our community. We have mental health needs, and we don't have counselors. I almost don't like to diagnose or look for depression these days. I said I do in my patients, but we don't have services for them. So you diagnose them and you give them a medication because that's all you got, and you suggest they exercise. And I often will refer them for traditional, to meet with traditional people who also are already overtaxed. We need counselors. Collaborate with Department of Education, include accurate and current Indigenous stories. This is supporting programs like the Shakopee Mdewakanton are doing with that history book. Help us get that information out about who we are. Trauma-informed care training. We heard from IHS yesterday that they're doing this in some areas. All providers who come across our populations, any of our populations, need to know trauma-informed care. Investing in our communities, we heard this said today, and it can't be overstated. We want to live on our traditional lands not because it's the best land, as you've heard, it's oftentimes some of the worst land, but that's where our communities are. That's where we're doing our stuff. That's where families gather. Support those areas and give us some economy, some ways to do that. So how about, we heard about the numbers of people who are waiting for doula training on doula training list. How about, what was that, 200, some crazy number? Help us pay for training in our communities. Our people there, let's invest in those communities by paying for those trainings. Decrease our reliance on grants, same thing, help us build capacity. I've heard of research project after research project that comes before me when I'm on the IRB for the Fond du Lac Nation, where they just want to do the grant, but they don't think about building in our community. One of the things we ask is, what are you going to do? Who are you going to pay in our community? How are you going to invest in our community? That's what we should all be asking. You come to us, how are you going to help us? This is one that I'm going to talk about in a second. Fund academic and tribal health residencies and collaborations, i.e. the VA system. The VA system is able to work with academic centers throughout the country and have great residency programs and different collaborations that serve to increase the number of people serving their communities. We need the same with the IHS. And then as we talked about, continue to demand transparency from HHS and IHS, especially regarding PIMC and ACOG. Next slide, please. This is an article, this refers to those collaborations between IHS and academic centers. This is an article that I wrote, just a opinion piece that I wrote along with Matt Toby up there and another a student about the lack of these collaborations that exist for IHS, even though they have tons of them for the VA. There's no reason we can't do the same for the Indian Health Services to improve our workforce. Next slide, please. And then ICWA. I heard someone say today that one of the reasons, or yes, I think it was today, that one of the reasons or one of the fears that our patients have when coming to the hospital or coming to our clinics is being reported or having to deal with the system. If you do nothing else, please help us support ICWA. We have to have ICWA alive. You can see the statistics here. Our children are moved higher from our families than any others. This is a travesty. Without ICWA, we return to the days when we lose our children, and the repercussions are going to be amazing. And this is coming up before the Supreme Court this next year, I believe. So please recognize the critical nature of ICWA for Native families and all the long repercussions of it. Next slide, please. This is a project that I started. It's called iHeart, which is Indigenous Health Education and Resource Task Force to address workforce shortages. I talked to you already about the fact that our kids are okay once they get to medical school. Most of them will get in. We have good numbers there. And it's the same with the other health professions. The problem are that K through 12 and even prenatal, we don't have enough of that support. So iHeart is an effort. The other problem that arises is that excuse me, schools like mine attract people from all over the country, i.e. Alaska, to come. And then what do? We go back to Alaska. So we end up with shortages in this Bemidji area of the 46% that I showed you. So how do we change that? We create regional pathways programs. So iHeart is working with Association of American Medical Colleges, the tribal colleges, Association of American Indian Physicians, and Native American medical students to develop these regional pockets of pathways programs from actually prenatal up through practice. Or as Dr. Warren says, up through postdocs. Next slide, please. Those are the objectives that we have and the goal. Next slide, please. And here are those aims, the regional infrastructure. Now, I was just talking with someone, Norma Pohl, who works at the AAMC about this project and feeling kind of a little flustered because you can imagine how big this task is, right? Because you have to connect people who have no time, like all of us, So they have to find time and admin power to support these regional structures where we'll develop curriculum, we will support students coming through the pathway from kindergarten all the way up through postdoc or into the professions. And we will develop databases where students can find out about scholarships, training programs, all that. It's huge, this effort. But here's the thing. 20 years ago, I complained to my mentors then that we were all cherry picking off the top. We're all pulling students into medical school from all over the country. We're all competing for the same bunch of students and not addressing the K through 12. And I heard then, and I continue to hear it today, that's not, there's no return on that. It'll take too long. If we had started 20 years ago, we'd be so much further ahead. So even though this is big and hard, I'm convinced this is the way that we need to go. Next slide, please. Next slide, please. And this is just a gross schematic of what those pathways could look like. So within the regional hubs, each of them will have K through 12 health professions, involvement from all of these. We've had 3 summits. The last one was in Washington, D.C. in July. And we had a great turnout for that. People are really excited about this work because we've been talking about the problem forever, but this is the first time we're actually coming together to try to form some solutions. So if any of you know funding, we're happy to hear about it. That's going to be the big piece, is funding people to have the time to develop these programs. But we definitely, I think a recommendation is to support something like this, a program like this. Next slide, please. And we're at the end. Next slide. Yep, that's it. So thank you.
Thank you, Mary. I really appreciate it. Let's say we have time for a couple of questions. Any questions that people might have?
One thing I wanted to address, I forgot to mention this, and Dr. Warren and I were sitting back there on our hands, just dying to answer these questions about the structure of the Indian Health Service. In 1975 and 1976, the Indian Healthcare Improvement Act and the Indian Self-Determined Education Act were passed under Nixon, of all people. But basically, they recognized the importance of autonomy in our communities. And so with that, we were able to start assuming care of our own healthcare facilities. So as of today, underneath those 2 acts, 65% of our government or our tribes now run their own healthcare facilities. 65% of them are what we call compacted. And there's a difference between contracted and compacted. And Dr. Warren, I think, is going to get into a little bit more of that detail when he speaks with you. But contracting is when we just start to take over some of our healthcare facilities, some of our operations, but compacting is when we fully take over our own healthcare care, the total sum of our healthcare. As in Alaska, we're the only state that has completely compacted all of our healthcare. And yes, it would be obviously great for the other states, but that is no small feat, as you can imagine. But
Speaking of the Indian Health Service, what's the total budget of the Indian Health Service, and what portion of that budget actually goes to health care?
Why are you asking me that? So
because you brought it up. You brought it up.
I want to say
my
it's
guess.
12. I think it's 12. Is it 9 or 12? No. It's just been increased. It's at least 9 now. It was increased to 9 last year. I'm pretty sure. We'll have to look it up to be sure. But how much of it goes to, we need 48 billion to become on par. That was the latest by the National Indian Health Board. I think they're on here so they can correct me if I'm wrong. 48 to get to where we need to be to adequately care for people. How much of that is used for healthcare? That's a good question, because all of us keep asking to do other things with it, right? All the time. So I guess my only point on that one is that if we have complaints about it, we have to go above the IHS, because that's who funds this. It goes through HHS and then goes through our president, right? Yeah.
Sharonda.
Hello, Sharonda Thompson. A couple questions. One, do you have more data on the cause of the lack of high school graduates? And 2, when you say you need more counselors, are we speaking of American Indian, Alaskan Native counselors, or more counselors trained to be sensitive and understand the cultural history of American Indians and Alaska Natives.
That's just like in the health professions, it's both. We'll never have enough Native doctors, right? So we need to train non-Native doctors how to adequately care for our population. So it's both, but yes, we absolutely. I have had depression since college and it got worse with residency and have needed a counselor, have never been able to find a counselor who has a clue of how to talk with me about needs. So finding that for my patients, yes, it's huge. Regarding the data on, what I was trying to point out here, and I didn't do a very good job of it, is that the social determinants of health are the social determinants of education. They're all related. So that poverty, the fact that half of us are on our knees, kids are going to school without enough food, they're going home to inadequate homes. How many of us are living without housing, multiple family generations, so attending to your homework? And then the schools, we don't see ourselves in the schools. We don't see ourselves in the teachers. We don't see ourselves on the walls. We don't see ourselves in the history. And discipline. I have a slide that I use for my students on discipline. We, like African-American students, are over-disciplined. In Duluth, I don't have the stats on me, but it's ridiculous. In fact, they've been called to task on it. And of course, they're addressing it under the carpets, not with transparency. So those kind of issues they just multiply. Yeah.
Where do tribal colleges fit in?
Tribal colleges are part of our HEART program, and I believe that they are critical to everything we do because our students tend to, in generalization, want to work closer to home. We are tied to our communities again. So those students generally want to be around where they have the support. So they are likely, those students, to me, in my mind, and I don't have the data behind me on this one, are likely to return and work in those same areas. So they are critical. Not only that, but a lot of our tribal schools know how to do it. A lot of them are not operating fully, like Fond du Lac is incredible, not operating fully in a Western model. They don't have this silly hierarchy that we seem to like in Western world, right? Much more equal between professors and deans and all that other stuff, right? So they're an incredibly important part of the puzzle. I saw another
Dr.
question.
Peck.
There. Yeah.
Thank you, Dr. Owen.
Mhm.
I want to tap you as a modern elder to elder at the moment. Those of us who have been doing this work
Speak
for
for
a really long
yourself.
time.
Jeez.
It's okay. It's a place of pride. We heard from our previous speakers about the birth of the National Council of the Urban Indian Health being in 76. We heard the National Indian Health Board from Stacy in 1972, that we're about a 50-year time. We also heard from you in statistics that nothing has changed in some dimensions around the data that you gave. And I was wondering, what makes this moment, for those of us who've been doing this a long time, what makes the 50-year moment, what is possible now, as opposed to incremental change? What is possible that's transformational now? And how can we, focusing on women and children, families and fathers, how can we be part of that strategic moment of now with urgency? So I'm just trying to figure out what makes this time different. And I thought for someone who is sage, and that you might give us some wisdom.
Well, let me just say that I have more hope now than I have in a long time because of
Can you hold that up?
I have more hope than I have had in a long time because of the decolonization movement that's going on and the movements like the land back that we're seeing that we've never seen. And the fact that we finally have a show on television, Reservation Dogs, that represents us, that looks like us, right? Not these silly stereotypes. So there are things that are happening that give me hope, for one thing. And also the fact that Dr. Ellinger was able to get you all to finally meet on tribal land. Things like that are critically important. It's hard to hear about how many people don't know about who we are over and over and over again. I'll give you that. So the testimony this morning was good, but it's also really painful for some of us. So what can you do today? You can help us. You can help Shakopee. Well, Shakopee doesn't need a lot of help, but you can help movements like Shakopee, help them spread that information about who we are in our textbooks. You can go to your school districts and ask, you can go to Juneau and say, where is our history about Native people in this school? You know, enough of just having our art on the walls or our art up throughout town to attract the tourists. Side note, sorry. But, you know, you can help us in those ways. You can help encourage others to learn more about us all the time. And we talked about the recommendations. You know, there are concrete recommendations. HHS should be working with the Department of Education to support a program like iHeart. You can support Indian Health. You can advocate that the Indian Health Service finally be fully funded so that they can do what they need to do. You can advocate that it have more power so that they're not having to hide and get beat up on Capitol Hill every time we turn around, and that they're able to say and be transparent of what's going on. There are lots of different things that you can do. Lots of different recommendations. Go ahead.
And thank you for helping us make that happen. So words become deeds and we fulfill our responsibilities. Thank you.
Yeah, we go ahead.
Marie, did you have a question?
I think Colleen was first. Dr. Malloy.
Okay, I'll go first. The education piece I think is really interesting, and I feel like with the school closures that's happened with COVID-19, the children, there was a lot of negative ramifications for children with school closures. And it's in an urban setting in Chicago, I mean, kids were kept home from school for almost 2 years, and that's time that they'll never get back. And I think it was very, very negative, and we're still seeing so many ramifications of that. So I imagine, is that the same for your community with like schools being closed? Like, where do all those kids go? Like, what happened to it? And I think in thinking about this issue, if you had more independence in directing your own school and saying what you want for your children of your community, if you want them to go to school versus the school being completely closed, because at least in Chicago, that kept, you know, what you're saying, meals were left out, and kids, sex abuse and physical abuse skyrocketed in children all across America with school closure. So I don't know if you had any thought about that, or like when you look at the negative statistics of graduation rates, is it going to be even worse when the data comes out for the past couple of years, do you think?
Well, it is worse. That's 41%, went from 51 to 41% for Native kids in Duluth. It got worse over the COVID years. Do I think that they shouldn't be going to school as a doctor? That's a really tough one, but how do we make it equitable if they're not at school? Like you said, if they're at school, they're getting free lunches, right? So how about getting those families the lunches and the food they need so the kids can be at home? How about getting the broadband so those kids can, at least in urban areas, don't get good broadband coverage? We're starting to get it more in our rural areas, but it's not, we're not in our urban areas. So there's all those other structural issues that are impacting our kids that are not being addressed if you, whether you leave them in school or take them out of school. So if you don't have them there, you need to support them even more. Jackie Dion said this well yesterday. You need to give, you know, it's about equity. In our community that's been so hit by trauma, we need more resources than ever, right? And that's what you need to think about anytime any of these things happen. They're not affecting us equally. They're affecting our community that much more. I don't have a question of, thank God I don't have to sit in Fauci's role or anybody else's role in deciding whether or not kids should be or should be out of school. But if you're gonna, either way, you need to think about the repercussions for communities like ours. Go ahead.
One more question.
Thank you. Thank you for your passion and your action forward presentation. Very much appreciated. Marie Ramos, Family Medicine. So my question in thinking about practical applications to the intersection between the 80% of life lived outside of the medical home, which contributes to our patients' well-being. And one of the questions that we brought up yesterday was workforce and pipeline. We discussed that a striking number of Native families are in homes that are single parent homes. We also recognize, and it's been discussed, that there are typically multiple generations living in homes that are inadequate. And so I'm behooved to think that on average, because of these external stressors, kids have to grow up quickly, and they probably have to think about how can they contribute economically to the livelihood of their family and their home. So that's the background. So in thinking about pipeline and how do we help to encourage students, and for that matter, family, to prioritize education in the long run, have you seen, or do you have any examples for the committee of programs that can help bring both introduction of needed services, and we're going to talk about maternal child health here and families. So needed services that may be able to leverage non-certificate roles, right, for the community members that can pay and also encourage families and children and those of childbearing age to continue along that path. So multiple kind of layers there, and I offer you to pick whichever layer you want out of that question.
Well, first of all, I don't know why it has to be non-certificate. One of the things we need to do is invest in our community. So pay people to get those certificates. If you are going, but there are programs that exist. And when I say pathway up there, I'm referring to pipeline. A lot of Native people don't like the use of pipeline because of what it's done to our communities. So that's why the pathways means the same thing. But there are a lot of pathways programs that do just that. We recognize the impact of family and others around a student that needs to be involved. For instance, we have been awarded for a NARCH grant, which is Native American Research. I forget what NARCH stands for, but essentially we're working with our medical school is working with the tribal college to support students making it through the tribal college and then successfully matriculating into the local UMD science school and then onward to either research or into our medical school. Now, the components that we put into that grant include supporting funds or supporting families joining us at every single meal, every single event. We also have components of teaching the family what it means to have their loved one go through education. It also means providing transport support, providing all the books, providing the computers, supporting all members, but particularly as to your question, supporting all members of the family to help the student succeed. It also includes monies to pay for a traditionalist to be part of, to hang out with the students, because that's such an important part of our community. And the traditionalists also oftentimes will work with their families as well. They just know them, they're part of our community. So there are all those different facets, and that's the reason that we need to lead this program when we know those things. Those are just part of who we are. I think that starts to answer it. Really, again, critical to find ways to get that money to support the economy for those communities. Thanks.
Dr. Rowan, thank you very, very much.
Yeah,
This was very, very helpful. What a morning. Do you think we can have lunch in 45 minutes? If we go to different restaurants, that we don't all go to the same restaurant? I would like to have us back here in 45 minutes. We have so much, and I really want to have a lot of time for conversation, because it's these conversations, the questions that I raised that are really, really crucial and really helpful. So let's come back here at 1:15 Central Daylight Time. And if you find some of the presenters who were here and you could join for lunch and have a little conversation, that would be great. So we'll see you back here in 45 minutes.
Okay, maybe not. But before we officially get started, I just wanted to share with you is that okay? It doesn't feel like there's a big difference when I'm standing here, but okay. But before we get started, I just wanted to share with you something that happened very serendipitously. As I was coming downstairs, coming into this room, thinking about how we set the tone for the next session that's about to start, I ran into these wonderful, amazing ladies who are coming out of a First Medicine conference down the hall, put on by the Indigenous Peoples Task Force, which we should all learn about because they do STD work. They do, it sounds like they do an amazing job with health care. And I asked if they would be able to share this honor of being present with us and share a song with us. So I'm going to pass the mic and let them introduce themselves. But I just want to let you know that we have said many times that it was, HRSA, the Health Services Research Administration. They moved mountains to be here, but Ed was that big impetus. Dr. Ellinger was the person who really pushed for it, who strong-armed people into it, who probably, I don't know, did you have to like, I don't know, do you have any dirt on someone and it? Thank you. Because you did that, Ed, we are here today. Thank you, Ed.
Ju basway ana kudu ko indigenous cause my ingin doim mashkazibi guy and mama king dunjaba. Hello, my name is Basway Ana Kudukwe. I'm from Bad River Reservation and my clan is Wolf Clan.
Uju and Dinaway Maganandok, Giwada Ne Benesikwe and Dijnakas, Magizi and Dundan, Gawapabignakag and Dunjaba. Hello, all my relatives. I am a Northern Thunderbird woman. My clan is the Eagle clan. I come from White Earth Nation and I'm a descendant of those that reside on Madeline Island.
Buju and Dinaway Maganadok, Awanish Basanukwe Indigenous Kaz, Ganabek and Dudem, Gawababiganakan and Dunjaba. Hello, my name is Awanish Basan, which means the breath of the spirits. I come from the White Earth Nation, from Snake Clan, and me and these beautiful women here today have just spent the last 3 days here with the Return to First Medicines Conference, just right next door to you. And we're out the door. We're just headed out the door. We got grabbed, but we also have been working towards, it sounds like your conference has been about healing. That's my work. I have my own healing practice as well. And so we each one of us tries to bring that out to the rest of the world as well. And our conference was about food sovereignty and healing. So it's great to just drop in here for a minute, and we'll do a song here in a second, it sounds like.
Uju and the way Mani Duk, Mushkane Wase Benesi Kwe Indigo, Makwa Indodem, Mikinakwa Juing and Dunjaba. Hello, my relatives. My name is, English name is Maria Morin McCoy, and I work at the American Indian Family Center in St. Paul. I worked with Stephanie Graves. In 2006, we were working through the Healthy Start grant, Twin Cities Healthy Start grant. And at the American Indian Family Center in St. Paul, we did a really beautiful work there. And we actually were able to reduce the infant mortality rate. And unfortunately, because the work was going so well, the grant went away because the 3 years we had it, the infant mortality rate went down, but that didn't mean that the work wasn't necessary and needed. And so the work continues. It's been a huge disparity in our community, and the support is always needed to help families thrive. And so I work with primarily women and their families, and also the children in the community. So Miigwech, it's a humbling experience to be here. We were on our way out and asked to come in and sing one song. We'll sing the Spirit Bear song. And it's a song about asking that white bear, that big white bear that's in the north, that will be coming out more as the season changes, and will come out and dance with the Northern Lights, our ancestors. And we're calling the spirit of that bear medicine to come in and help us heal. Miigwech.
Thank you. The power of simplicity, as my friend Ken has said. So, Ed, if you want to introduce the.
I have to admit, I was in tears during that song. It was really touching. Thank you, Janelle, for being out there. And this just highlights the fact of where you hold a meeting makes a difference. It really makes context is not everything, but context makes a huge difference. So being here just to allow that to happen is really cool. But now we have another, I mean, every session is just incredibly powerful, but I'm looking forward to this one that Janelle is going to lead. So we're going to be looking at learning from our history in a whole variety of ways. And so we've got 3 presenters who are joining us. 2 of them are here. No, 1 is here in person and 2 are virtual. So I will let Janelle introduce them.
So this next afternoon panel will include 3 speakers from diverse areas of our nation, representing different tribal communities, cultures, and languages, each with their own unique issues, concerns, and strengths, but also unified in a shared experience of Native American history within this nation, rooted in systemic and structural racism. Rhonda Claremont Swaney, past managing attorney and former tribal chairwoman for the Confederated Salish and Kootenai tribes, will share her lived experience as a Salish Kootenai mother. She will be followed by Ms. Nicole Gonzalez, founder and midwife director of Changing Women Initiative, who will speak about special concerns rural and urban Native women have in accessing health and well-being services. Finally, we will hear from Ms. Abra Patkotak from Alaska Native Birth Workers Association located in Anchorage, Alaska. As you listen to the next panel, please incorporate all that have you learned and discussed thus far from the past 3 SACIMM meetings and over the past 2 days. I invite you to ask yourselves what differences have developed over the past 50 years, what remains the same, and what actions will take us into a future where all Native families are healthy. Welcome. You may take the floor, the virtual floor, Rhonda. And we can see you, Rhonda, and you're welcome to introduce yourself.
Good afternoon, everyone. Hassalat. My name is Rhonda Claremont Swaney. I am Salish and Kootenai from the Flathead Reservation located in Northwest Montana, where our ancestral homeland is. Thank you for inviting me. No one's ever asked me to share my story before. Granted, it's 45 years old and I didn't think it would have any relevance today, but Janelle assures me that it has relevance. I hope we can learn from it. Little bit of background about my reservation. There are 7 reservations in Montana. I live on the Flathead Reservation. It's the home of the Salish, Kootenai, and Ponto Rey people. It was created by treaty in 1855. It's a mere fraction of our ancestral homelands. However, we were successful when we negotiated the treaty in the provision that we would have exclusive occupancy. A reservation is about 90 miles long and 60 miles wide. It's 1.3 million acres. It bisects Flathead Lake, and it's still very rural. There are 3 stoplights on the reservation in 2 different small towns. The reservation was opened in 1910 because it was so beautiful and people wanted to live here. It's now 75% non-native and 25% native. My tribe has about 8,000 members, but not all of them live here. The 1855 treaty I spoke of has been broken by the federal government over 200 times. I worked for the tribes for many years. The tribes are the largest employer on the reservation, and enrolled members automatically qualify for Indian Health Service, healthcare. That can be supplemented by tribal dollars, and we have compacted all of the health services at this point in time: Medicaid, Medicare, and TRICARE. Tribal employees are now eligible for federal health care insurance, which they purchase, and the employer pays a portion as well. For those people with only IHS funded health care, excuse me, let me turn that off. For those with only IHS funded healthcare, there is a committee that approves procedures to be done and paid for by IHS dollars and tribal dollars. The committee uses IHS regulations. That is, to be eligible for a procedure, you have to be very sick. That is, be nearly losing your life or a limb. We have very limited clinic capabilities with the tribes, and we have one doctor that's a tribal member, and all of the procedures that are waiting to be approved generally begin getting approved the 1st of October, and then our money runs out very quickly. So people rush to get in there and get treated. There was one individual that I know of personally who had cataracts, and he was left unable to see for about 25 years before he was treated. We have 2 low-level hospitals. Specialty care is located 60 to 120 miles away, depending on where you start from on the reservation. Local hospitals, 2 hospitals, rely heavily on IHS purchased care reimbursements to stay in business. They shift costs. And ERs are used for primary care as well. Now onto my story. As I mentioned, it was 45 years ago. I was 24 years old at the time of my first pregnancy. I'd been to college. I was married. I was working for my tribes. And my husband was a heavy drinker, just like many other men his age. I attended all the prenatal appointments with my family doctor through purchased care. On the 6-month appointment, was a Friday afternoon, late in the day, the nurse told the doctor I had protein in my urine. Said I was fine to go. and he didn't give me any warnings about what to look for if problems should occur. The next night, I developed what they called toxemia then. They now call preeclampsia. And it was my first pregnancy, so I didn't know what was normal, but I began to feel that something was very wrong. About 5 or 6 in the morning, I drove myself to the local emergency room. Because it's rural and there aren't many providers, the local hospitals put doctors who are providers for their hospital on call. And so they're only there on the weekend if there's an emergency. I went to the ER, but the nurse told me that they didn't have my blood type on hand, so they would be transferring me by ambulance to a bigger hospital about 60 miles away. The on-call doctor didn't ever look at me, didn't come in. When I began my trip to the larger hospital, my baby's heart was still beating. When I arrived at my destination, the heartbeat couldn't be detected. I began to hemorrhage heavily. The on-call doctor in the larger hospital induced labor. He told me I couldn't have a C-section because I lost too much blood and I wasn't clotting. I delivered my dead baby and was hospitalized for several more days, given units of blood and anti-seizure medication, and was released without instruction on how to care for myself or how long to wait before getting pregnant again. Being young and thinking it was just a terrible accident that wouldn't happen again, I did learn recently that preeclampsia occurs when there's stress in your life. I want to say that most reservation residents have stress in their life every minute of every day. Just going to work, trying to get equal treatment, knowing that you're a second-class citizen, is very stressful. And you know you're never going to get ahead, never be as good as everybody else. You try harder, but you're never successful. As I was young and wanting to move on, I became pregnant again rather quickly. I was given a high-risk designation because of the stillbirth I had. And I was sent to a specialist about 60 miles away. I chose the same OB/GYN that delivered my first baby because he knew of my problems. I drove 120 miles each way for each 15-minute appointment. He didn't take any special care or any special tests. And one night, right after New Year's, I began spotting and was told by the hospital to drive in. It was January, it was cold and the roads were icy. I remember we slid through 1 or 2 stoplights in Missoula. When I arrived, I was informed that I was in preterm labor and I delivered a little tiny baby at midnight. I was told my son probably would not live until the next morning. He was put in an isolette in the nursery and they gave me something to sleep. My son weighed in at 1 pound, 12 ounces with the umbilical clamp on, measured 13 inches. My husband's hand was bigger than the baby. The next morning, my son was still alive and the doctor decided to transfer him to the University of Utah Medical Center neonatal unit, 500 miles away. I did get to see my son and touch his hand before he left, but couldn't hold him. I was also able to visit him twice while he was in that medical center. I was told that children born as early as my son did not live, and his chances of surviving were 1 in 100. I was asked to sign paperwork promising not to sue the medical center if anything happened to my son because they would be providing him experimental treatment. I learned that I delivered at about 26 weeks, and the cause of the early delivery was attributed to DES syndrome. That is, my uterus couldn't support the weight of anything over 2 pounds. I still don't know if that's true. The only thing the doctors told me was keep trying. Eventually, you'll have one that lives. My son did live. Today, he's a 44-year-old man with severe cerebral palsy, profound deafness, and an intellect that can't be accurately measured. I love him more than words can describe. He accepts his disabilities with humor and grace and lives defiantly to this day. That is, if you tell him he can't do something, he'll find a way to do it. Oh, but what he could have been, what they both could have been. Again, these events happened over 45 years ago, and really nothing has changed. The reservation I live on is still very rural. Providers are not plentiful. They use an on-call system on the weekends. And frankly, Indian people are considered disposable. That's what I felt. That's what I feel today. Although these events happened 45 years ago, I challenge you to think about what's changed over that time. Native women are still at high risk for complicated pregnancies. Our babies die at the highest rate compared to other populations in our nation. Scarcity of funds for healthcare is an ongoing issue, particularly if you go to the Indian Health Service for help. Health literacy among our population remains low. We are deficient in providers in our communities. Many of our people are underhoused or considered homeless or live in a unit that's too small because several other family members live there. Access to transportation and good roadways are still an issue. And through this, I've not even touched on the mental health needs of our community, stemming from intergenerational trauma, endless daily encounters with racism in our communities, violence, and substance misuse. So what has changed in 45 years? Not much. I understand your efforts to bring the problems of Native American pregnant women to the forefront and provide them better care. But I just challenge each and every one of you just to help one person. Thank you.
Thank you, Rhonda Lenmetch. We will now hear from Nicole Gonzalez, and we'll hold questions for the end. Thank you.
Good morning or good afternoon, everybody. She'e Nicole Gonzalez Nisha, Glass Chain Nishla, Dawa Tochini Bushes Chain, Ashkai Soy Desha Chain, Anastasia Deshanella. I'm Navajo from the Navajo Nation. I'm Nicole. I am a nurse midwife. I've been a nurse practicing for 17 years, and I've been a nurse midwife for 10 years. Majority of those years, I've provided midwifery care and nursing care within a hospital setting in a rural area north of Albuquerque. I worked 2 years as a nurse in an obstetrical and med-surg unit in Santa Fe during the time that their OB unit was closing. And from what I saw there, I felt very propelled and bothered and concerned by the care that Native American women were experiencing under the care of midwives and doctors in that facility. Since 2008, I returned to school and I became a nurse midwife to address maternal health issues in my communities because I did not see a lot of Native Indigenous women choosing midwifery as a career path. I'm actually now one of 20 Native American nurse midwives in the United States providing midwifery care in my community. I do not work for Indian Health Services. Many of us have chosen not to work for Indian Health Services because of the racism and lateral violence we experience as healthcare providers trying to serve our own communities. I've been propelled to create this nonprofit organization called Changing Woman Initiative. We've been a nonprofit since 2015. We are currently located in Albuquerque, New Mexico, providing home birth services to Native American Indigenous women in the Navajo Nation in Albuquerque, Santa Fe. We cover about 3 hours distance from our location to attend births, not only in people's homes, but in providing traditional home birth, meaning returning birth to community in a hogan with traditional medicine, with medicine people, with doulas that we have trained. Our services cost about $4,000 per client. It doesn't include midwifery care. Right now, Medicaid reimbursement for global return of care for midwifery care or just birth services $1,500. So if the funds that we provide services to our families covers food. So we work with local farmers to get food every 2 weeks to our families up to 6 weeks postpartum. We pay for traditional medicine body work with healers. We also provide plant medicines and tinctures and teas to our women during their pregnancy. They get a paid doula to attend their birth, and they get a lactation specialist consultation support through their pregnancy and postpartum. All of those services cost $4,000. And so because of what's happening in New Mexico in regards to hospitals closing, like Santa Fe Indian Hospital closed their OB unit in 2008. San Juan Medical Regional Center is closing. Their midwives are having to go elsewhere to provide care. The Phoenix Indian Medical Center has closed their obstetrical units. Las Vegas, New Mexico does not provide OB care. Los Alamos does not provide OB care. Santa Fe has 2 hospitals, but basically the Native women are now required to navigate a very complex healthcare system because their IHS services are not providing care to them anymore, or they're having to transfer at some point during their prenatal care visits. So a lot of the women that I see, especially during COVID, have not received care up to 20 weeks into their pregnancy because A, they can't access a care provider. B, they have to travel more than 30 miles to get access to care, or they have to wait more than 6 weeks to get in with a healthcare provider to get care for their pregnancy. And so when we see the statistics around obesity, diabetes, hypertension, postpartum hemorrhage, Native women not accessing care in the first trimester, increased maternal mortality rates because of car accidents, just trying to get an appointment, it's because these hospitals are closing their labor and delivery units, causing women to have to travel further. But also IHS is not fulfilling their treaty obligations to the tribes around maternal health care and women's health care in general. I have an easy access clinic on Wednesdays where I see women oftentimes who will travel 2 hours to come in for care. Regardless if they have health insurance or proof of insurance, I will see them for care. I'm seeing women who have diabetes that hasn't been managed or controlled for 2 years because they can't get in for an appointment at their local hospital or their clinic within their tribal facility. I'm seeing 14-year-old pregnant young women who've gotten no prenatal care up to 20 weeks because they can't get in for an appointment for their prenatal visits. And they're unsure of how to navigate the healthcare system that they're kind of pushed into navigating because IHS isn't providing those services in their community. I've just recently returned from Sweden, Geneva, and represented and talked about these issues to the Committee on Elimination of Racial Discrimination because clearly this is a problem. When I look at the data, and it's 20 years since 1980 to current, like the maternal mortality rate for Native women has tripled, despite all the healthcare advances that we like to talk about. I'm seeing structural racism impede access to quality care because funding isn't getting where it needs to go. I know that Biden gave $9 billion more to IHS facilities to take care of our health, but that funding isn't getting to grassroots organizations or even nonprofits who are trying to fill the gaps where they are not filling the gaps. And so I work on the front lines. I take care of all of these women who can't get care or have issues with how they're being treated in a hospital setting. I hear stories over and over around their rights as Indigenous people, Native women not being honored in their birthing experience, people still getting episiotomies that they don't need and did not ask for. Unconsented procedures is still an issue. I don't see an apology from Indian Health Services for the forced sterilizations that our people have gone under in the 1970s, which is interesting because it's in all the research that I read, but there's no formal apology about that act ever happening to our people. My concern is like, at what point when we continue to tell our stories of hardship, like who's gonna listen? Where's the funding gonna come from? You know, I'm seeing like Joe Biden, president, talk about protecting our reproductive rights. And I'm seeing these things happen in a high level, but they're not trickling down to the state. And so where is that break happening? And so I just wrote down some recommendations in regards to what I'm seeing. I would like to see a federal mandate within IHS to work with grassroots midwifery, doula, birth assistants to improve maternal health care. A majority of nurse midwives and doctors work in the city. They do not work in rural settings. I think it's great. We want to improve and get more doctors out there, but we need the people who are going to work in rural communities to do the work, and we need the funding to help support their education and their training. I think the funding that needs to follow Native American women, no matter where we live. As I heard earlier, that Native women are just Native people. We don't just stay on our reservations. We live in all different parts of the world and different parts of the state. We're putting a lot of pressure for Medicaid to cover the costs of care for those women who are not able to get care under Indian Health Services. And it's not working. Like I have a story of a woman who has health insurance. Actually, she didn't have health insurance. She had IHS healthcare here in Albuquerque. She had a miscarriage and needed a DNC, and she had to go back to her tribal nation up in North Dakota to get that DNC. And so because of how funding is placed in some of these locations, like you're not capturing the needed services that Native women need to have healthy lives. I would like to see anti-racism training and oversight within IHS for all providers and nurses. Funding to go towards nonprofits and grassroots organizations who are addressing healthcare gaps in maternal healthcare. As I mentioned, it's $4,000 about to take care of the families that CWI is taking care of. To take care of 30 families with that budget, it's about 100,000. Our budget is $1 million. It's not enough to take care of all of the families and areas that we're trying to fill in the gaps. Funding to focus on health impact studies in these areas where OB services are going away. I know we pay a lot of attention to research, and you've just been presented with a lot of research from really well-educated Native Indigenous people. But a lot of what I read around maternal health, especially the experiences that Native women have in childbirth, is that it's more about focusing on our culture and our traditions, and from a white lens. It's nothing about whether we felt respected or honored, or that we had things done to us that we did not ask for or understand. I think that information needs to be captured. We need to have tax incentives for midwives, especially for licensed certified midwives. And these are not nurse midwives, these are licensed midwives by the state or by the government to attend births in people's homes. They're the ones who are trained specifically to go into rural communities with special skills around maternal health. I don't see any of that type of legislation supporting those birth workers in the community. I would like to see a statement of support for Indigenous midwifery in a collaboration with grassroots organizations serving their communities. Right now, we've been trying to get a meeting with Fort Defiance Hospital on Navajo Nation just to talk about the services we're providing in the community. And they won't meet with us. They have to have a meeting around safety and whether they feel like safe to meet with us, which I find is interesting because we've had a lot of women die within Indian Health Services over the years. And so the fact that they have to do a meeting around the safety about meeting with a community organization serving them in their communities is concerning to me. As I talked about, Medicaid only covers $1,500 of prenatal care as a global fee. As I mentioned, our services were $4,000. If someone were to birth in a hospital, it would probably be around $20,000 for them to birth in a hospital. And so that isn't enough to cover the cost of birth. And definitely, I heard this earlier around funding for Indigenous healthcare workforce. I believe that because we have blinders on and who can do this work, we're leaving out the ability for our own communities to be trained as doulas, to be trained as birth assistants, to be trained as licensed midwives. Not everybody has the capacity to go to school to be a doctor. I'm a nurse midwife. I've been in school for my nurse midwifery education from postgraduate is 2 years, and then there's been 5 years for my bachelor's. That's 7 years of education. And considering the communities that we come from, where the families are fractured, transportation, electricity, not having a computer, single family members having to work at Walmart for their job, like how do we expect those individuals to go to school to be doctors and to come back to their communities to serve them? I think we need to think outside the box and be innovative in our options and our choices around serving our communities. I know my organization has focused on that work. We do bring in training for doulas and lactation specialists to the community so that they can be trained. They're committed, they're experts, they're not going anywhere. And it creates seeds of skills that our communities are hungry for. I know there's a resurgence of returning traditional birth back to our community. And that's exactly what my organization does. That's what I do. Sometimes I travel 3 hours to a hogan out on the Navajo reservation with a fireplace and the medicines are all there. And these women are supported by their healers and by doulas that look like them and by their midwife that looks like them. Their babies are granted and presented into this world with song and prayer and the smell of cedar. And that's so different from the hospital setting. And I think we need to create opportunities for places like that where birth can happen. I see hogans all over the Navajo reservation. They're right next to hospitals, but they don't use them to birth in. They don't use them to do care in. And so I believe there's this understanding that care has to happen in a clinic and it has to happen in a facility, but it doesn't. You can do a prenatal visit in a hogan. You can do a prenatal visit in a teepee. If someone can't come to appointments, you can go to their house and do their prenatal visit. But I think we're all very have this idea in our head that it needs to look a certain way, but it doesn't. And I'm happy to chat with anyone individually on innovative ways to address these issues, because I know that's what we're focused on. That's what I'm focused on. I know what the story is. I know the history. I've read the reports. I've got 3 reports in front of me now about maternal mortality for Native women in New Mexico and Joe Biden's recommendations for reproductive health care. But how do we get to the communities? That's where I'm interested. What's the holdup? And so that's my message. That's what I have to offer. Thank you.
Thank you, Nicole. Thank you. We will next hear from Abra.
Let's see, is this already on? Yeah, okay, good. Okay, and James, I emailed you an image. I don't know if you could pull that up. Okay, just of Alaska. So
It's really good to be here today with you all. And I did come down from Anchorage, Alaska. This is not a presentation, but a map of Alaska. And I'll start by introducing myself. So, Ovanga Nungasuk, Utkeagavig Mugaranga, Patkatat Kuyagaranga, Angayukaka, Teresa Lu, Glenn Lu, Suli Kagamuk, Adadaka, Nasuk, Suli Wesley, Anaka, Nungasuk, Suli Artis. So I am Abra and my Nupiaq name is Nungasuk and I'm from Utkeagavik, which is way up north, the furthest north dot on that map where it says Inupiaq, and I'm a Inupiaq. I also grew up in Idaho on the Nez Perce Reservation. I'm not Nez Perce, but I've been in Alaska for 10 years and that's where my roots are. And I was able to live in Utkeagavik for 6 years, where I ran the prematernal home for Arctic Slope Native Association. And I also was a 911 dispatcher for the North Slope Borough Police Department, dispatching for police, fire, and EMS. I had 2 jobs. And that work greatly informed my current role on the Alaska Maternal and Child Death Review Committee, which has been wonderful. And I want to say thanks to the manager of that program, Ness Verrigan, for making sure that there's Native people at the table. Like people have said, when we're making these decisions about Native people and thinking about these things, Native people need to be included. Our voices need to be there. So I'm really grateful also to Janelle and Ed for making this possible and having this voice of Alaska. I was giving a little grief earlier about one of the maps earlier didn't have Alaska on it. So it's okay, wherever you are, I forgive you. But we are a part of the United States where I have some Alaskan statistics actually, which you might have heard, but we have 586,412 square miles, or about 365 million acres. We are the largest state. We're 1/5 the size of the lower 48 states. And there are not that many people in Alaska. We're very sparsely populated. There's 700,000 people around there in the whole state. So I guess the other thing about, I'm not just on the MCDR committee, I forgot, I'm also here as a co-founder of the Alaska Native Birth Workers community. And within that organization, I'm an Indigenous birth worker. I am a doula, but one thing I do want to talk about is language and how important language is. And our people don't know what the word doula means. We all know because we work in this realm. We're working with pregnancy, we're working with doulas, and we want to expand that. But in Alaska, when I talk to people from Utkeagavik or Point Hope or Bethel or somewhere, like, and they don't know when I say, oh yeah, we mentioned the nurses refer people to our care and they say, what's a doula? So when we're thinking about that care that we provide, we have to really think about how important language is and whether or not it's accessible to people. The other thing about language, so most of the births that I attend are at Alaska Native Medical Center, and Dr. Owen had a wonderful presentation earlier talking about in Alaska, the healthcare is a little bit different. So we are owners of our healthcare system as Alaska Native people. I actually didn't know we're the only state that has all of that. The healthcare is in our hands. And I really love going to births at the Alaska Native Medical Center in Anchorage. It's special. And most of the time, the team there affirms people's choices and the care they receive. And it's a positive thing. I've been to births in the lower 48 and it's a lot more difficult. So that's maybe one of the benefits of Alaska. There's some things that are going right up there that I really appreciate. But one thing that's come up over and over is the way, if culturally matched care. So if a healthcare provider is non-Native, Alaska Native people speak with their eyebrows and nose, and healthcare providers don't know that. I've seen so many times people with their backs turned to someone charting in the computer, asking questions, and the person is answering, and they will,
they'll answer like 5 times without saying a word. And it's really frustrating that they're not being listened to because they're not using words. But that is our language. And that when I'm there, I hear that. I hear those words that are not words. I hear that body language. So it's so important. And then it's frustrating. It's like, okay, I answered you. And then finally on like the 5th time, the person in labor, yes, I said yes, like, very frustrating. And we heard about how stress can lead to, we know, negative healthcare outcomes. So when you're not being listened to, when people don't even understand how to read your body language or speak to you, that's really going to lead to difficulties during birth. Some of the other numbers that I'll share about here is the pregnancy associated mortality rate for 2011 to 2020 is 8.5 per 10,000 live births. And we use pregnancy associated because our numbers are small in Alaska. For Alaska Native people, that is 17.9 per 10,000. For white people, for 4.1 per 10,000. So those are all the numbers. But what we're looking at lately, what's really concerning is the 58 maternal deaths ending in the 5 years before 2021. 19% were from homicide and 14% were suicide. 74% of those deaths were BIPOC people. Majority of those were Indigenous. 60% of those deaths were Native people. So I found it interesting. I'm learning a lot this week and in the past few months of the way this committee works. From what I understand, there's no law enforcement or public safety individuals that serve on this committee, which was really interesting to me when we're seeing these really high rates of violence within a year of childbirth against Indigenous women. So that is really, really concerning that just being pregnant increases those rates of violence so much. And I bet that some of you committee members do have a background in mental health, but we talk about mental health and how important that is. And that is a huge issue that we're facing. And that really, really needs to be addressed in a way. And men, Lee mentioned men earlier. So when we are seeing these rates of homicide, who's killing people who recently gave birth? It's usually a male partner. It's intimate partner violence that we're seeing happening in our communities. And going back to this map, so these are our languages. I'm pretty sure this is a language map actually. So it's not necessarily all the different people, but different dialects of our language. But it shows you too, you can see how we like kind of move into Canada and Alaska often gets left out. We're way up there. We're like this imaginary line that was drawn between Alaska and Canada. We could have easily just been a part of Canada or whoever Russia decided to sell Alaska to when that happened. But the way it worked out, we are a part of the United States. But this imaginary line here that's crossing us, I mean, our people, we move freely between those places and we're so diverse, and we are also living in very, very rural places. So there's hardly any, the road system in Alaska, I'm sure you all know, at least to a certain extent, that it's not that extensive. So most of the communities, you have to fly to give birth. And most people are flying to Anchorage. The thing that we are seeing that other people don't have to go through, I appreciated hearing about from lots of people how far you have to travel, usually by car. Well, in this case, you're flying. And do medical providers want women flying at 40 weeks? No. So you're flying at 35 weeks and you're leaving behind your family, you're leaving behind your children, your support person, your aunties, your mother, your cousins, your sisters, all of those people who traditionally were there to support you. Every Indigenous group of people the world over had support system in place, people who were knowledgeable and who knew how to provide that care in their communities. And this forced evacuation from your home community at 35 weeks, maybe 34 weeks if something's going wrong, or earlier, where you're sent to a city hundreds of miles away, Anchorage usually. Also, there's hub communities, there's Juneau, Kotzebue, there's different hospitals, Bethel, Barrow has a hospital, or Utqiagvik. So you're sent away though from your village and removed from your support system, leaving your family behind. Can you imagine how stressful that is for someone who is pregnant, all alone, possibly doesn't have anyone else to care for their other children? They have to bring those children with them, who are then not allowed to be at the birth, and then they have to struggle to find healthcare. And if people do choose to stay in the hub communities, because births do not normally happen in villages anymore, though on the North Slope of Alaska, which is where I'm from, there were still children being born by midwives at home in the 1990s, but that hasn't happened very often since then. Sometimes also babies will just be born because they come when they want and they come early. And oftentimes that results in a medevac. So the medevac flight has to then remove that family, that mom and that baby, to Anchorage. I have also seen at my time in the North Slope Borough at the pre-maternal home that was run by Arctic Slope Native Association, there was one mom who was overdue, and the doctor, I think she might have been like 40 weeks in one day. And the doctor was like, well, just go ahead. We're going to put you on the Alaska Airlines flight. She was sent on a commercial flight by herself from Utqiagvik to Anchorage. And with 2 hours after the plane landed, she delivered that baby. So she almost had the baby on the airplane. These choices that are being made by these providers for our people are not always in our best interest and can be really difficult. And then she had to deal with all of the stress and expenses of being far away from her home. And she could have just as easily have stayed in Barrow. So the other thing that I wanted to touch on is a personal story of the really difficult, I had a unexpectedly very difficult time postpartum with one mom recently. She got discharged, and it took a while for her baby to get discharged. They get discharged at separate times. And we do have within our healthcare system, we've got patient housing and we have the hospital, Alaska Native Medical Center in Anchorage. People from patient housing can usually just go over to the hospital and give birth, and they go back to patient housing. At this time, patient housing was full. Airline issues have been a huge thing across the whole world, but it also affected Alaska. And there were no flights for a while because of weather, construction, et cetera. The hotels in Anchorage were also full. And this mom had a baby 2 days before. She was dealing with stressful postpartum bleeding, terrible backaches, all alone, no support people. She didn't have anywhere to go. She didn't have anywhere to stay. So we went to the travel office. We had to find a Medicaid voucher for her to get a stay at a hotel. The hotels were full. There was one left. And even though it was a Medicaid approved hotel, this hotel required a $100 deposit from a credit card to stay there. She was this close to not having anywhere to stay in Anchorage, Alaska. And she's from a village of 300 or 400 people. And I had no idea how difficult it was. I have a bed, I have a home in Anchorage, so I don't have to deal with that. But can you imagine just trying to get home with a 2-day-old infant and having to fly multiple airlines? But before you do that, you have to find a place to stay. You're on Medicaid, but you're required to have a credit card. I mean, it made no sense to me at all. So I did end up just using my credit card, because what was I going to do? Let her stay? I mean, it was horrifying how difficult it was. And it took 12 hours between discharge and getting her to a hotel late at night. Yeah, that was just one story of how difficult it can be getting home from giving birth to your baby. And I can't think of anyone who would willingly choose to get on an airplane with a 2 or 3-day-old baby. And that's what people have to do just to get home. And we wonder why these babies are getting sick, why they're having ear infections. I also don't know, I'm not sure if a study exists, but I don't know what the studies are like of bringing a brand new tiny baby on these flights. Like it's not, I had a terrible earache on the way here. It was so painful. I'm an adult and I could work with it. I could chew gum and take an ibuprofen. But these babies, that it's unnatural. We all know that when babies are born, and it's ideal if we're just at home with them in our arms immediately and we don't have to go anywhere. Okay, the other thing I wanted to touch on here is the importance, and I've heard this already multiple times, but an Indigenous birth worker, which I like to say that I'm an Indigenous birth worker, Indigenous birth keeper. I'm not a healthcare provider. I'm a community member that cares about people. And I do have birth work in my history too. On my both grandparents' side of my family, there were birth workers. So thinking of history, it's important that we have these people to speak up. Going to the appointments, we mentioned that. Or this morning, we heard in the opening, when you're at a doctor's appointment and you've just had a baby or you're pregnant and you hear stressful news, you're not gonna be able to carry all that information and adapt it and absorb it. So having someone there, and I had a conversation with another doula, like traditional doulas who have businesses. At our organization, we provide our services at no cost to Native birthing families. We are paid through grant money. This is my job, but we don't charge those families money because that is not how we traditionally operated. In community, you didn't pay the midwives. You maybe traded with them. I get plenty of dried fish and salmon and traditional foods. I love that. That's great. That's what I appreciate from families. But being there with them through this process as they navigate the healthcare system, which in Anchorage, I really appreciate. They see midwives. There's certified nurse midwives who are there who provide people care. But being there to help them navigate that system, that is so, so important. And I do have I guess I did ask that question. The other about, public safety, law enforcement. Also, how many of the committee members have a background in suicide prevention? That's really, really important when we're thinking about Alaska, when we're making these recommendations. How many committee members have a background in rural emergency services? So rural Alaska, being a 911 dispatcher, a lot of the calls I got were about small babies or pregnant people in distress that needed to end up getting medevaced. So my main recommendations are that there are Indigenous birth workers at all births. I know the family. I know these families. I know their community members. I ask about who their parents are. I ask about their traditional names. I know the relationship between the two parents and whether or not there's something dangerous going on there. Speaking of OCS or Child Protective Services earlier, I've also been at a birth where the doctor and nurses were very threatened by the male partner in the room because birth is a stressful and scary event sometimes. It's not always, sometimes it is. And there was an OCS report that was opened up. I knew enough about this family that it's completely, it made no sense to me when we're thinking about families and Native men and Native women. Sometimes there is violence, oftentimes there's violence there. Sometimes it's false accusations. If you have an Indigenous birth worker there, then it's great. And also remove this certification of a doula, like certified doulas. Indigenous people can certify themselves in becoming a birth worker. It's having that person there. Thank you. Yes. We have this knowledge, and having that person there who looks like them, like that's going to provide better health outcomes. We also need, again, to look at language, listen to people. I even worked with someone who was Native from the lower 48, and I forgot to tell her about how Inupiaq and Yupik people are going to talk with their eyebrows and nose. So I know that. So when I'm working with those families, we can talk to each other without saying a lot of words. We need culturally matched care. We need people that look like us in the room. And the home visiting program, that is huge. And that's come up over and over in our Alaska MCDR programs. We need that in every Native community, but we need American Indian and Alaska Native people doing that work, visiting those homes, and watching out for those things when we're looking at violence, suicide, overdoses. Those people are going to help identify those issues, and they're going to be trusted and welcomed in those homes. The other thing that am really curious about and want to learn more about is this American Indian, Alaska Native-led maternal and child death review committees. We need to make that funding accessible and the process of getting those funds accessible. I have more to learn. I don't know very much about that. I've heard a little bit about that funding, but the one thing I want to close with is Native people, we love our people. We value our people. With every maternal child death review that we go to, I'm a core committee member, so I help compile groups, the panelists. I also serve on reviews for maternal deaths, sudden infant deaths, and youth deaths up to the age of 18. When we open, we talk about honoring those lives. And that is what we need to do. And I don't know if it's going to look like individual tribal-led reviews or maybe state or like Janelle and I talked about briefly, maybe regional, but when Indigenous people, when American Indian and Alaska Native people are reviewing these deaths, they will honor those lives, and that will greatly help in reducing our maternal and child mortality rates. So thank you so much.
Thank you. Thank you, Abra. So thank you, Abra, for bringing to our attention the notion that the border crossed us. And that's something that we don't often talk about, is that we have Native people along the borders. We have, people that have I have family that live in Canada. They're still part of my community, part of my nation. And there are people in the South have their families in Mexico. And then also another point that stuck out to me, all of it stuck out, but another point was that we are a policed people. Depending on what some reservations and communities, you have multiple layers of police task force. You have the tribal police, you have the non-tribal police or the local community police or the county sheriff, you have the state troopers, and then you have the FBI. So we are a policed population as well. So thank you for sharing, Nicole, Abra, and Rhonda. I will open up the floor to any questions. We could probably take about 3. Yeah, Colleen.
Thank you for your stories. I was blown away by the travel aspect, both with Ms. Claremont Sweeney and driving 120 miles, and then the idea of the plane. As I've never heard that before. That's shocking. So clearly we need to get more providers, more local, so that doesn't need to happen. Mrs. Claremont Sweeney did say that you feel like nothing's changed in 45 years. And I heard that loud and clear. I kind of wanted to say that from a medical standpoint, I think we've made a lot of improvements, and a baby at 26 weeks today should have a different outcome than your son did. And I love that you celebrate your son's life, and that's fantastic how you have so much love for him. I think the piece so I can say it's better from a medical standpoint, but clearly it's not better from the receiving end of it. So it's not translating to your community is what you're saying. So we can make all the medical advances in the world, but if it's not getting to you where you live, so that a baby who's 26 weeks is born today, close to you, should have the same outcome as the baby that's born in a city with access to university hospitals. So I do think the positive is that there have been a lot of improvements in premature birth, but these issues of getting that to you didn't happen. And a 26-week shouldn't have been left in the room with the mom overnight and then reassessing the next morning. That doesn't sound like a good plan at all. So that's the part that we have to work on, obviously. And I just really wanted to tell you, I appreciate your story as a neonatologist, because it shows me how far that we've gone over 45 years, but how much more we need to do to kind of get that to the people. So the improvement is uniform across the country and not just in pockets where there's academic medicine.
Thank you. Are there any other questions?
I don't have a question, but I do. This is Joy Nyhart from Alaska. I wanted to mention to Abra that I've been on the State of Alaska Maternal Child Death Review Committee since 2014 or 15. And my first few meetings, there was no Native representation at the table. And I brought it up slowly and forcefully. And then I actually yelled at somebody and said, we can't keep doing it this way. So yes, thank you to Ness and her predecessor, Katie, and Jared Parrish, and all the people that work on the committee and support it. And thank you for being part of the committee. And you are so correct that when we review deaths that happen in the villages, I can review it. I can come up with an educated understanding and help with some information, but I can't change it. But you can change it. You can change the outcomes and you can make them fewer. So thank you.
Thank you so much, Dr. Nyhart, right? Yeah. Kuyanakpak.
Yeah, please, Dr. Ramos.
Thank you all for your presentation. Once again, I'm just struck by the dichotomy that we live in here in the United States, how we can have third world conditions in one of the richest countries in the world. It continues to baffle me. So I want to thank you once again for sharing your stories. And I apologize that you have to continue to share your story and re-traumatize yourself for the benefit of others. With that being said, something that has struck me, and I'm curious to hear the panelists' suggestions. One of the things that, as a family physician that has provided maternity care for over a dozen years, I recognize is this notion of having comprehensive whole person care in one setting. And there's this notion particularly in Western and in the United States, that people have to come to get their care. And that's how we think about access. And that's a bias. But what I'm hearing continually is that we have to bring the care and help people make the right decisions for themselves and reduce those barriers. So it's increasingly becoming evident to me that, one, we know based on statistics that family physicians, nurse midwives, multidisciplinary teams are part of the way to create a solution and creating a comprehensive home base, safe place for our birthing families. My question is, if you had an ideal world, I hear funding. If you had an ideal world where, one, the system and the people within the system, Indigenous or not Indigenous, actually saw you and listened, what would that ideal setting look like for you and the communities that you each serve? So paint us a picture on this committee on what would that look like for the birthing parents and the communities that you serve if people dared to listen and act.
Okay, I can speak to that to an extent. So yeah, thank you. Thank you for your question. Like Dr. Owen said earlier, and I think it's really true, we have a pretty incredible healthcare system in Alaska in many ways. And I do have the privilege, well, and it's also a burden in some ways because I'm not home in my community of Utqiagvik, but I do live in Anchorage where we have pretty amazing healthcare. And so I received my primary care at South Central Foundation, and they do something called the NUCA model of care. And I really appreciate it. I go to one place where I can see, if I were pregnant, a midwife, my primary care physician, or whoever my provider is, possibly a PA and behavioral health all in the same room. And I do like that. They come to me and it's wonderful. It does not exist in our rural villages or I guess anywhere outside of Anchorage, I'm assuming. It's wonderful. We do have a lot of Alaska Native, Native American Indian people, if we're using, like we were told earlier by Stacy, the federal terms in Anchorage. I believe South Central Foundation cares for 60,000 Native people in that area who can then go and get their primary care. There's also a clinic in Wasilla. They come to us. It's amazing. I really, really appreciate our healthcare system. If anyone in Alaska complains about it, I do say you have not received care through an IHS facility in the lower 48, which I did because I did grow up in Idaho and had pretty terrifying healthcare experiences in New Mexico that informed what I do now, because I don't want people to get treated the way I do, where I almost died. I can share more about that later, but I want that for everyone in Alaska and for all of our Native people. When they go to get their care, those providers are coming to them. Yes, they do have to go to one appointment, but then they come to them and you're in that clinic. You don't have to hop around to a million different places. It's hard to imagine thinking of that and bringing birth back to our communities. I would love that. And I don't actually know exactly what that would look like, but I would love to see that.
Nicole or Rhonda, if you have any response. And Nicole, I know you're trying to show this, living this, doing this.
Yeah, I would say part of the colonization model has made us dependent on a system that is not serving us and hasn't served us and even wasn't created to serve us intentionally. And so decolonization from that model for me is more about creating systems and healthcare that reflect the communities that they're serving, which means redistributing funding to food and access into things that maybe we might not think are part of our healthcare. I know we are experiencing high rates of suicide and depression in our maternal communities and not having access to a mental health care provider, but also understanding that Native women, just Native people, that trauma we've experienced and are continuing to experience is partially because of having to navigate a complex system, one. Two is not being able to practice our traditional ways of life because we are separated from that in one way or another. Three, our families are fragmented and so our support systems are not there. And I think that's where the poverty is what I see, is not having a support system. But also thinking that as a Native woman that I want to go talk to somebody about my problems. That's not traditionally what we did. Like we would go to sweat lodge, we'd go to ceremony, we would go see a medicine person. And so when I say decolonizing our way of thinking about what we think mental health care looks like is incorporating those practices and centering them in our care, as well as thinking a little bit outside of the box about going to people and providing care for them in their home and not putting all of that burden on a family to access care. And then reading statistics that make us look bad as Native women, that we don't care about ourselves, right? We don't care that we're not getting care early like we're supposed to. And everybody uses a lot of different terms to describe that. So for me, yes, funding. Two is policy and legislation that allows, and specifically the language around certification, Indigenous midwifery, doula, unfortunately, when we start to make policies, it begins to criminalize those who don't adhere to that policy. And we need to think that when we're creating policies that support our communities for better access, that it doesn't criminalize our traditional medicine healers and women and people choosing not to license or to be regulated, but who are choosing to still serve their community as a healer, as a medicine person outside of that policy and that model. And often I see that off in circles, specifically creating policy to support communities is like, we're seeing that right now with the access to abortion services. Like is that even a topic of discussion? Like, is there a support for Native women to get an abortion if they need it? Because a lot of the funding comes through the government, and like that's not something that Native women can access right now. And so as Native women, I feel like our bodies are highly regulated, and decisions around what we can have access to or can't have access to is tied to funding and to government decisions that we can't even be a part of, and that's a problem. And so how do we, ideally, I would love to see a think tank of doctors, midwives, doulas, medicine people sitting down and talking about what the problems are, and think about innovative ways to address them, and coming to you all with recommendations. Oftentimes I get invited on the back end for recommendations, and then I'm not invited to the spaces where those recommendations are being read out or even continued through their policy changing phases. And so like that needs to change. I would love to say access to food and clean water, but like some of that is out of our hands. I just went to the UN committee hearing recently and hearing from a Shoshone tribe that their land is being desecrated for gold, and like a majority of their sacred lands is being torn up, and their water quality is not good. And they're fighting this battle that they're not winning right now. And so a lot of our tribes are in that place with not only the government, but like companies coming in to steal our resources, our water, our minerals, our coal mining, and that's affecting our health. And like, what is our obligation to our community and to the land if we can't even fight those battles? Like, we can make a recommendation, but is that going to change anything? And so I think this is an opportunity to change and to have innovation. That's how I'm seeing it. I hope I answered.
Thank you, Nicole. You've all given us a lot to think about. And I know we're supposed to go to the next session, but Abra,
I just want to say something really quick in response to Dr. Malloy's. Sorry, I'm trying to read. I might need a new prescription here, but like you mentioned that things have changed, and I wanted to, Rhonda, her baby was removed from her hundreds of miles away. That happens in Alaska all the time. I do have so many more stories. If any of you want to come and talk to me afterwards, I'm going to be here until tomorrow. And I'm very grateful to share these stories. I had from the prematernal home, a mom who had a C-section, and her and dad and baby went back to Utqiagvik, and baby needed to get medevaced to Anchorage, and they only had room for one parent, and she was recovering from major surgery and couldn't carry a bag or car seat. You know the rules after a C-section, and she was separated from her child. She was trying to breastfeed, and there was no way or resources for her to get back to her baby. So yeah, it's still happening, sadly, today, very, very often. Thank you.
And thank you. It's all these stories that need to be heard so that changes can be made and that hearts can be changed as well. I know that we're running behind, but I just want to say thank you all for being here. And you are in the room where it happens, Nicole, Abra, and Rhonda, and we're going to have to keep you in the room where it happens. Okay.
Just one comment. 45 years ago, I was a pediatric resident at the University of Utah, flying throughout the Intermountain West, picking up babies who needed newborn intensive care unit. Rhonda, I may have picked up your baby, but that experience was one of the things that drove me into public health and focusing on health disparities because of all of the inequities that I saw throughout the Intermountain West when I was a pediatric resident. So things don't change a lot, but some things change. And whatever we do influences things as they move forward in some mysterious way. So just learn from your presentation. We're going to take 1 minute to stand and stretch while we get our next panel to come forward. Just to let you know, we're going to cut short on breaks, and we are going to cut short on the discussion time for the committee just because all of these sessions are running a bit longer than usual. We also have Tina Paralau from from the IHS. I'm going to give her some time. She's on the screen, and I'm going to give her time near the end of our meeting so that we can have some discussion with her. So 1 minute, we'll get started.
Spot, I was going to put you here. That's okay. So that you have ample side here and you guys get to share this mic. We're going to try to have folks in front of the table unless you do want something around the room. I will fix that. Okay. I totally, no, you were fine. I just wasn't, I have an UCI, so.
All right, the minute is up. Get back to your chairs. Crack the whip.
Thank you. Well, welcome back, everyone. I wanted to know, Dr. Ellinger, is there anything you want to do about why you wanted this session to be able to tee us up? And then I'll take it and introduce. And while we're doing that, Emma, could we get our two colleagues, Terrence and Deborah, on split screen so we have the full family up here while we're getting ready? Ed, would you set us up?
Yes, so many of us have worked in the field of maternal and child health. So we know the organizations that really focus on MCH issues, AMCHIP, City Match, Healthy Start. But a lot of the new members of this committee may not have had the same kind of public health experience. So it was really good. I wanted the members of this committee to learn about some of these organizations that are outside of the government, but work a lot with government programs on maternal and child health issues, to learn about some of what they're doing, but also particularly what they're doing around American Indian, Alaska Native birth outcomes, and also to have them learn a little bit about what the issue is so that their organization can focus on it, on some of those issues. And I want to form a relationship so that these organizations can leverage what we do here and amplify what we do here by taking whatever the recommendations come forward and putting them into their work plans as they move forward.
Thank you, Dr. Ellinger. By introduction, my name is Magda Peck. I'm a member of ACIMM, SACIMM, but it is the Secretary's Advisory Committee on Infant and Maternal Mortality. I come to you today with a chance to hang out with family. Folks that I have known for we've been talking about 40 years. It's been a 40-year in the desert journey. And here we are to come home to some core maternal and child health impact organizations who have come together over the years, most recently with an explicit statement to embrace an anti-racist strategy together in the pursuit of health and racial equity. And we've had some new faces here. So Terrence, we're so glad to have new family members join us over time. So here's what I'd like to do. This is the lightning round. We are not doing a series of presentations that you've heard. This is a conversation among the family, so that folks who work with organizations whose public health missions are explicitly dedicated to changing systems, policies, and programs can have a chance to give their reflections on what they heard over the last 2 days. Family goes last. And what their positioning can be to help amplify our work. So the lightning round goes like this. And Terrence, I'm going to start with you and then go to Deborah and do a once around. And you don't both have to give the full explanation, but if we were in the elevator and I were to say, what's AMCHIP? Because there may be folks here who don't know. So what's the elevator 2 or 3 sentences you now use to describe your organization?
First and foremost, I want to thank the committee for assembling on this important topic over the last day or so. The session that I just participated in or listened in on is deeply rich. And so I'm excited to be a part of this discussion this afternoon with my friends. I like the discussion of family because I do believe in most families. We know that in order to sort of advance progress, part of it is getting to know one another, getting to better understand the needs and desires of our families. And so I want to thank you all this afternoon for this. About AMCHIP, the elevator speech I would say is AMCHIP is a membership organization that represents governmental public health, particularly state governmental leaders, as well as leaders in community, families, people with lived experience. Our folks are sort of deep in the health department across areas of foci, including children with use of special healthcare need directors, MCH epidemiologists, adolescent health coordinators, et cetera. And we really come today sharing what you've already mentioned, a deep commitment to anti-racism and recognizing that in order to sort of move the needle on our work in MCH and beyond, we must acknowledge past harm. We must interrogate the ways in which we interact with each other and community, and also looking at the policy landscape and the tools that we have at our disposal and what we know already works among communities. And so we're excited to participate in this discussion to add, but also to learn and listen.
Thank you. That is a very tall building. And we love that you're in the elevator with us. Deborah Fraser, give us your elevator. What do people need to know about the National Healthy Start Association?
Thank you, Magda, and thank you all for allowing us to join you this afternoon. And I am not here, Terrence is not here, obviously, and our condolences to Terrence for his reasons for not being here. And I am not there with all of you because I'm here with our pilot sites that are working on addressing maternal health and disparities in maternal health. And so I was not able to tune into all the proceedings today. We are in New Orleans, and I want to acknowledge that we are here on the banks of the Mississippi River, and what was for centuries home to the Chitamacha tribes, the Choctaw, Homa, and Tunica tribes, and the Biloxi tribes, and what the Choctaw tribe called the Bobancha, the place of other tongues. And so we acknowledge that and acknowledge the injustices that led to those tribes during all of those centuries and continues to happen during colonization then and now. So, and we did that in our meeting today. We as an association, we inculcate all of our work with equity, but the Healthy Start program is a community-driven, which is important, community-driven and community-based program, which was founded and continues to work to address disparities and inequities in birth outcomes for moms, dads, and families. And we put an emphasis on the work that we do with fathers, and that's really, really important. And that is our quick elevator speech. And we can expand on that, but I mentioned fathers, I mentioned at the beginning of this, we have a portfolio of programs that we do with our AIM CCI, and we have a racial equity learning series with 7 modules that address equity across a course, and it is inculcated in our policy for the National Healthy Start Association. It is a required part of our personnel policy, and we also lean on that for our contractors and our partners as well.
Thank you, Deborah. I'm going to turn to our family members at City Match, Denise Pecca, who is the Deputy Executive Director, and our current board chair, Stephanie Graves, who I've heard of many times mentioned over the last 2 days locally, who is the lead for maternal and child health at Minnesota, at the one more M. It's been a long 3 M's at the Minneapolis Health Department. May I pass it to you, Stephanie, first?
All right, my elevator is just a couple floors. So City Match is a national maternal child health organization that the membership consists of local urban public health members and then community members that also work on and believe in trying to improve the lives of women and children, and especially to enhance birth outcomes. That's who we are. We also believe in equity, and we believe in, we did our anti-racist statement, and then Denise can talk a little bit more about that.
Is that what you want? I would also say that we focus on MCH, and on the elevator, I always say that's a very big umbrella. It's hard to find anything that doesn't fit under MCH, including men. And I think we talked about this at a previous meeting, and you have it, it's in the folder, that all of us are committed to being anti-racist organizations. I think all of us had started that journey before we had the joint statement. So you'll hear that, I think, as we talk more about our work.
Mm-hmm.
I'll take that back, that one. If I could go to our last organization, which is NICHQ, which is the National Institute for Children's Health Quality. We have folks here to be able to tell us what that is and what that means. And any other way you'd like to make sure you are self-introduced.
Okay, I'll go. And then you'll go, right? All right. Hi, everybody. Scott Burns. I'm CEO at the National Institute for Children's Health Quality, or NICHQ. We're a 501c3 nonprofit that's based in Boston, Massachusetts. And I do want to acknowledge that that is the land of the Massachusetts and Pawtucket and Naumkeag, I hope I pronounced that correctly, peoples who stewarded that land for generations and generations. And NICHQ, what we do is our mission is to improve children's health. Our vision is that every child achieves his, her, their optimal health. And we boldly lead improvements in children's health by addressing inequities and other complex issues facing families. That's my elevator speech. Latasha?
So I'm Latasha Rouse. I'm a birth and postpartum doula, mother of 9-year-old 26-weekers. The triplets are 9, I can't believe it, and a 12-year-old. And I am a board member on the board at NICHQ. And I am excited about the work that we're going to get to do.
Well, the opportunity we have today, and we want to first of all acknowledge that time has been expansive today. And sometimes when you have something that's quite extraordinary, it takes the time that it takes to tell the stories that must be told. So we're going to use our time in having the organizations tell their stories in response to a couple of questions that I shared with them to be reflective about. Background about these organizations are in your briefing book. Ways to follow up about the long list of many accomplishments that they have can be done at another time. This is a conversation. And in the first conversation, I want to ask, and I'm going to start with City Match, and I'm going to start with you, if I could, Stephanie. What have we learned? And what are the strengths that you've seen over the years you've been with City Match that lend itself to this moment of an explicit and intentional focus on American Indian and Alaska Native policy change and broader Indigenous health and equity? So what have we learned from an organizational lens of City Match? And what are the strengths that you want to make sure that folks can count on?
Thank you, Magda. I think what I've learned over the years, and Magda and Ed both being founders of City Match and how many years it's been around. I've been around doing this work for close to Noya as well, about 30 years, long time, Belinda, I know. And what I've seen through the years is the shift and the change of what is important, that it's not just one group of people that matters in this country, that it's all of us that matter. And I think I've seen that and I've watched it because I have been going to City Match for a long time and now actually a board member. But I've seen the faces change. I've seen the dynamics change of who sits at the table. And this is part of what you heard earlier. Who sits at the table and who's impacted by the health disparities that we talk about matters. So I've seen more BIPOC community or Black and brown folks sitting at the table. I've seen City Match shift and incorporate American Indian people into the program. When I first went, we weren't even there. There was maybe a couple of us that showed up at the big conference in this whole group of hundreds of people. And we know that across the country, how many tribes there are. So that to me was devastating to find out where's all the people. And so I've seen City Match take an interest and do what they say. They listen to what we're saying, and then they take it and do action. And that is something that's different. And that's even with the anti-racism work that we've done. We had to look at ourselves internally first, because we can't go out and change the world if we don't change internally first. And so that's something else that City Match has done. And I have been proud to be part of that transition.
It's hard to top that. Thank you, Stephanie. I would just say that's true. We have funding from HRSA, MCHB, and CDC, DRH. I'm looking at Charlene because back in the day, she was our project officer. And we started doing work with the tribal epicenters, which were talked about earlier, as part of our conference. And the very first year, we were like, yay for us, right? We've got the tribal epicenters here, and we've got some stuff. And the feedback was like, not enough. Like, we don't see ourselves beyond this in conference. So we took that very seriously. We have our conference next week. We have a session on data sovereignty on the main stage. Abigail Akahawk was our keynote last year. We incorporated main stage and workshops throughout. We're working with the tribal epicenters throughout the year. So we're just really looking at all the opportunities that we can build on that and be intentional. Terrence, right? Terrence, you're next.
Thanks so much. And I also want to acknowledge Belinda Pettyford, AMCHIP's president, a committee member that's in the room. And we've had lots of conversations about the importance of health equity And one of the sort of main lessons that we continue to discuss internally as team members and also with members is really the importance, and this came up in the last session around Rhonda Swanee mentioning the sort of the 200 times that the treaty had been breached, and how often we don't acknowledge the harms that have occurred. And so we believe step one is, as part of our phased approach to or journey to racial equity, is we believe the important process is reconciliation to improve ourselves, as was just mentioned, the examination of self, the admission of ignorance or error, acknowledging past actions that have not that we are not destined to repeat. And in that spirit, acknowledging that some of what we have done, we are deeply regretful for. And some examples are, as an organization, recognizing that we have at times used language that characterizes racial groups as, quote, at risk, or quote, vulnerable, as if the race of a person is a predetermined factor as opposed to racism itself. We've contributed to the invisibility of the indigenous populations of women, their children, youth, their tribes, their birth caregivers, and their histories by existing as an organization for decades, having few long-standing historical relationships that we know are so critical and important in this effort. We've talked about with our members and also internally about our membership structure, our events, our annual conference, how they're not always easily accessible for community-based organizations. And they have not always appropriately prioritized the engagement of their wisdom, which we know is profound and potent in the work that we do. And so we're willing to share our truths. And we believe that that's step one, to provide clarity about our failures, to illuminate how we intend to improve, and challenge ourselves and those around us to do the same.
Thank you so much, Terrence. Deborah, given it, you're right across the way from him on this lovely screen. Tell us about your lessons learned and how we can appreciate the work of Healthy Start.
Thank you, Magda. And so Terrence and I couldn't be better partners. We're sharing a screen and a board member. So, Belinda Pettiford is a founding board member of National Healthy Start Association. And so for those in the room who don't know this, Healthy Start is the membership organization of the Healthy Start grantees. And Healthy Start grantees can be city, county, state health departments, community health centers, 501c3s, universities, hospital systems. So it's a mix of organizational grantees. And so we represent those grantees that are funded who respond to the notice of funding opportunity. So I want to lay that landscape there for you. So that's who we represent. So in that context, what we've learned, we were funded as a demonstration project in 1991 with 15 grantees. And I want to invite Belinda, with your permission, Magda, as a backup to this conversation, because we were funded with 15 demonstration projects, and of those 15, one was the Great Plains Tribal Nation. And so we went along with those 15 tribal nations, so bear with me on what we've learned. When we began to expand this program, about 1999 or so, I think, because it was under Belinda Pettiford as a founding board member and the board president at that time, working with the division director who had actually spent time in service as in a nursing leadership position on tribal nations. We expanded the Healthy Start program and carved out, Healthy Start program was going to expand addressing disparities in equity. And so at the end of that funding period, we had maybe 104, 105 Healthy Start, something like that. And we had an indigenous population in Alaska, one in Hawaii, we had three or four tribal nations. And then we were serving a tribal population in North Carolina under Belinda's Healthy Start in North Carolina. The next funding opportunity written differently, I think it was Healthy Start 3.0. We lost Alaska, we lost Hawaii by the next, and I think one of our tribal nations. The next funding opportunity, we lost another. Right now, we are representing 2 tribal nations. We as an association represent those tribal nations. Anything I say is a direct comment from those tribal nations. When we had all of those indigenous and tribal nations, they compiled a report that Belinda has. And we asked, and that report was developed again with Mary Beth Badura at that time and Belinda under her leadership. And we've asked some of our tribal advisors to help us to update that report from that time. And they said 2 things. One, we cannot speak for indigenous populations that are no longer with us, but looking at it now, there is really no update because very few recommendations have been implemented. They gave us a series of other recommendations, many of which you already have. And all of that is to say what we've learned is that much of what we were asked to do some time ago have not been heeded, but we represent in the Healthy Start program, community-driven, community-based programs, but we represent those tribal nations that meet the eligibility criteria. And so what we've learned is that those eligibility criteria are not being written for tribal nations to qualify. And so what they asked me to deliver today is that message, that they'd like to be in the Healthy Start family, because when they're funded, and I think you heard that from one of the, I think the presentation you had immediately following lunch, you heard from a presenter who said, we were formerly a Healthy Start grantee. That's one of the grantees we lost. We formerly had the Great Lakes. We had several Healthy Start grantees from tribal nations. And what they also say is that this is a very hard project to manage. We have a list of recommendations and we can give those to you. But that's what we've learned.
Right.
That it's hard for them to qualify because of the way the geography of the reservations, the way they're counted in census or by the CDC, and the way that the tribal leaders know best what works for them. And they make good decisions, but they're not what works for researchers. What works for the general population does not work for tribal nations. And once you write a notice of funding opportunity for the general population that says you must reach this infant mortality rate, or you must reach this number of women, that doesn't work for tribal nations, and it automatically eliminates them. So there are a number of things I think we can do because, as they say, when we receive money from Healthy Start, we move the needle on addressing infant and maternal mortality and morbidity. We can implement our spirit curricula for moms and daddies. And we can improve breastfeeding rates and other rates and look at other programs that have made strides in how they can carve out Head Start, McBee, and other programs that provide the support to tribal nations. So that's a long answer, but that answer is, it doesn't come from me because I've done a lot of things in my career. I've trained Alaskan Native providers in how to do FEMA many, many years ago. But I've never worked a tribal nation. So I only speak from those tribal nations that we serve and we represent. And I would ask Belinda to add what happened to the tribal nation that she served in terms of lessons learned in North Carolina.
Belinda?
Thank you, Deborah. I think I think you've already shared the basic information, Deborah, and I'll share the report with the full committee. We did work with the tribal sites, the Healthy Start sites that were tribal sites, and worked with the Bureau and came up with a report. The recommendations are so in line with the recommendations that's coming from ACIMM. I did spend time last night trying to do a comparison and to see where things were missing, and the conversation is the same. I mean, the recommendations were made in 2005. The report that we worked with through the National Healthy Start Association, and we're still not seeing the movement because the recommendations are the same. In North Carolina, we actually ended up, we have 2 sites in North Carolina, 2 federally funded Healthy Start sites in North Carolina. One that serves primarily Native American Indian families, and they have continued to receive funding. Some of the challenges that they've shared with me has been around, with the Healthy Start program, is around the screening tool and all of the data that has to be collected. It seems, seems a bit much to ask families to respond to all of the questions on the screening tool. And so those are, some of the challenges that they see. And we see those same things in the report that came out in 2005. And, if there are areas of improvement, what could you improve? And I will say that was one of those areas. But in that same report, it talked about, the importance of program implementation, having, working on the systems, making sure that the screening tools could, be changed. The level of client level data was a bit much, and that really it needs to be a family approach. It has to be a holistic approach. It does not happen in isolation. Our second program in North Carolina, we actually had a second site that once out of my office, we actually at one point had 3 federally funded sites. The last NOFO that came out allowed us to only apply for 1. So at that time, we did work with the American Indian tribe, the Halawassaponi Indian tribe in our area, but we couldn't get the numbers enough. We could not get the numbers lined up for them to actually qualify to apply for the program on their own. So we work with them in some level. More recently, they are a partner with us on our doula grant, and we'll be helping with that implementation. But Deborah's correct. I mean, the way the data, and I understand the data. I've been in this field for 30 plus years. I understand the data, but there's got to be a way that the data can be released, and the way that you qualify to apply does not eliminate a whole population of individuals. And we see that in our state.
Right. Thank you for those insights, Belinda. Let us round out that with best experiences and lessons learned from NICHQ. Let's start us off, Natasha.
The internal work of an organization is the first step in how important it is to make sure that it's not just staff, it's also the board, and everyone is learning this information together. So I appreciate being here as a board member, and not just a lead. I think that's important. Because what happens is a board member comes to something like this and they start to recognize, if I close my eyes as a Black woman, there are several things that I heard that I could have been at a Black maternal mortality meeting. It's the same stories. It's the same recommendations. We're trying to get the same things done. There are differences, and those are significant. But when you close your eyes and you hear that, you realize that not much is changing. And so the impatience of having someone like me on the board means that you start to think about the experience of the person and not just the data and the big, tall orders. What things can we do that will change the experience of people on the ground locally, and not just live in the cloud of it all? And so my lesson is to make sure that I keep pushing those kind of discussions in board meetings, and anywhere that I sit.
So I need to give a shout out to the representation here from NICHQ. I should add that Charlene Collier is on the NICHQ board as well, a member of ACIMM. And we have Ken Harris here, who is our engagement lead and executive project director, who's leading our supporting HRSA-funded supporting Healthy Start Performance project. We provide technical assistance and capacity building assistance to the 101 Healthy Start sites, funded sites around the country. I think in terms of lessons learned and what NICHQ does, I'll just first say that, well, we're completely grant funded, by the way. I didn't say that earlier. We have about 12 current projects right now. Most of our funding is public funding, some private foundation funding. In listening here and hearing in the last 2 days, we clearly need to do more. There's no doubt about it. That's my takeaway. We've done some work, and I'm proud of our work. We've done work in Oklahoma and Chickasaw Nation Medical Center around safe sleep and breastfeeding. We've done some work in Alaska at the Matanuska-Susitna Borough, or Matsu, on our early childhood efforts. We also did some work with some tribal communities in Oklahoma in our early childhood efforts, and of course in our Healthy Start efforts. And then just to circle back to Latasha's point, is that we need to be really very purposeful. You talked about the anti-racism statement and commitment of the organizations that are here together today. We maintain communication monthly. We do hold each other accountable. We share our lessons learned. You know, we try to fail fast, as we say in quality improvement, and try to share those lessons learned. And internally, I would add that we've been very purposeful about diversifying our staff, about diversifying our consultants, about analyzing our vendors, and our consultants. There's clearly more work to be done.
So we have these organizations that are essential partners to elevating the work. So our last round, as we are here together, and this conversation will continue. It's not about this moment alone, but it's about pivoting from this moment. So the question to you is, you've had a chance to listen in over the last 2 days. Many of you have been to many of the SACIMM, SACIMM, ACIMM meetings over the last 30 years. And in particular, the last couple of years that we've had the opportunity to serve. Now that we have this very strategic focus on Indigenous women, children, families, and fathers, the first time, and the first time here as your guest, what do you see is strategy or advice that you have as we shape these recommendations so that they will move from word to deed, that'll become more than a list of 10, 20, 30, 40? How do we make them actionable? How do we make them strategic? And how will you leverage them in the work while we're waiting for the secretary, as he has said, to listen and act? So recommendations to us as this committee for being able to seize this moment, make these strong, and how you can use them for change. And I open that in no order. As the spirit moves you, I give you back the mic.
So I would say a lot of times when I see recommendations like this, there's no way of knowing how those would be implemented. So asking people and taking suggestions that they already gave as to how these could be implemented, I think is always helpful, because it could be interpreted a whole nother way than what the feeling was in the room just by saying doula program or community-based doula program. Those mean different things to different people. So making sure that some details follow those amends, and we are clear about how those play out, and how organizations like ours can help support that work.
Thanks, Latasha. I'll just add to that a couple of things. It really all comes down to community. you know, and in every sense of the word. And that's who we are here today together. But what I mean community in the sense of action, it's connecting with communities, and every, you know, interaction I have, listening session, whatever, it all comes down to meeting the needs of the community and truly listening and engaging the communities you're trying to serve. You know, the American Indian, Alaska Native communities in this context, we have to engage the community. I think for me, for NICHQ, you know, this has been an eye-opening 2 days for me. And I'm ready to go back. I've already been communicating with my communications lead about what we could potentially do in terms of raising awareness on our part. I mean, I think that that's something that's important, and working with our partners to do that as well. And we also talk about in quality improvement, we talk about the will to change. And I think that that's something that while we're waiting for the recommendations to hopefully come to fruition or whenever that will be, I think, you know, I would like to say that at least from a NICHQ standpoint, and I imagine our colleagues that are here, that we will have the collective will to think through and to take action. And for example, I mentioned private foundation funding. We have a planning grant we're actually finishing up from the Kellogg Foundation around something called an equity systems continuum that Dr. Stacy Scott, who's our equity lead, had been working on at the Global Infant Safe Sleep Center, and then we've been evolving it at NICHQ, and we're creating something called an equity systems auditing tool. And what that's going to enable an organization, wherever they may be, including in tribal communities or a local hospital, or an MCH organization, to see where you are on an equity systems continuum. Are you a savior design system where you're coming in as a savior? Are you an ally design system where you think you're sharing power, but you're just having, let's say, a family member on a committee to check a box, or a member of the community? Or are you an equity empowered system where you are actually giving up some power? You're actually truly having a partnership and truly listening. And so we're excited. We're actually starting to pilot this. We're validating it. And I think that could be something that we could bring in a very powerful way to this conversation. Thanks.
Denise, 2 minutes.
So Magda, this is Deborah. And since I can't see the room, I hope I'm not speaking over someone else. So I just spent the morning listening to the feedback from our AIM-CCI contractors who've been doing focus groups around the country with birthing mothers and fathers. And the stories left me in tears. And then I listened to part of this today. And so I'm beyond a sense of urgency about this. This is actually, and let me first also commend Ed and this committee for taking this on with a sense of urgency, because we are honestly beyond urgency. This is a moral issue. It is so unacceptable. And I've said to my staff and all of the folks who work with us, I want you to look at every piece of data, every number, and I want you to see your mama, your sister, your auntie, because that's exactly, you are who you serve. And we have to stop telling people, we have to stop expecting the people we serve to be resilient. And we, the structures and the funding, have to become resilient to serve the populations we are charged to serve.
Thanks. It is about, when I think about everything everybody has said, but we talk a lot about doing our own work, right? And I've been on this journey. If you're doing anti-racist work, you're doing your own work. And I've continued to learn a lot. You know, I knew a lot and I've learned a lot more. And I've already, I was texting our leadership team and talking to Stephanie as our board chair about additional training that we can do with our board, because our board represents health departments around the country. And we're talking about urban Indians, right? And where our urban Indians live, but the cities and the counties that our members serve. So how can we really help accelerate the work and thinking? But I have the same sense of these conversations aren't new. A lot of the stuff you could close your eyes and say, but I mean, the simple answer is let's just honor the treaties, right? Let's do what's in law and let's do what we're supposed to do. But so I also say run for office, look at who you vote for. I mean, those are all like we need to that at the system level. And there's other just things I wanted to highlight that people have said over the last 2 days, but I can send those in an email. Just things I think were said once, and I checked them off my list. I'm like, okay, that was said, but I think that's it.
Well, I think that one of the things my recommendation would be you have an opportunity to do something as a committee, right? This committee's been around for what, 30 years or something, and what changes have been made? We know not very many, especially for our people. And so change your narrative. We're always asked to look at our narrative and do something different. Why don't you all change your narrative and do some actionable items? You know, you heard a lot of information. You've got a lot of information. What is it you can do to propel some actual change for the lives? You know, this is, and as someone said earlier, and it might have been Deb, this is an emergent situation. You know, we're constantly in a state of emergency. American Indian people, we live this way every single day. And as Lisa said, we don't want to be a unicorn. We just don't want to be, you know, some mythical creature that comes around once in a while that you have to think about. What is it you can do? So undo some of the biases that you have and say, what is it we can do different to move and make that dial better for our people?
Thank you. Terrence, AMCHIP, what are you going to do? What are your advice to us?
First, I think the laser focus today is an amazing sort of first step. And at AMCHIP, you know, we firmly believe that there is no solution to the crisis that we are talking about, particularly the racial inequities and maternal mortality that Indigenous women do not already have. As published and practiced, Indigenous women scholars who have spoken, healthcare workers who have spoken, and many of the individuals around the table. And so as it relates to AMCHIP, AMCHIP's role as a membership organization can be to continue to support our members and listening to these solutions, actualizing these solutions. And then I point to the flexibility of the Title V Maternal and Child Health Block Grant and that hope to uplift and invest in those solutions, the solutions that I mentioned, of Indigenous and other women of color who are implementing them. And so we can support our members in striving to remove these fundamental health barriers, such as losing healthcare coverage 60 days postpartum and losing access to abortion care.
We want to thank you. And before a final comment, absolutely. There's always room for one more.
Okay, so one more thing. We talk about something. So ideas on what something could be that we could do as organizations would be to offer our platforms that we have, because as we know, we don't have the diversity that we need in the medical staff in any community. So being able to offer the platforms where we know that we have access to those clinicians and being able to help train them on just what is smudging. We heard that here. Did anyone look it up? Look it up. Right. So what is smudging? How can we accommodate that? You know, what is a cradle board? How is it used? Getting information so that we don't have CPS call for something that they don't understand. Those are some things that we can actually say that we can do. We can bring those stories to the forefront. It's out there, but if you're not looking for it, you don't know. So being able to use the platforms that these organizations have to put it on the forefront, and so that we can make the connections between all the people of color having the similar experience and not look at them in isolation as anomalies that just happened.
We heard this morning and started the day with our tribal organizational leaders, the Tribal Health Board, the Urban Indian health centers, those that are on the front lines from a tribal perspective. This afternoon, we begin to close up with the organizations that are on the front line of the MCH perspective. From this day forward, may they not be in separate places, but partnered, integrated, where we wake, where we work and where we do the work. And may this conversation not be a one-off. Shame on us. May it be the beginning of a fresh conversation with collective action that builds on the racial equity and anti-racism work you've already begun. Please join me in thanking my colleagues and family members for coming to this time. See my time, Dr.
Add
Ellinger.
my thanks to that of Magda. The fact that you are here today, that you took the time, I know all of your schedules are busy. So that makes a statement, you're being here. And I think, as Magda said, it's just the beginning, that you as organizations can amplify whatever recommendations come out of this committee. And moving forward, you can be a resource to this committee moving forward on other issues. So all of the ACIMM members, these are the people that should hold you accountable for what you're doing. And they should be resources for you to get information and ideas. So it is a partnership. ACIMM has a particular role. It has the ear of the Health and Human Services Secretary. That's what our job is, to make recommendations to him or her, or they, but we get information and it can be leveraged in other ways. So this partnership needs to move forward in a really robust way. And moving forward, we're going to take a 5-minute break and then we're going to come back. So move quickly, and then we will have Dr. Warren, and then we will get some public comment, and then we'll have Dr. Tina Padero-Lau.
Okay, excellent. Thank you. Thank you very much. Your neighbors.
That's what I said. I'm worried. And then I haven't been there, but you know. Okay, great. 1 minute left. I lived in Durham for 2 years.
I'll take it. I'll take it.
But I'm gonna shade it dark blue. 1, 2, 3. One more time. 1, 2, 3. So what were you doing in Durham?
Actually, was undergraduate.
Oh, were you okay?
Many more years. at
She's a
UNC.
Carolina person.
Three years of education at UNC.
You don't go with that.
So what was the significance of the 4 of you? There were North Carolina. So what made it North Carolina? I went to school there, but I wasn't.
You did?
What?
Where did you go?
UNC Chapel.
Okay. I went to NC State. I forget.
Well, did they have a master's in public health? See, that's why I went to UNC Chapel Hill, because they had a master's in public health.
Yeah.
I didn't do my other knowledge. I worked.
Yeah. So I'm almost turning blue. But thank you for this meeting. We have all been raving about how different this is at the other meetings at this level. And I know it had a lot to do with this.
Well, I just had a lot of help, pull people and people were agreeable to come. I mean, having Scott here for this, that's a lot. And I think he got something out of it. I think, and all of you can come again. Having all of these things, either come in person or virtually. I mean, everybody's busy. They make that kind of time for this because most people get cynical at it. Obviously, they're committed. They want something that so that puts the pressure on us.
Oh, but I believe it.
All right. Thanks for being here. Well, and you've had a couple of visits here. I know. Yes, it was a powerful first visit and powerful second visit. So very good. Keep up the good work. All right. Let's start to settle in. All right. Dr. Peck. Some people just like to chat. They love to visit. And I never want to be a meeting planner, but I had to be a meeting planner, and you need to build in a lot more just interaction time, communication time, non-schedule time. And I'll learn, but that's going to be in my next life when I'm a meeting planner, which I think that'll be hell. So I hope I don't have that. But I've asked Dr. Don Warren to take on a very important task, and I'm not sure if it's mission impossible, but when I asked him to speak, I said, you've got a lot of experience and you're looked up as a leader in American Indian, Alaska Native health, and have been offered a lot of wisdom over the years on how to approach this. I wanted him to kind of end up our formal presentations, sort of reflecting on what we've learned, what we've heard. We started by putting it in context with that first panel. What was the context? Now I want to kind of think about what did we learn and what's the new context moving forward? How do we take this sort of to the next step? How do we put this into the bigger picture of where we're moving and what our opportunities might be? And Dr. Warren, I think, is going to be the perfect person to do that. And particularly, I'm really excited about his new position at the Center for Indigenous Health and Indigenous Health Policy at Johns Hopkins University. It'll take me a long time to figure out all of those things. It's got to be an acronym in there somewhere. But good luck on that job. But welcome to ACIMM. Really appreciate you being here.
Hello, thank you and welcome to all my relations here today. I'm very honored to be a part of these important discussions. And I know we've had a lot of material that we've gone over the last couple of days and a lot of things that are very emotionally and spiritually heavy and mentally taxing, just to think of some of the suffering and the challenges that are going on right now. So I really applaud all of you for doing work in this space. Again, my name is Dr. Donald Warren. I'm Oglala Lakota, originally from a small town called Kyle, South Dakota, on the Pine Ridge Indian Reservation. And I always like to ask, who's been to Kyle, South Dakota? Wow, that's 4 people. That's 4 more than usual. That's actually really impressive. Very small community on the Pine Ridge Reservation. And I've worked in a number of different areas in medicine and public health over the years. I am a family physician, also have training in public health, particularly in health policy. And I've served on a number of federal advisory committees and other national boards. I was a member of the National Board of Trustees for March of Dimes for a number of years, working in this space, as well as serving on the National Advisory Committee on Rural Health and Human Services through HRSA, and then on several CDC committees as well. So I know this work is challenging and difficult and really trying to make a difference at the policy level. So I'd been on faculty at University of North Dakota for a number of years, and just as of last, let's see, what was say the 13 days ago, I took a new position at Johns Hopkins. I'm now the co-director of the Center for Indigenous Health and also the Provost Fellow in Indigenous Health Policy. And they're expanding their work to include international Indigenous health. But next slide, please. So what I'll cover, and it'll be an interesting task because there's been so much important information already covered, but I wanted to share some additional thoughts, just even on our definitions and how we describe ourselves. And Stacy Boland, I think, did a very good job of kind of delineating the different types of terminology, but I have a diagram that helps to explain it a little bit more clearly. Then we'll look at historical context as well as positionality. You know, where are we in physical space, but also where are we historically? And then just we'll look at some very brief discussions on the disparities, data issues, and then the recommendations report. Next slide, please. So when we're defining ourselves, we know the term is American Indian and Alaska Native, and that's actually the legal term set forth by the federal government. It's actually Office of Management and Budget that determines the races and ethnicities. I've never understood why it's OMB that determines the races and ethnicities in the US. But there's the 5 races, so American Indian, Alaska Native, white or Caucasian, Black or African American, Asian American, and Pacific Islander, and then just one ethnicity, right? Hispanic. So you're either Hispanic or non-Hispanic. So the legal term, at least in the census, is American Indian and Alaska Native. And I really appreciate the discussion on Alaska and the map, because not all Alaska Natives are American Indian. So the Inuit populations, for example, are more of a circumpolar population. So there's Inuit people in Siberia, Alaska, Canada, and Greenland. So if you call them American Indian, they get very angry with you, right? Okay, yes. But there are some people in Alaska, the Athabascan groups, who are also connected to American Indian populations. Athabascans are all across North America. So even Navajo and Apache tribal groups are Athabascan culturally. So that's why it's American Indian and Alaskan Native. So 9.7 million of us self-identified in the US Census. Next slide, please. So there's also within that enrolled tribal members. And to be eligible for Indian Health Service, you have to be enrolled in your tribe. So anybody on the census can claim American Indian or Alaskan Native heritage. There's no checks and balances. But to be eligible for services like IHS, you have to be enrolled in your tribe or a descendant and closely connected to your community. So next slide, please. So we've talked a lot about Indian Health Service. What's important to remember is that the IHS user population, so an active chart in the IHS is about 2.6 million people. So 2.6 million out of 9.7 million. So it's important to remember that the IHS database does not include all American Indians and Alaska Natives. There are people like me who have health insurance and live in a city in which there are no IHS facilities. So I'm not in the IHS database. I'm an enrolled tribal member and I'm American Indian on the census, but I'm not in the IHS database. So it's something important to keep in mind. We tend to look at IHS data as being representative of all American Indians, and it is not. It's actually a minority of American Indians are in the Indian Health Service database. Next slide, please. So we also look at the term Native American, and we use it interchangeably with American Indian. And I think it's even in the recommendations. We might want to be really consistent and intentional about what terminology we're using. Native American is also legally defined. In 1978, there was the Native American Programs Act, and it defines Native Americans as American Indian and Alaska Native, but also Native Hawaiians and indigenous people of the Pacific Islands like Guam and American Samoa. So if you're saying Native American and you're not including them, you're actually using the wrong term. So if we're talking about American Indian and Alaska Native, we need to be very specific about that. Next slide, please. So one of the other terms that's much more commonly used now is indigenous. And the indigenous peoples are the first inhabitants of various parts of the globe. So we kind of use some of those terms interchangeably, but if we're talking about American Indian and Alaska Native or tribal groups, we have to be very specific about the terminology that we're using. So we might want to be cognizant of that. And Stacy Boland from NIHB mentioned that earlier today as well. So next slide. So where we are now is in the land of the Dakota people. And I'm Lakota, or my tribal group is a little bit further west. So historically, we called ourselves the Oyate, and it's Lakota, Dakota, and Nakota. And the reason that it became the Dakota territory is that the Dakotas were further east and colonization came from the east. So that's why it became North Dakota and South Dakota. I always like to point out if colonization had come from the west, it would have been the Lakota territory and be North Lakota and South Lakota, and I would have worked at UNL instead of UND, right? But it was from this direction. So the Dakotas are in what is now Western Minnesota, Lakotas further west, and Nakota also were renamed Assiniboine, if you've heard of that tribal group, and they're further north. So you can see where we are in Minneapolis. Next slide, please. So if we look at this region and where I have been working in Grand Forks, North Dakota, where University of North Dakota is located, that's actually a sacred gathering point for Dakota and Lakota peoples. The reason it was called Grand Forks is that it was a confluence of the Red Lake River heading west and the Red River heading north. And people would gather there throughout the summer months. And again, the reason it was the Dakotas is because the Dakota people were further east. And then of course there's Minnesota. And out of curiosity, how many people know what the word Minnesota means? 1, 2, 3, 4. Wow, that's actually more than usual as well. Most people have no idea what the word Minnesota means, but it comes from two Dakota words. Mini is water and Shota means cloudy or smoky. So next slide, please. So this time of year, when the weather starts to change and it appears that the clouds are rising off of the water, that's a Mini Shota. So the Dakota called this region Mini Shota Makoche, the land where the clouds rise off of the water. Isn't that beautiful? This is the land where the clouds rise off of the water. And now we just call it Minnesota, right? Don't know what it means. So you probably flew into Minneapolis. Every time you say the word Minneapolis, pat yourself on the back. You're being bilingual you're actually saying water city in Dakota Greek, right? Again, Mini is water in Dakota, polis is city in Greek. So Minneapolis is water city. People don't realize that, but that's part of where we are. Next slide, please. So, and again, we talked about the tribal communities in the very beginning when we had our opening blessing from our cultural leader and knowledge bearer. He talked about the fact that there was a Dakota War in the 1860s, and most of the Dakota people were pushed west of the Red River into what is now North Dakota and South Dakota. So along what is now Eastern Dakotas, the Spirit Lake Nation, Sisseton, Wahpeton, Oyate, Flandreau, Santee, and the Crow Creek tribes are Dakota communities, and the ones further west are still the Lakota communities. And in what is now Minnesota, there's only 4 Dakota communities, and we're at one of them right now, Shakopee, Mdewakanton, Sioux community. So next slide, please. So I think it's important just to know where we are and some of the history, but I know most of you are from other parts of the country. And it's also important to understand the history and why we actually have things like historical trauma and intergenerational challenges and intergenerational poverty and marginalization and distrust. There's all these factors have an impact on maternal and child health and wellness. So next slide. So we know that the 13 colonies were not good for the indigenous peoples of what is now the Northeast. So yeah, next slide, please. Thank you. So the 13 colonies were devastating to the Northeastern tribes. I know many of you are from the Northeast, and you know there's very few American Indian people left in that part of the country. And I'm sure many of you have heard of Amherst, Massachusetts, right? Named after Lord Jeffrey Amherst. And Jeffrey Amherst is very famous in Indian country because he is the colonial governor who ordered the distribution of blankets from a smallpox hospital to the regional tribes with the purpose of killing them. So next slide, please. So this is well documented that the intention was to spread smallpox intentionally to the Northeastern tribes with the purpose of killing them. And you can actually Google this, Amherst and smallpox. And next slide, please. And you can actually find the letter written from Amherst. This is in his pen. I know it's in cursive and hard to read, but this is what he said. You will do well to try to inoculate the Indians by means of blankets, as well as to try every other method that can serve to extirpate or get rid of this exorable or horrible race. Extirpate this exorable race. I should be very glad your scheme for hunting them down by dogs could take effect. This is part of our history. It's not pleasant to think about. It's not pleasant to talk about, but it is the truth. And if we're ever going to get to equity, we have to walk through truth, even when it's unpleasant, even when it makes us uncomfortable. This is a part of our US history. And what do we do now? We honor him, right? We have Amherst College, UMass Amherst. We have a city named after him. We have statues of him. He was our first documented bioterrorist and killed many, many thousands of indigenous peoples in what is now the Northeast of the United States. It's a true part of our history, even though it's not taught effectively in our history books. Next slide, please. So that explains why there's relatively few American Indians in the Northeast, but in the Southeast, there was a law passed in 1830 called the Indian Removal Act. And the Indian Removal Act removed tribes from their homelands in the Southeast to what is now Oklahoma. So next slide, please. And this map shows the pattern of tribal migration, forced migration from their homelands into what is now Oklahoma. So as a result, some of the tribal members refused to leave. They stayed in their homelands, and some did get removed to Oklahoma. So that's why we have this interesting dynamic where we have Seminoles in Florida and Seminoles in Oklahoma, Cherokees in North Carolina, Cherokees in Oklahoma, Choctaws in Mississippi, Choctaws in Oklahoma. So you get the idea. Of the 38 federally recognized tribes in Oklahoma, only 4 are actually from Oklahoma. The rest were removed from other parts of the country. So that's why we have that interesting dynamic now and why we have so many tribal nations in the state of Oklahoma. This was also called the Trail of Tears. I'm sure you've heard of that terminology as well. Next slide, please. So the discovery of gold was devastating to the California tribes. And there was a time when there was a bounty, it was actually legal to kill American Indians to make way for the gold rush. It was actually legal. There was a bounty. There's many articles written on this, just not in our history books, unfortunately. So next slide, please. So what we're left with, this is from the 2020 census. You can see the states that have the highest concentrations of indigenous people. So Alaska has the highest concentration of its Alaska natives. And then you can see other states like Oklahoma, New Mexico, South Dakota, Montana have at least 6% American Indian. Other states like Washington, Oregon, Arizona, Colorado, and Wyoming and North Dakota have at least 4%. So our numbers actually grew significantly from 2010 to 2020. And I don't think it was actually true growth in the population. It was better response to the census is really what happened. There was a lot of outreach that was conducted even in the midst of the pandemic. So you can think about where you're from, and you might be from a state that has relatively few American Indians, but there's a reason for that. There's policy-based reasons put forth by the federal government that removed people or killed them. That's why we have such a small population now. So next slide, please. So I've done a lot of work in this space, really trying to understand the impact of historical trauma and how that directly links to current day health disparities. And we just have to be honest, there was genocide in the United States. That's what created opportunities for this country to grow. And again, it's not comfortable to think about or talk about. And I talk about these things not to make anyone feel bad. That's not the intention. I talk about these things because it's the truth. We have to understand the truth if we're going to get to real solutions. Next slide, please. So there was also the boarding school era, and I'm sure many people are familiar with that. There was actually a report put forth by the Department of Interior just this past May, looking at the history of boarding schools in the United States. And this was forced removal, and I know a couple other speakers have talked about this. But the way that the families were compelled to give up their children is that when the populations were put onto reservations, they lost their food sovereignty and they lost their food systems. So our populations became dependent on the federal government for food. So the families were told, either give up your children to go to boarding school, or we will withhold your rations. So give up your children or starve. That's the message from the federal government. This is well documented as well. Again, not documented in our history books because it doesn't paint us in a very good light, but again, it's the truth. So that's how our children were compelled to go to boarding school. Next slide, please. So in the boarding schools, if you visit them now, most of them have a huge graveyard right next to them. And the reason is we had huge mortality rates of children while they were at boarding school. We don't know why so many children were dying and the basis for all that excess death. We know there were outbreaks of things like influenza and tuberculosis, but it doesn't answer the question as to why so many children were dying at boarding school. And this is a picture of the Carlisle Indian School in Carlisle, Pennsylvania, where many of our children perished, unfortunately. Next slide, please. This other picture is a famous picture. It's a school picture at Carlisle. And I have 4 children and I've seen lots of school pictures over the years. And I always see smiling, I see laughter, and I see joy. I don't see any of that here. I see a lot of fear. I see a lot of anger. I see sadness. And we're talking about thousands and thousands of American Indian and Alaska Native children sent to boarding school, including my mother. So my mother is a survivor of boarding schools. This is not ancient history. And I would strongly encourage you to read the report that was put forth by the Department of Interior just in May. And the reason we finally did this is that for the first time in history, there's an American Indian in the cabinet, right? The Secretary of Interior is Deb Haaland, who happens to be American Indian. Isn't it remarkable? It took until 2021 until there was an indigenous person in the cabinet of the administration. So that's why we actually had this report. Next slide, please. One of the purposes of the boarding school system was to get rid of the culture. The motto was kill the Indian, save the man. And this is another famous picture of a Navajo young man upon entering Carlisle and then 3 years later. And this was shown as a success story, that this was the purpose of the boarding schools, is to get rid of the culture. Next slide, please. So what is the long-term impact? And one of the research projects that I'm a part of is actually looking at epigenetic and potentially intergenerational epigenetic changes to DNA. as well as intergenerational measures of inflammation and allostatic load. So we're looking at boarding school survivors and their adult children and looking at patterns of changes to DNA. And we haven't finalized all the research yet, but there's some compelling evidence in other populations, including Holocaust survivors from Germany, and that Jewish Holocaust survivors' descendants tend to have worse health status than matched controls who were not direct descendants of the Holocaust. So there's some evidence that there's some sort of epigenetic basis for historical trauma. Still has yet to be fully elucidated, but I think this will be the scientific platform to better understand it. Next slide, please. So once we get through the boarding school era, we also have to recognize there's a lot of gestational stressors and a lot of unplanned pregnancies. And in my own experience as a family doctor, we've tried so many different methods. And I remember there was a public health nurse on one of the reservations where I worked. And they tried everything they could think of to try to prevent pregnancy in the teenage girls. And, all the educational programs and, free condoms, whatever they could do. And nothing seemed to work until the public health nurse decided to pay the girls $5 a week to not get pregnant. And that was the most successful intervention, believe it or not. It was never evaluated or studied, but even the boyfriends are saying, let's not get pregnant. We could use that $5 every week. When you're impoverished, that's a lot of money. This is back in the 1990s. So just as an FYI, maybe we can be more creative. I think someone even talked about paying people to go to prenatal care, right? So once we get through that, then we have other types of stressors. And the USDA sponsored food programs have improved tremendously. There's actually going to be a White House summit on food and nutrition coming up at the end of this month. So if you're interested, they're going to be looking at some of the policies related to food, and that certainly has an impact on maternal and child health as well. So the WIC program, Women, Infants, and Children, has done a lot of work in recent years to promote breastfeeding. When I was a full-time clinician in the 1990s, the WIC program was basically a baby formula distribution center. And as a result, we wound up seeing more use of baby formula among American Indians and among the white population because it was free baby formula, basically just distributing it. So think about the word formula. Does that sound appealing to anybody? Come on over, we'll have a glass of formula, right? It's formulated in a laboratory and it's not natural and it's not healthy. Then there's the food distribution program on Indian reservations or the commodity food program. So next slide, please. So when we think of traditional American Indian food, a lot of people think of fry bread, right? You heard of Indian fry bread. Well, it's actually not traditional American Indian food. It's people doing the best they can with their commodities. The elder on the right there is using commodity shortening and commodity flour to make fry bread. So if we want to call this traditional food, it's traditional USDA food. It's not traditional American Indian food, but now it's been acculturated. And I wonder about the nutritional epigenetics. What's happening to our children when they're taking in this type of food at such a high rate? Next slide. These are some pictures of commodity foods. And I know it's in fine print, but on the right, this is pure corn syrup. So it's an engineered food. It's not natural. It's incredibly unhealthy from the USDA. And look what it says right here. Use in baby formula. Use in baby formula. What is the nutritional epigenetic impact of generations of this type of policy on our children? And we know that as a population, formula-fed babies grow up to have higher rates of diabetes, heart disease, and obesity than breastfed babies. So, and then all kinds of food, I don't know exactly what all of the ingredients were. I grew up with eating a lot of these foods. That's where government cheese comes from, right? The commodity cheese. I really like commodity cheese. I wish I didn't, but I actually do like it. It's kind of really valuable if you can get a brick of cheese. But the other foods were just really unhealthy. And they had grape juice, which I think was just sugar, water with purple food coloring, basically. But this is what we were feeding people for many, many generations. And now we wonder why we have such high rates of diabetes. It's because of these types of programs. Next slide, please. So we also know that we have higher rates of adverse childhood experiences, and I'm sure everyone here is familiar with the ACE studies that have occurred. Next slide, please. One thing I'm very happy about and proud of my friends at CDC particularly in the National Center for Injury Prevention, is that the ACE pyramid used to have ACEs at the base, right? That was the bottom, and then all of the outcomes flowing from adverse childhood experiences. But the new ACE pyramid recognizes that there is generational embodiment and historical trauma that can create the local conditions in the community to put families at higher risk for adverse childhood experiences. So let's not blame the families and the patients. Let's look at the actual basis for these types of risk factors. So CDC, thank you for actually recognizing this and putting us in print. Next slide. Well, we know the outcomes from adverse childhood experiences, and I was co-principal investigator on the South Dakota Health Survey a number of years ago, and we found just terrible disparities in adverse childhood experiences among children and all of the associated health conditions and risk factors with that. So next slide, please. Yeah. So the adversity does not end at age 18, right? We have adverse adulthood experiences as well. We have a lot of toxic stress in our communities. Living in poverty is stressful. Living under marginalized conditions is stressful. Dealing directly with racism is stressful. And when I think about the measures of inflammation, the amount of cortisol and epinephrine that's coursing through our people's bodies at all times is really tremendous and puts us at greater risk for poor health outcomes. And not surprisingly, our average age at death is much worse for American Indians. We just ran the data in North Dakota for the decade of 2009 to 2019, so the 10 years prior to the pandemic. Average age at death for the white population in North Dakota was 79. Average age at death for the American Indian population in North Dakota was 58. 21 years difference in average age at death. That's statewide, even worse in some of our reservation communities. So next slide, please. So what are we doing about this? And what are the factors that we need to address here? And again, I appreciate being a part of these important discussions and won't go into too much detail regarding the disparities. We've already talked about that, but we know we have worse maternal morbidity and mortality, and we have worse infant morbidity and mortality for American Indians. And we did hear just a compelling story about preeclampsia and that direct experience and what can happen, especially in a remote and rural environment. Next slide, please. Again, with my work with the March of Dimes, we were tracking the data for infant mortality as well. And in South Dakota, the infant mortality rate for American Indian population was 8.9 per thousand live births compared to statewide of 6.2. So much worse for American Indians. Next slide, please. In North Dakota, the disparity is even worse. 9.4 compared to 5.5 for the overall population. But we already know these numbers, right? These are well-known disparities. So next slide. So I've read through the draft recommendations, and I really appreciate all the work that's already gone into those draft recommendations. And I also really appreciate the fact that you're using the Broken Promises report from the U.S. Commission on Civil Rights. It was published in 2018. That's a really good document to look at underfunding federal programs for American Indians and Alaska Natives. So next slide, please. And I'll just go through some just general thoughts and what might be added to it or thought about. There's just some considerations. So in the introduction and framing, we should also make reference to the strengths, resilience, and wisdom that exists in our communities, and that we have a lot of culturally based solutions as well. We tend to focus so much on the disparities and the negativity because that's a compelling story, but in truth, we have a lot of answers within our communities and a lot of strengths that should be a part of that. And there's mention to include Indigenous individuals as active participants. I'd even take it a step further. Indigenous people should actually be key leaders and decision makers in moving forward with recommendations and implementation of those recommendations. Next slide, please. So in the framing and historical context, there's really no mention of the boarding school era. I would refer to this document because it's very compelling. And so many of us as Indigenous people have family members who went through that experience very directly, and it has an impact on intergenerational parenting. So I think it's worth mentioning specifically the boarding school era. The federal government has acknowledged it. We need to include that as part of the background. Next slide, please. Also then include root causes, including racism as part of the social determinants, and really make recommendations to have a deep dive to uncover and understand those deep roots of structural racism that persist and how those have an impact on our families, on our pregnant women, infants, and children. And there's structural racism across the board. You know, even when we look at our ability to access resources. And a little later, we'll talk more specifically about things like the Title V block grant. But we're really depending on the friendliness and kindness of the states as to whether or not American Indians get access to those resources. And if you think that all of the states are friendly to Indians, you're not paying attention, all right? We've got to look at this in a very serious way. And there's structural racism that's even a part of whether or not those resources get to the people who need it the most. That needs to be a part of that discussion. And then commit to ongoing exploration and learning about what allyship and full partnership actually really looks like. We have a lot of wonderful allies and champions and partners, but we really need to, I think, frame that in a way that's genuine collaboration and not just looking at capacity building as someone from the outside building our capacity, but genuine partnership. Next slide, please. So also looking at expanding the programs and caregivers, we had a lot of really good discussion about doulas. We have a lot of good data to support the use of doulas and other paraprofessionals, but we don't have access to all of those services in each of our communities. And there does need to be recommendations even for Medicaid as payers and for certification programs to make sure that we're having more locally certified midwives and doulas and culturally relevant interventions. Next slide, please. In addition, we have inherently protective teachings within our cultures. And, you know, long before we had formula, everyone was breastfed, but there was even a system because not every woman can easily breastfeed. We know that there are challenges. Some people just have challenges with successful breastfeeding, and we don't want to marginalize them or traumatize them, you know, by delivering the message that they have to breastfeed. But if they can't, what if there's a challenge in doing that? Historically, we had wet nurses. It was part of our culture, right? We had a communitarian approach to this. And then we've talked about other things like the cradle boards and back to sleep. You know, there's a lot of things that we have done throughout history that are consistent with what we're calling evidence-based practices. And I think it might even be worth pointing out that modern science is finally catching up to indigenous knowledge, right? That's the way it should be framed because it's true, all right? So next slide, please. Telemedicine was talked about, and I think that's a great idea, but it's not for everyone. Some of our populations respond well to telemedicine, so we need to make it available. But for some people, they don't respond well to it. So it's not going to be a one-size-fits-all solution for each population. And I have all these written out that I'll email to you as well. And you can have the slides, obviously. So next slide, please. Medicaid expansion, that's been mentioned before. Of course, that's a state-by-state decision. One of the things that National Indian Health Board has looked at is the whole idea of a 51st state being American Indians. Why is it that state legislatures are the gatekeepers between federal dollars and American Indians? Think about that. When an American Indian is seen at an IHS or tribal facility, that Medicaid payment is 100% federal dollars. The FMAP, the federal medical assistance percentage, is 100%. So you have 100% federal dollars, you have American Indian patients, and then you have a state legislature standing in the way saying, no, you can't have access to those federal dollars. That's the circumstance that we're dealing with right now in places like South Dakota, where I am from. That is unacceptable. That needs to be part of advocacy, is get the state legislatures out of the way of access to federal dollars for American Indians. I really think that should be a part of what we're advocating for. In addition, for doulas, looking at the accreditation process, if we're just going with the existing national accreditation processes, for many people, it's cost prohibitive. We should have recognition of tribal sovereignty and tribal certification of doulas. I think that was mentioned before. Yeah, very good. Excellent. Next slide, please. And I'm so happy that we heard from Deborah and Healthy Start. So in one of my previous roles, this is now going 15 years ago or so back, I was the executive director of, at the time, the Aberdeen Area Tribal Chairman's Health Board. It's now the Great Plains Area Tribal Leaders Health Board, but we did have a Healthy Start program there. And the challenge, as was mentioned, is that our reporting requirements, our data collection was kind of the one size fits all approach, right? We were working with 4 states, 17 tribes, and trying to do that in a remote way. We can't have the same practices that would occur in Chicago, where you have a relatively small geographic area. We're talking about 4 states. We're talking huge regions. We're talking about rural and frontier communities. So the one size fits all approach doesn't work for us. And it's evident in the data, right? There's 2 tribal programs now for Healthy Start. Think about that. The primary program for HRSA is funding 2 tribal programs. And the competitive nature of getting those dollars, the communities that need it the most are the under-resourced communities. Guess what? They don't have a team of grant writers, right? Do we need to convert all of our local people to grant writers in order to access resources? That's just wrong. And I'm really looking forward to reading the recommendations coming from Healthy Start, because the way the system is set up now, the populations who need the resources the most do not have access to those resources. That's something that can be fixed. For McVie, it's been wonderful. I think we see a lot of really good evidence with McVie. When I was on faculty at North Dakota State University, this is now 10 years ago, 8 to 10 years ago, we were doing the evaluation of the McVie programs, the tribal McVie in North Dakota, and some really good outcomes. And there's the 3% carve out for tribes. So the states get it on a formula basis, and then the tribes compete for it, right? That's just the nature of it. Maybe we need to look at how that's funded as well. Title V, the state block grants. If you have a friendly state, those resources get to American Indians. If you are from a place like South Dakota, it's not a friendly state to American Indians. It is adversarial. And I think there needs to be more language in the requirements that if you have American Indians in your state, you need to demonstrate exactly how you're using those resources to improve infant mortality rates in those populations. It's basically up to the states in terms of what degree they report those data. That's not good enough in states like South Dakota. We need to enforce adequate reporting from the states, because the way the legislation is written in Title V of the Social Security Act is that it's with the states. It's not with the tribes. So to change that would be an act of Congress, or we could just make the reporting requirements meet the needs of tribal people. And we've had a lot of talk about IHS funding. And I think for Indian Health Service, I've seen a real change over the last couple decades. That I think IHS has been beaten up a lot, and we're seeing it change the behavior too, that they're less engaging now. I think we see that even here. So we have to recognize that IHS is not a failed system, it's a starved system. It's never been adequately resourced. We don't know how good IHS could be if it was actually funded. So next slide. So been some mention of data sovereignty, so I won't go into too much detail there. And this has been wonderful 2 days of discussions. But another consideration would be to expand the tribal PRAMs programs and having more specific data collection about pregnancy and the data in the tribal communities. Next slide, please. And then just in the last couple slides, just talking about some of the programs that I'm affiliated with now through Johns Hopkins. Family Spirit, hopefully you're familiar with this, but it's a wonderful program, and it's the only evidence-based home visiting program designed for, by, and with American Indian families. It's now used in over 100 tribal communities across 16 states, but it's largely dependent on grant funding, right? If these programs are evidence-based, they should be reimbursable, right? That it's not, shouldn't just be dependent on whether or not the grant is going to continue. I'd strongly recommend looking at the website for Family Spirit. Next slide, please. Just a few of the components of that. It's kind of like a McVie model, but it leverages local cultural assets and indigenous ways of knowing about health. It encourages the use of paraprofessionals and addresses behavioral health disparities. And next slide. there's been some very good publications on this as well. So just recently, there's been 3 randomized controlled trials using this curriculum. And the most recent study showed that family spirit significantly improves parenting efficacy, reduces mother's drug use and depressive symptoms, and improves social, emotional, and behavioral development for children through 3 years postpartum. This is evidence-based, it's working, it needs to be scaled up and implemented in other communities. So next slide, please. So I'm sure many of you have seen this slide or similar images looking at the differences between equality and equity. And I just really like this image because on the left, it's the one size fits all approach to equality, right? Everyone gets the same curriculum, everyone gets the same healthcare, everyone has to follow the same reporting requirements for a grant, everyone has to compete for the same type of grant at the same level, as though everyone was the same. We need to be smarter than that. And an equity lens is not looking at the process or the box on which people are standing, but the outcome, right? And we might need to do unique programming for some populations. And that just means we have to be flexible. And that's it's easier said than done, I recognize that. But that's got to be part of our solution. And I'd shown this image for years. And a few years ago, someone sent me a slide that I think is just brilliant. So next slide. And the question is, what is that fence doing there in the first place, right? Is it just the package of services to overcome the barrier, or do we need to get rid of the systemic barrier? And I would put forth that so many things we've talked about, like poverty, lack of American Indian providers, all of these things are systemic barriers. So it's much bigger than what can be done within one agency, but we have to be a part of that broader solution. So next slide. And just in closing, I did 40 minutes instead of 45. I'm sorry we're running late, but we learn a lot from the natural world in my tribal traditions and lessons. And one of the things that we observe in this part of the country is the bison herds. And the strongest bison, when there's a storm, stand and protect the ones behind them, the ones who are more vulnerable, the elder, the weak, the children. And the strongest bisons stand and face the storm directly. It's a beautiful image when they're doing this. And I would put forth that each of us has the opportunity to behave in that manner and to be that strong force facing the challenges directly, because there's so many vulnerable people behind us who are depending on us doing exactly that. Next slide, please. And I'll go ahead and end it there. Thank you all very much.
Dr. Warren, thank you very much. Will you be able to stick around for a little while? Because we have 2 things that I really need to get in before 5 o'clock. We have public comment, which we have to do. And Dr. Tina Patera-Lau from IHS, want to give her a little bit of time. She's been on the video, so, and she has to leave by 5. So I want to build that in, and then I want to come back because there's lots of things that Dr. Warren talked about. And I appreciate the time you took to go through our recommendations and come up with some really important and perfect recommendations from my standpoint. So thank you. Lee.
Yeah, good afternoon, folks. Again, this is Lee Wilson, acting as designated federal official for this meeting. As I said yesterday, we are a public meeting under the Federal Advisory Committee Act regulations. And this is our opportunity to provide public comment to those individuals who have contacted us about that public comment. We have received a number of requests for public comment, and I'm going to take them in a particular order just because we are short on time. First, all of the public commenters appear to be with us virtually. So I'm going to start with Candy Hadsall. If Candy is still available on the line with us, please go ahead, Candy. Okay, thank you. I have been communicating back and forth with Candy because of the delay. She was probably not going to be able to make it, but I did want to provide her an opportunity. We may try, I've sent her a note, provide her an opportunity to share her public comment with you tomorrow, if we can find the space for that. If not, we'll have something in writing. Let's move to April Phillips, who is with Frontier Nursing University. Go ahead, April.
Hello, everyone. My name is April Phillips, and I'm the Clinical Director of the Psychiatric Mental Health Nurse Practitioner Program at Frontier. And my question is such. According to the MMRC most recent report, it was found that 11% of maternal deaths were due to some mental health condition directly. A recent study found that American Indian women have a 62% increased risk of developing a mental health diagnosis in pregnancy. And a recent California Health Foundation report found that as many as 30% of African American mothers reported anxiety and depression in pregnancy and postpartum. Given that 72% of women with perinatal mental health conditions never receive treatment, what strategies can we implement to provide mental health services to pregnant and postpartum women? And also, how will the needs of these vulnerable populations be addressed?
So April, again, this is Lee Wilson. Just wanted to say that this is not a question and answer period so much as it is an opportunity for you to provide comment to the committee or suggestions. So I realize that as part of the questioning, you may likely have some suggestions or recommendations or areas of deficiency that you would like to call out. So are there any of those points that you would like to make to the committee?
Yes, absolutely. So I think there is a dire need to increase access to care, certainly during prenatal period and postpartum.
Thank you. Are there any questions or comments that the committee would like to make back to April? Seeing none, thank you. We appreciate your feedback, April, and if you have further information that you'd like to provide to us, please do in writing. We will be accepting them and we will share that information with the committee. I'd next like to recognize Lori Roth, who is from Region 9 HHS, and I'm wondering whether Lori is on the phone and is able to speak with us.
Lori, if you're present, please use the raise hand function in Zoom so we can identify you.
Hearing nothing from Lori, the final individual or organization that had requested an opportunity to make public comment was the Association of Black Cardiologists. We did not receive a specific name indicating who would be the speaker, but I'm wondering whether or not there's a representative from the Association for Black Cardiologists with us. All right, then. Thank you. This concludes our public comment period.
Thank you, Lee. And I do apologize for, I usually like to run a tighter agenda than we've had with this one. So we didn't make enough time for the public comment. We could, if there is other public commenters, we could make time tomorrow for that to occur, because that's really important. But now I would like to open the floor for Dr. Patera Lau from IHS. I know, Dr. Patera Lau, you've been monitoring what's going on here, and I think you heard yesterday we had some discussion about IHS. So I'm glad you're here. Thank you, and appreciate your presence here today.
Oh, absolutely. Thank you, Dr. Ehrlich, and members of the committee for, again, inviting me to participate virtually, to the administration for putting together the meeting, to our panelists, just demonstrating amazing honesty, strength that really I've only heard behind closed doors and had the honor of and privilege of sharing with you. I do want to apologize that I am not physically in the room with you. I just wanted to let you all know that I have been listening since day one on behalf of IHS and our patients, as I'm on, as Dr. C mentioned, pre-planned travel for site visit later today. I am, for the committee members, as you remember, and I introduced myself in June. I'm an OBGYN, spent the last 7 years in Phoenix, PIMC, Flow to Peach, Parker, now doing deliveries at Playwise. And started in the MCH role back in May, met the committee and presented in June. And my role is basically to serve as subject matter expert, something that hasn't existed in the IHS for the last 2 years. So as you mentioned, the attention and the spotlight is on MCH, and that is my goal, my job. For example, the CDC has been in talks with me about looking at their AIA and data to make sure that we are accounting for every single, in this case, we're looking at cervical cancer screening and cancer cases. I was just on a meeting this morning with her, so they reached out because they wanted to look at their cervical cancer screening practices and then looking at how we can be more attuned to the culturally sensitive needs of our patient population, and looking at my work again in the last 7 years. And also looking at community partners. I know Dr. Warney mentioned Family Spirit. I've actually been in talks with Kristen Speakerman because Family Spirit has been part of IHS for several years, and we'd love for that partnership to continue, again, being such a benefit to our patients. The two things I just wanted to share with the committee and for the panelists, one is, the first is that I hear the pain, the loss, the healing, and the call that there is more work to be done. And I hear it loud and clear. And that is my passion. As you know, my heart is with our patients and our staff, and I will continue to invest in ways to move the needle again in the short time that I've been in this role. The second, I wanted you to know that, again, IHS may not physically be there, but I have been actively listening on behalf of our patients. As I've learned from my care, it's our role to listen, learn, ask questions, and we can always do better. So again, thank you for allowing me to speak. Again, we've been reaching out to some of your panelists, Lynn, Heidi, and Phoenix. If you would like to, talk about practices in Phoenix and how we can work together. Nicole Gonzalez, we're working with the 12th Native midwife to help look at mentoring practices for Diné or Navajo midwifery students, because we want to, again, mentor them and bring them through the training programs. And then Rhonda, Arbra, and Dr. Layton Thurman, I apologize. I completely agree with you. We have to be creative. We have to think outside the box. Things that we've done so far, the home visits, Dr. C mentioned getting blood pressure cuffs out to the field so our patients don't have to make that long trip and that long travel, and perhaps can do some of their care, over telehealth. And we know there are mixed feelings about telehealth, but there was one thing in the pandemic, and that is that we had to shift to incorporating telehealth in our prenatal care models and behavioral health. And we noticed that while there are still challenges, broadband access, patient familiarity, it helped us expand services. It helped us provide care to those patients who were at home and needed childcare or transportation, and those were barriers to access. And so we hope to continue that, looking at patient navigator and patient advocate roles in the IHS. So again, I'm here to listen, I'm here to learn, and I'm here to work with you. Thank you.
Thank you, Dr. Patera. Just two things. One, I know and I appreciate the fact that after our last meeting, you did go over our draft recommendation and submitted some suggestions, which I've incorporated into our draft. I would appreciate it if you could take another look at that more recent draft, which we'll get to you. And if you have any other additional comments, particularly those related to IHS, would really appreciate hearing about that. The other is, I know that we will be having some recommendations related to the Indian Health Service. And I think those recommendations will encourage continued dialogue between this committee and IHS in terms of finding out what's going on, what kind of information is out there. So I anticipate for the committee moving forward, we're going to be seeking additional information on an ongoing basis. So I hope that the relationship is one where we have this partnership of asking questions, getting information, having dialogue, and moving forward. And I'm wondering if there are any other questions that we'd like to pose to Dr. Patera at this point from the committee.
I'd be happy to review, sir. And yes, I would like to continue the conversation on behalf of both myself and Dr. C.
Great. Thank you very much.
Just for the record, I'd like to say to the committee in response to the discussion that we had yesterday, regarding the relationship with IHS. Dr. Patera Lau has been in this role for a very short time, a number of months, and in that time we have had a tremendous amount of engagement with her and with the office out of Rockville as a result of her involvement with us. So it has been a tremendous opportunity for us to bridge that gap, and we look forward to continued conversations, information sharing, and hopefully resource sharing in both directions. So I am hopeful that given your commitment to working with us, as demonstrated over the last few months, that we can continue to make progress from here. So thank you. We appreciate it.
Thank you,
Thank you.
Dr. Patera Lau. Dr. Warren, would you be able to come back up and take some questions from the committee? And again, thank you for the great presentation that you made. You can, up there would be where you have a microphone. So questions for Dr. Warren. And you said that you did have those recommendations written down so we can get copies. So I think a lot of it,
Yeah.
excuse me.
So you can have the slides, but also I do have the written recommendations on the Word document too.
Dr. Peck.
Well, first, I want to thank you, Dr. Warren, for being one of my great teachers. I've learned with you and from you since my time in Nebraska and before that. And to see how you are now continuing a difference from different vantage points and help us make a greater difference. I just want to personally extend my gratitude for you for being one of my mentors. I'd like some help with language, because how we tell this story was your feedback on framing and going from mild not being acceptable, in the words of our current HHS secretary. So can you go a little deeper on positionality? I'm just going to give you a couple at a time. So when you talk about positionality, that struck me. Can you help me understand that better?
Yeah, so it has a few meanings. One is just even the physical space and where we are, but then also other types of the space that we occupy, and even our framework of where we are in history. And so the cultural, historical, and even the physical space in which we're currently existing, because this work would be very different if it was 10 years ago. It would be very different if it's 10 years from now. And even looking at the discussions of the local communities and who's here. So I think just recognizing that there's a relative nature to time and space, and we formally recognize it in many indigenous cultures as part of our framework for even having discussions about where we are in history, where we are physically, where we are culturally.
Two more, if you would. The notion of adult ACEs, that addition to the, we've been talking life course for a long time with Michael Liu and Neil Halfon and others that institutionalized that. The movement from along the life course from childhood trauma to adult trauma. And then I'm curious about listing parenting in a slide around adult trauma. And we certainly heard, and I'm curious, not surprised, we've heard stories of parenting in birth trauma. And so I was wondering in your work and in recommending to us, how can we build on this adult trauma and adult experiences that then build on the cumulative toxic effect of acute childhood events?
Yeah, it's basically looking at toxic stress that is across the lifetime. And unfortunately for a lot of our populations, those stressors are there at all times and across various age groups. So obviously, childhood trauma is very well studied and has a huge negative impact. And there have been some good studies looking at toxic stress in communities as well and its association with poor outcomes. But also, for a lot of our people, what they're doing is self-medicating their childhood trauma with various substances and anything that could make them forget their trauma for a little while. And in that setting, we We also wind up seeing unplanned pregnancies. We also wind up seeing in some of our communities where the solution is to try to incarcerate our way out of the problem, which is never going to work. It's just going to make more trauma for the next generation. So we see this intergenerational challenge. And I think it's important to remember that the children who've gone through abuse and neglect eventually become parents. And what have they learned about parenting? So that's why that we're part of that cycle is historical and intergenerational, but sometimes it's just even within one generation, we can see those cycles continuing. So the cumulative effect of toxic stress is across the entire lifespan. And in truth, even prenatally, what's happening with toxic stress during pregnancy and its outcomes.
My last, and I do things in threes, so thank you, Dr. Ellinger. Thank you for language. To get through equity, we walk through truth and painful truth. And one of the ways that you told that story of truth is to talk about weaponization of seemingly harmless things. The weaponization of blankets in the form of disease, earliest bioterrorism, with the goal of eradication, the weaponization of removal of children as the threat and starvation in exchange for supposed education, the weaponization of food commodities with explicit instructions on how to do harm for generation by the addition of an unnatural substance in lieu of the most natural. And the consequence being the chronic disease, diabetes, and more. And so this language about blankets and disease, this way of telling the story, I just want to thank you for that. And because I think how we frame this, which is what your advice to us is, how we frame this needs to be in line with how you're framing it and how Indigenous communities want their story told. We can't tell this about you without you. So I just wanted to acknowledge the framing of weaponization of things that are in some context additive and other deadly, and to wonder if you might be willing to help us further after today in this framing piece as a partner so that the story and stories sing a better future.
I'd be honored to do that. And thank you for picking up on that, because things that should be innocuous, like blankets, education, and food, have been very harmful based on the way they've been implemented.
And strategically so, with a very clear, insidious, deadly intent.
Thank you. And thank you, Dr. Warren. This is a few comments in general, because I believe that your presentation helped just inform more about our concerns in our country, in Indian country in particular. But, the adverse childhood experiences across the lifetime, from even before birth until death, whatever that takes you, and that definitely the substance use as a way to self-medicate, and not just through adulthood, but for childhood as well. I started drinking when I was 9 years of age and huffing gas at that time as well to deal with my traumas. And a close friend who lived in our HUD housing project died huffing gas. And that was when I stopped. And that was at age 10. So it is very much alive and continues today. So these are not things that are delayed that happen, but also while you're children. This is what we're doing to also self-medicate and heal, but not really heal. And the issue that you talked about, that states, when you have a friendly state, when you have a state that's going to be kind to you, is reflective of racism and the structural systems that we have in play, and this push and pull. That even to have a casino, even though we are sovereign nations and we have rights to our own economics, to even have a casino on our lands, you have to go through a state process. You have to get a governor on board. There is a whole process that's lengthy about that. So our economics are controlled even by those who are in power in the state. And I remember not too long ago, Dr. Warren, when maternal mortality rates were blinded by state. We did not know which states had the highest maternal mortality rates. That was not too far long ago. And when you shared a slide of all 50 states, we could not pick out whose state had the highest, and it was only recently unblinded. So there is power in the states controlling, the states having power in terms of whose bodies have access, whose babies are being taken, whose bodies are harmed. So it is, I would push us to consider what kind of action we can take that it would be pressing the government to press the states to do this work. And finally, the last comment is Indian Health Service. I shared with Dr. Warren, Dr. Owens, that, and Dr. Tina Patera-Lau knows this, and Dr. Christensen knows this, that IHS is like the messenger, the starving messenger almost, who has been given the task to provide a number of tasks, that are almost insurmountable. But it is largely the problem lies with our government, with the federal government, because that is where this stems from. It is not necessarily, it's not Indian Health Service. They're starving, as Dr. Warren has stated. It is the larger government. So my question to you, Dr. Warren, is universal health care a possible solution?
Absolutely. And that's for, across multiple populations. And isn't it remarkable that we are having those discussions, and there's other nations that are already doing it, much more effectively than we are. We're spending a lot more money and having worse outcomes in so many other nations. So absolutely, there's better models than what we're doing. We have this very odd public-private healthcare system that's obviously, incredibly complex to understand, but even more complex to try to change. So, we don't want socialized medicine in some sectors politically, but we don't want anyone to touch our Medicare, right? So we have a lot of government spending in healthcare, but we also have a private sector that makes incredible profits, just looking at the insurance sector. So we have a very odd system, and I don't think anyone would have ever sat down at a conference room table and design the system that we have. You know what I mean? This is not intelligent design. It's just evolution of multiple stakeholders and their priorities. So yeah, I think long-term for the entire nation, that would be a less expensive, better outcomes approach. But it's been tried before, and politically it's very difficult. And I think getting more and more difficult all the time. But I'd say specifically for IHS, IHS doesn't determine its own funding levels. That's Congress. And I'm always, I don't even know what the right word is. I'm stunned, I'm surprised every time I hear Congress criticizing IHS. Well, who's funding it? They should be criticizing themselves for starving a system that's responsible for taking care of my relatives and your relatives. That's the fault of Congress. And the analogy that I use is if you need a full tank of gas to get from point A to point B, and every day only put in a half a tank of gas, you can blame the car, you can blame the driver, you can blame the road, whatever you want to do. But ultimately, it's the fools who don't fill the tank are the ones who are really responsible. And that's Congress.
Dr. Warren, you've had lots of experience and with different federal agencies and different activities. When you're looking at what ACIMM can do, and you have 58 or so draft recommendations. Are there things that we should be prioritizing that we as a committee might be able to move more effectively than anybody else? And we tried to reference, like the American Academy of Pediatrics had some recommendations related to SIDS and SUID, and we didn't repeat those because we support all those things and they're moving that forward. But are there things that this committee should prioritize in our recommendations that might have the biggest impact?
Absolutely. And there are things that can be done with rulemaking authority within the department of HHS. So not all of the recommendations are going to require Congress. So obviously we can make recommendations that Congress should do X, Y, and Z, but there are things that can be done internal with rulemaking authority, even looking at how the grants are awarded, and how we require reporting requirements for Healthy Start. We had a good discussion on that, and making the tribal nations who are most impoverished and most need compete for resources when they don't have the infrastructure to compete for them. You don't need an act of Congress to fix those types of things, so I would just outline, what are the things that can be done through the secretary and this advisory committee's recommendations within the Department of Health and Human Services. But then there's other departments, there might be recommendations that would have an impact on them and make those recommendations. And then there are things that are going to require congressional approval. And then there's other things that are just going to require advocacy, like Medicaid expansion. That's up to the states. So I would just, characterize that, what can be done within the department, what can be done within the administration and the cabinet with other departments, what needs Congress and what needs to be just advocacy.
Great. Well, thank you very much and best wishes on your new opportunity. Is there, Joy, did you have a comment?
I think
sorry.
I channel both Magda and Janelle. I'm Joy Nehart. I'm a pediatrician. I've worked in Alaska, Southeast Alaska for 20 something years and just recently gave up an independent practice to join tribal health in Southeast Alaska. And I also work with Abra on the Maternal Child Death Review Committee for the state of Alaska. Two things stood out. The utter lack of bitterness that you didn't show while relating these grueling and horrible facts that all Americans should know. And then the second thing is that, your comment that IHS is not the enemy, the crippling underfunding is, so we need to bring these things with us in our recommendations. Thank you.
Yeah, thank you for those comments. Appreciate that.
I feel very educated.
Thank you. Thanks.
Go ahead.
This is by no means a final comment in any way, but a question really for Dr. Ward. I was struck by what you said about should the American Indian, Native American, Native Alaskan, should it be the 51st state? And what could that look like? And is there an opportunity to take the state legislature out of the equation? Is there an opportunity to take variable levels of racism and discrimination kind of state to state out of the equation? And what could that look like? When there's possibilities, probably, this is healthcare, right? We could do a layer of it without a state, right? We could do it for healthcare. We could do it for healthcare resource distribution. Can you kind of paint a picture for me of what that would look like with 600 tribes, right? What would that look like?
Yeah, so American Indians are very unique in United States because our tribes have a government-to-government relationship with the federal government. So it's not like other underserved minority populations because we have separate political entities. We're nations within the nation. So that nation-to-nation relationship could be part of an amendment to Title 19 of the Social Security Act. That we will now fund Medicaid eligible enrolled tribal members directly as opposed to going through the states. That could be done, absolutely. So that could be done by amendment to the Social Security Act. It could be done, with a new title potentially within Social Security Act. There'd be a whole host of options to do it. And I think one of the things that could be done is just the framework of constitutionality. It's very clear in the US Constitution, Article 1, Section 8 is the Commerce Clause. And the Commerce Clause states that Congress shall regulate commerce with the foreign nations and the Indian tribes. So we were put on par with foreign nations. So that's, recognition of tribal sovereignty. But at the same time, when we're paying for healthcare, that's commerce. And right now, who's regulating it? State legislatures. So that's actually unconstitutional, but within the federalism system where the states get a lot more authority, it's legal. It's actually legal, but it's not within the intent of the original writing of the Constitution. So I would frame it, this is unconstitutional the way it's being done. Let's respect the Constitution and its framers, and let's amend the Social Security Act in Title 19 and get the state legislatures out of the way of federal dollars to American Indians.
Thank you. One more comment then, may I?
Go ahead.
So yesterday we have new Congresswoman Mary Peltola. I'm going to, may I introduce you to her or have you already met her?
I'd be deeply honored to meet her. I've never met her. No.
I'd be deeply honored to make that connection, so I will.
Yeah. Thank you. Yeah, I'll be in National Indian Health Board Annual Conference is coming up in a couple weeks.
I'm dreaming of the collaboration you guys could do.
That'd be great.
Dr. Warren, really appreciate your presentation, and you gave a very concrete suggestion around Title V. And not only the option to change the legislation, which is not within our power, but you did talk about something that is within the power, and that's changing the guidance. And so wanted to make sure that the committee knew we redo that guidance every 3 years. We're in the process of redoing it now. So it's certainly something you could talk about in your recommendations, and there will be an RFI that will be put out, and we'll make sure the committee knows about that, because that would be a good opportunity. Similarly, you heard about Healthy Start earlier. A Healthy Start will recompete in 24. We've been doing a series of listening sessions with community partners broadly around how we get to equity and infant mortality. We're going to be doing 2 of those sessions in October and November with Healthy Start grantees. And there will also be a public RFI. So a number of opportunities to get broad input on things like data collection and the ways the program is structured, in addition to the recommendations you all might make.
Dr. Warren, thank you very, very much. This was very helpful. And I hope you stick around for just another 5 minutes to hear my charge to this committee for tomorrow's work. Could you hand this out to the committee members? So we didn't have a chance to kind of talk through what we're going to do tomorrow, but this is just going to the committee members because this is homework. You know, we have, and I think 58 recommendations. And so I'm suggesting that tonight you take a look at a certain segment of those recommendations, just to review them based on what you've heard over the last 2 days. And I've just arbitrarily divided them up to have you people take a look at it and to make sure that we're not missing something, you know, and how can they be strengthened? You know, what kind of timeline can we put on some of these things? What kind of partnerships need to be developed? What kind of evaluation, reportability, and accountability should be there? So I just want to have you review them one more time, you know, and we're not going to go through each one tomorrow. I want to make sure we're not going to miss anything. But I want you also to think about this, and this is where I'd be interested in Dr. Warren's response after we are adjourned. I would like to, given what we've heard, I would like to reframe our report as not recommendations, but either, and this is where we can use the term, are these demands or are these, I'm thinking, well, or is it to meet the obligations that the United States has, HHS must? You know, frame it in terms of not we recommend this to happen. It says these should be givens. So what are the givens that we need to see you step up to accept responsibility for? So I want to, as we look over all of those recommendations, think about them in terms of how do they fit with the legal obligation that the federal government has with American Indians, Alaska Natives? And how can they be reframed? I think they're still pretty much accurate. You're asking to do the same thing. In order to meet the obligations, you need to fund IHS. You need to look at different ways of looking at small number analysis. You need to, you know, this is the things that you need to do to meet your obligation. So I want you to be thinking about that. And my goal tomorrow is just to make sure we're not missing anything in terms of the recommendations. Are there things that we should prioritize? Are there things that are missing? And then how do we reframe those so that I'm hoping by the end of tomorrow, we can actually say, we're signing off on this and moving it forward. Because I really do want to, you know, get this out to the secretary before the election. Because I think once that happens, you know, the world is going to change a little bit.
May I ask a question?
Sure.
As the DFO and sort of charged with overseeing your sort of responsibility and role, one of the questions that was raised during an earlier presentation today was whether these are demands or whether these are recommendations that are being made. And I would just like to put out there that as an advisory committee to the secretary, you represent voices from a variety of areas of expertise, positions and views, regions of the country, professions. Not all of you are Native Americans. And so I would just ask each of you to think about when you're crafting that language to determine how it best presents itself as an advisory committee to the secretary on certain points and how it presents itself in referring back to Native Americans. So it's easy for a Native American to say, you made a guarantee to my family, therefore. It's a different thing for the advisory committee to use that language or other language to reflect that. So just be mindful of that in the way you couch your recommendations.
Yeah, thank you, Lee. And, you know, and we walk a fine line, and that's where I initially thought about demands, but as opposed to the other, not to meet the obligations that it appears to us, and with input from American Indian, Alaska Native community, you know, this is what we see needs to happen in order for this to go.
To that, excuse me, to that point, I believe it was Dr. Owens that had a slide that referenced the actual law that obligated the US government to provide optimal care for. Would it be possible if we could have that sent to the committee so we can look at that and reference? I can't remember who exactly it was that put that up there.
Yes, I think it was Dr. Owen, and that we should be able to get that to you, to all of the committee members. The slides that were given today, a lot of good recommendations were in those, and it'd be good to review those. Magda.
Towards that end, that was one of the heftiest briefing books that we've received. And I know that the briefing book is not a public document. Is that correct? I would like some clarification about that, because for the task for tomorrow, in the Broken Promises report, this history is cited and the law is there. So we can get it from Dr. Owen, but it is already in the briefing book. And so I don't know who read every 1,727 pages. I know I did, Janelle did, and a couple others, because we helped put it together. But I do think that it will be helpful to look at the broken, I'd like to ask Janelle for a consult here, but the Broken Promises report is essential reading before you look at our recommendations. Again, it's there. And the second, to Lee's point, look at our charter. Just as we consider the strategy of language, we have to be able to fulfill our obligations. And I just think I've had fantastic conversations with our newer members who are still like, you know, like they're not drowning, but there's a lot of snorkeling going on, right? So, and so I just think, and fabulous swimmers, and everybody is, but the notion that this is relatively new, a fresh look at the charter and at Broken Promises, and maybe a third thing of my rules of free that Janelle might recommend. But I just think that this briefing book knocks my socks off in terms of how it allows me to go back and learn in addition to the slides, whether it's Dr. Owen or Dr. Orney or others that were presented. So I just think it's more homework, but bring it back up and look again. Any thoughts on that, Janelle?
No, I would agree. In terms of the language, the Broken Promises Treaty, read the letter or the executive summary, right? Read that really well, and then skim the introduction. And because they ground it in the law, they ground it in that these were treaties that were made, all the wording we can just replicate in this. And I was trying to be very concise in what I recommended. So you can also look in June's briefing book, which you might have an email to and access to, but that has even more resources with other GAO reports, Government Accountability Office, and but all of those reports, a lot of them have that same language that we are not fulfilling the obligations to the first people of this nation.
And hearty thanks for a fabulous job putting together the briefing book. May it be used.
sorry, one more thing. So I am sending an email in just a few moments where I will have hopefully Dr. Warren's presentation attached so that we can review the slides. It will also have NIHB's slides and let's see, Socia Love Thurman's recommendations that she gave yesterday. So it will have a few recommendations that people have sent that they've presented to us that they're sending so we can look at them again. And then also Socia sent a link in case anyone wanted to experience the drama again of her dear friend who passed away, who was, after childbirth. So from that NBC report. So that will also be in the email. Lots of heavy stuff tonight.
And before I forget, Steve Calvin isn't here. So Kate, would you be able to just take a look at the workforce ones instead of the data one? I need somebody just to take a brief look to make sure that we're not missing something. All right. Any other questions or comments before you collapse at your chair? My hope is that we bring back, we start with the draft that we have of the recommendations that have been looked at and commented on for nearly 4 months. See what changes need to be made, see if they can be reframed, and then actually vote on the recommendations that we agree or would like to move them forward. There will be some need to do some text around that in terms of explanations and that kind of stuff. So that won't be finalized tomorrow, so we won't be able to see that. But the recommendations, I would like to see a final vote on those recommendations tomorrow. So that's why we were here. And that's why we had 3 days to hear the voice. And I didn't want to vote on any of these things until we really had at least 2 full days of hearing the stories and the perspectives and the thoughts of American Indian Alaska Natives. And we did that in an incredibly powerful way over these last 2 days. So really help it inform your thinking overnight and our discussion tomorrow. So with that, we are adjourned for today.